and for opening their doors when we reached out to them for support. Thank you.
Africa stands at a crossroads. Technology is transforming healthcare like never before. But will digital innovation bring healthcare closer to everyone or leave some even further behind? As part of the 25th anniversary of the College of Health Sciences and the 2025 annual research meeting of NMIMR, we are bringing you a live thought-provoking debate where two of the brightest teams face off. Experts from Team Legon versus experts from Team Kolebu.
Expert fierce arguments, fresh perspectives, and powerful insight that must reshape how we see the future of healthcare innovation in Africa. Trust me, this is one conversation you do not want to miss.
And the motion, digital health, will widen rather than bridge Africa's healthcare equity gap. And this is happening on the 27th of November 2025 at the Great Hall, University of Ghana, 1 p.m. sharp.
Be there, be inspired, because the future of African healthcare starts with the conversation we have today. See you at the Great Hall.
Dear team, what do you think about our upcoming debate?
All right, so we are excited about this debate. This forms part of the 25th anniversary celebration of the College of Health Sciences, and we are gearing up for this debate.
Team Kolebu is truly excited. We know we are going to win. We are surely going to prove that digital healthcare will widen the equity gap.
And even as we win this debate, it's not just a victory for us, but a wake-up call to Africa to start building real foundations for our healthcare.
Yes, it's going to be exciting, insightful, and I'm excited because the points we are going to turn out will shape how healthcare is delivered on our continent for many years to come.
Digital health will certainly widen the healthcare equity gap in Africa, and there are lots of insights to be revealed from this debate.
The debate comes off on Thursday, the 27th of November at 2 p.m. at the Great Hall of the University of Ghana campus, Legon. See you there.
Hi everyone. As part of the University of Ghana's College of Health Sciences 25th anniversary celebration, there's going to be a grand debate on the topic digital health will widen rather than bridge Africa's healthcare equity gap. And we are against the motion. As lead, my name is Dr. Lee. I'm the Deputy Director at the West African Genetic Medicine Center. I'm a molecular geneticist.
And my name is Dr. Justice Kumi, a supporting speaker from the Noguchi Memorial Institute for Medical Research, and I'm a toxicologist.
And I am Dr. Nana Amamukujima from the School of Pharmacy and Natural Product Research.
I am Dr. Constance Agbemoruchumafu from the Noguchi Memorial Institute for Medical Research. I'm a molecular biologist and I'm a supporting speaker.
And we are
Team Legon. This debate is happening at our Great Hall on the 27th of November 2025 at 2 p.m.
Come, let's have fun. Come and let's learn digital health from Ghana and Africa and beyond to all parts of the world. And we know that we are winning. Catch you there.
Come and be wild.
We are winning.
We are winning. We are winning.
I welcome you to the 10th annual research meeting of the Noguchi Memorial Institute for Medical Research, College of Health Sciences, University of Ghana. This year we have a lot for you, and the theme for our annual research meeting is Advancing Healthcare Through Impactful Research and Innovations. This ties in very well with what we are doing. Noguchi, we support health delivery not only in Ghana, but in the sub-region. We employ you to join us. We have innovative speakers who are going to speak about their innovative research, antimicrobial resistance. Why is that you go to hospital and they give you all the antibiotics, but you are not responding? Please come, get understanding. How do we prevent the spread of antimicrobial resistance? Please, there are so much information for you. Malaria, is it coming down? Is it going up? We are there. Come. Innovative solutions. drug discovery, diagnostics. So I'm employing you. Come join us 25th, 26th. It is not going to be science alone. We are going to have fun. We are inviting all school children. We are going to open the doors.
Good morning.
Come and look at all the machines we heard about. JHS.
Today is a bright and beautiful day, but your response doesn't reflect that at all. Good morning. Great, this is better. On behalf of the director of Noguchi Memorial Institute for Medical Research, I welcome you to this year's annual research meeting. And today, I'm delighted to serve as your co-MC for this year's research meeting. I'll be doing this with my colleague, Dr. Christopher Abana.
Well, like my co-MC said, my name is Dr. Chris Abana, and it's been a year of planning, trying to plan hard for this annual research meeting. Well, distinguished guests, esteemed scientists, colleagues and friends, on behalf of the Vice Chancellor of the Premier University, the University of Ghana, and the Director of the best Biomedical Research Institute, the Noguchi Memorial Institute for Medical Research, it's a joy to welcome you to our 10th annual research meeting, dubbed the ARM 2025. Are you not happy? Are you not excited?
We are.
Well, it's an honor to serve as one of the MCs for this scientific gathering where brilliant minds meet, ideas take shape, and innovations that transform healthcare are born. And I'm doing this with
I'm Federica Dedopati. I'm a research fellow here at the Department of Immunology. So before we proceed, I would like to share with you a few housekeeping rules. For your own safety, kindly take note of the nearest exits close to you, one located to my left and one to the back. And if you need to use the restrooms are located downstairs towards the end of the building. And we do have our ushers on standby to assist you. Now, this year's research meeting has a special meaning because not only is this our 10th annual research meeting, but it actually coincides with the climax of the celebration of the College of Health Sciences 25th anniversary. I thought you would give a round of applause for that. So this milestone actually reflects our shared commitment to improving health in our communities in Ghana and beyond. So we'll quickly proceed to begin the program, but we invite you all to connect with us on our social media pages, and we'll share with you the hashtags.
Well, today we stand united with an inspiring theme, advancing healthcare through impactful research and innovation. And as we begin today's session, I invite you to engage actively, open, question boldly, and connect meaningfully. Every conversation today has the potential to spark the next breakthrough. And on behalf of the organizing committee, I thank you all for being here, for your commitment to scientific excellence, and the impactful work you continue to do. Ladies and gentlemen, let's begin this year's conference with energy and shared vision for a better healthier future. All around the globe, we are streaming live on YouTube on the main University of Ghana channel, and you can follow us for live updates, highlights, and behind the scenes on LinkedIn at NMIMR ARM 2025, on Facebook at NMIMR ARM 2025, and Instagram at NMIMR official, and then X or Twitter at NMMR_UG. Frederica, what do you think?
Thank you, Christopher. So we'll quickly begin as I invite forward the co-chairs of the organizing committee to share with us a brief message on the vision guiding this year's meeting. Please, with a round of applause, let us welcome Professors Asamoah Kusi and Jejom D'Souza.
He doesn't want to go anywhere without me. So.
All right, we are co-chairs, so we should be here together. Well, we've been asked to give the unofficial welcome address. The official welcome will come from the director. So, distinguished guests, colleagues, partners, friends, you are welcome to the 2025th edition of the annual research meeting of the Noguchi Memorial Institute for Medical Research. This year's theme, Advancing Healthcare Through Impactful Research and Innovation, reflects the collective ambition to deepen scientific inquiry, strengthen the evidence that guides health policy and practice in Ghana and beyond. So our ARM continues to serve as a premier platform for scientific exchange, one that brings together seasoned researchers, early career scientists, students, collaborators, friends, partners, stakeholders from diverse disciplines. So it is a space where idea meets opportunity, where innovations are showcased, and where new collaboration are sparked. So over the next 4 days, participants can look forward to a rich and engaging program. The scientific sessions from today to tomorrow would highlight the research we're doing across the Institute, including infectious disease surveillance, genomics and molecular diagnostics, environmental and public health. I can't see. No, it's not the minister. Well, we'll keep going. We were expecting the minister to come in. See, he's coming. The minister is here. All right. Something? You want to say something?
No. Yeah. Just welcome in and continue. Just welcome in and then continue.
Hello, everyone. The Minister of Health is in our midst. Welcome, sir. All right. So, where was I? So, over the next 4 days, you can expect inciting sessions looking at environmental public health research, mental health, maternal newborns, and climate change. We have poster and oral presentations that will provide a platform for scientists to share their work, receive feedback, and build professional networks. Thursday is the climax of the 25th anniversary, and the second ARM 2025 keynote address would be held at the Great Hall of the university. We have put together discussions and keynote presentations that address priority health challenges and the evolving role of research institutions in national and global health security. You should also expect the debate on digital health and its impact on the access to healthcare in Ghana and Africa. Team Legon will be debating Team Kolebu, and it will be an exciting debate not to be missed. On Friday, we are opening our doors to the general public, especially students at all levels of our education system, to experience the work we do. And other schools of the College of Health Sciences would also be exhibiting. So as co-chairs for this year's annual research meeting, we are grateful to all who have played parts in this meeting. The planning committee has been working for the last 5-6 months to put together this event. Our reviewers, our sponsors, the dedicated staff, whose efforts have made this gathering possible. And most importantly, we appreciate the scientific community whose work forms the backbone for this event. So it is our hope that the ARM 2025 would inspire new ideas, strengthen collaborations, and reaffirm our shared commitment to scientific excellence, innovation, and impact. We encourage all the participants to engage fully, ask questions, forge partnerships, and explore opportunities for future research endeavors. So we wish you all a productive, stimulating, and memorable annual research meeting 2025. Thank you very much.
Thank you, co-chairs, for setting the stage for our research meeting. At this point, we'll take the welcome address, and this will be delivered by our very own director, Professor Dorothy Yeboah-Menu. She's a distinguished professor of medical microbiology, I know she doesn't like a very long profile, but I'll keep it very, very brief. I know most of you know her as the first female director, rightly so. But recently, her staff has conferred onto her a new title as the first ISO certified director of a biomedical center. Yes, director, thank you.
Thank you very much, Frederica, for your kind introduction. The Minister of Health, Honorable Kwamina Minta Akando, Provost of the College of Health Sciences, Professor Alfred Edwin Yelsen, Pro-Vice Chancellor, Academic and Student Affairs, Professor Gordon Awandari, the Japanese Ambassador to Ghana, His Excellency Hiroshi Yoshimoto, the WHO country representative, my sister, Dr. Fiona Braka, keynote speakers, Professor Abdullahi and Professor Beverly Edri, deans and faculty of the College of Health Sciences and other colleges represented, directors of administrative units of the University of Ghana, my past directors and my seniors of the famous Noguchi Memorial Institute for Medical Research, staff of the Noguchi Memorial Institute for Medical Research, and constituents of the College of Health Sciences, distinguished researchers, scientists, and participants of the Noguchi Annual Research Meeting, friends of the media, specially invited guests, ladies and gentlemen, a very good morning to you all. Oh, good morning to you all. It is with a great pleasure that I welcome you to the 10th Annual Research Meeting of the Noguchi Memorial Institute for Medical Research, College of Health Sciences, University of Ghana. As an institute, we remain steadfast in our three core mandates, which are conducting research into diseases of public health importance to Ghana and the sub-region, providing specialized diagnostics to support global health interventions, and building the capacity of the next generation of scientists across Ghana and our sub-region. Our enduring commitment to these pillars has positioned Noguchi Memorial Institute as a central player in strengthening health security and increasingly critical responsibility in today's rapidly evolving global landscape. This year's theme, Advancing Health Care Through Impactful Research and Innovation, is both timely and aspirational. It calls on us not only to generate new knowledge, but to ensure that this knowledge is translated into meaningful action. It urges us to focus on solutions like diagnostics, therapeutics, and policies that tangibly improve patient care and public health outcomes. Achieving this requires stronger and more deliberate partnership among researchers, practitioners, industry, and policy makers. It also requires systems that support innovation from discovery to scale. And I'm happy the minister is here because we have a lot to discuss. There are so many national policies that limit research. One of them is procurement law. In this regard, The Institute continues to play a critical national role, particularly through our collaborative research with national and international stakeholders, including your very own ministry, Ministry of Health and its agencies, the World Health Organization, Africa CDC, CDC Atlanta, and so forth. Work outputs from the Institute impact several global initiatives and policies. Examples are the Global Polio Eradication Program, where the Noguchi is the regional collaborative center, vaccination schedules, Global Neglected Tropical Disease Program, African Pathogen Genomic Initiative, just to mention a few. Provost, it may interest you to know that as of last week, more than 200 manuscripts from researchers of the Institute have been published in impactful journals, including New England Journal, Lancet journals this year alone. A remarkable testament to our knowledge production. Through our collaboration, we are also supporting projects focused on point-of-care diagnostics and local phytomedicines, embodying the practical innovation our theme champions. I'm happy to let you know that due to the quality of work produced at Noguchi, our scientists are celebrated not only in Ghana, but on several global platforms. Ladies and gentlemen, permit me to celebrate two of our own who this year have brightened the Black Star internationally. The first is Professor Daniel Boache. This year in January, he was recognized and received the Lifetime Achievement Award Kylen Prize for his distinguished work in ending the neglected tropical diseases. And in just this November, he was acknowledged as a distinguished international fellow of American Society for Tropical Medicine and Hygiene. I would like to celebrate our very own again, Professor George Ama, the vaccine hero. He was this year elected in April as a fellow of the African Academy of Sciences. And in September this year, he was again the recipient of the Rotavirus Champion Award in Cape Town. I'm happy to let you know that he was the only African recipient of this award. As a trailblazer in global health, I'm happy to let you know that this year marks 25th anniversary of the Noguchi Memorial Institute for Medical Research Institutional Review Board, and this is the first ethics board ever established in Ghana. Through our ethics board, we've been able to give birth to a lot of several ethics boards within the university and outside the university. This is a testament of our long-standing commitment to ethical, high-quality research. For our third mandate, that is building the next generation of scientists, Mr. Minister, Honorable, I'm happy to let you know that just 2 years ago, since 2023, Noguchi has trained more than 1,500 individuals from 48 of the 54 member countries of the AU. This includes PhDs, postdoctoral fellows, laboratory scientists, and many of this marks a major in our ability to holistically manage challenges through integrated multidisciplinary approaches. On our third mandate, Noguchi, Mr. Minister, as you know, continues to be a formidable player in responding to health emergencies both in Ghana and across Africa. And following our recent surveillance audit, I'm happy to let you know that we have maintained our ISO accreditation, reaffirming the global quality, accuracy, and reliability of our diagnostic service. Additionally, new process expanded scope for accreditation is on course. The strength of our research ecosystem is clearly reflected in this meeting. We received over 300 abstract submissions, of which 310 were accepted for presentations. We will have 37 oral presentations and 273 posters. The breadth of work spans from infectious and non-infectious diseases and extends into maternal and neonatal health, mental health, climate change, and health system strengthening. I'm happy that we did not receive abstracts from staff of this institute, but across the country from all research institutions, notably the CSIR, School of Public Health, University of Ghana Medical School, School of Nursing, School of Pharmacy, Kwame Nkrumah University of Science and Technology, UHAS, and so forth. And alongside esteemed partners across the continents from countries like Nigeria, Cote d'Ivoire, Malawi, Uganda, and Morocco. This is a testament of our rich collaboration and our rich presence across the globe. As we celebrate this milestone, I want to extend my deepest gratitude to the committee that chaired by Professor D'Souza and Professor Asamoah-Kusi, who did this very good work and organized the whole meeting. I am also particularly happy to see my past directors, Professor Nyako and Professor Oforiaje here. They deserve a round of applause because we are building on what they did. And I cannot end by thanking the Japan Embassy, JICA, and the Japanese government for their continuous support to the Institute and all our funders. I'd like to thank all of you for being here, and I'm confident that this week will be a very good week for exchange, scientific exchange. On that note, I humbly welcome you to the very Noguchi Memorial Institute for Medical Research. Thank you very much.
Thank you, Director, for welcoming us. At this point, I would like to acknowledge some dignitaries and invited guests amongst us. We do have our very own Pro-VC for academics, Professor Gordon Awandari, who is celebrating his birthday today. We are honored to have you here sharing your morning with us. We also have in our midst Brigadier General Seth Ato, Director General of the Ghana Armed Forces Medical Directorate with us. So thank you for honoring our invitation. We also have Dr. Derek Akpalu, CEO of Revna Biosciences. If you are here, please give us a wave. He's not here. Oh, he's there. Thank you so much. And as we go along, I will be introducing or acknowledging the dignitaries we have. At this point, I would invite forward Mr. Prince Atudonko to come and introduce our special guest for today. Thank you. With a round of applause, let us welcome him.
Standing on already established protocol, ladies and gentlemen, good morning. It's an honor than me to introduce to you the chairperson for this year's annual research meeting. He is a renowned physician, a public health expert, an academic leader whose impact on health strengthening, research and policy development extends across Ghana and beyond. With over 2 decades of experience in clinical practice, public health research, and academic mentorship, he has contributed significantly to national and international health initiatives. He has led major studies, including Ghana's component of the WHO World Health Survey Plus, and has served as a key member of the WHO study on global aging and adult health. His expertise spans health policy, aging, chronic diseases, health financing, and community health systems. He is also a fellow of both the West Africa College of Physicians and the Ghana College of Physicians and Surgeons, and has served as a consultant to the global bodies such as WHO, the World Bank, UNICEF, and Global Fund. His leadership continues to shape health innovations, evidence-based policy, and capacity building in our health sector. He was the former dean of the University of Ghana Medical School, and he is currently the provost of the College of Health Sciences, University of Ghana. Ladies and gentlemen, with a round of applause, shall we welcome Professor Alfred Edwin Yossi.
The Honorable Minister of Health, we are very excited to have you here this morning. The Pro-Vice Chancellor, Academic and Student Affairs, our birthday boy, you are most welcome, sir. The country representative, WHO, we are very delighted to have you as well. The Japanese ambassador to Ghana, deans and directors of the College of Health Sciences and directors of other units and offices of the university, our former university officials and directors of Noguchi, and our very distinguished guests, esteemed colleagues, partners, and friends of the Noguchi Memorial Institute for Medical Research. It is with great pride and honor I always find it extremely delightful to be in Noguchi as one of the constituent units of the College of Health Sciences. If you have children who are doing very well, you must be proud as a parent, and we are a very proud parent as a college. Each year, this gathering reminds us of the power of research to connect people, inspire ideas, and translate knowledge and innovation that improves lives. It has truly become a defining platform where science meets purpose and collaboration derives impact. The theme for this year's research meeting, as we have in this morning, is Advancing Health through Impactful Research and Innovation, which beautifully captures the essence of Noguchi's work. That is science with purpose, innovation with relevance, and research that leads to meaningful solutions for our citizens. It reminds us that true progress in healthcare comes when ideas are transformed into actions that serve our communities, strengthen our health systems, and guide national and regional policy. This meeting, again, is particularly special as it coincides with the Silver Jubilee of the College of Health Sciences, which has provided 25 years of leadership in health education, research, and service. Over the period, the college has nurtured vibrant communities of scholars, scientists, clinicians, researchers who continue to push the boundaries of knowledge and innovation beyond the shores of Ghana. Within the ecosystem, the Noguchi Memorial Institute for Medical Research stands as a shining example of excellence. Its remarkable achievement in infectious disease surveillance, biomedical research, diagnostics, and capacity building have made it not only a national but also a regional and global reference point for scientific leadership, laboratory expertise, and commitment to national and international collaborations, which continues to enhance the college's reputation and impact in health science education and research. We are mightily proud of this, and let's give a round of applause to Noguchi. As provost, I immensely appreciate the Institute's accomplishment and the dedicated staff and faculty whose work continue to elevate the standing of the College of Health Sciences. And as we celebrate 25 years of progress with our Silver Jubilee, we are also called to look forward, to envision a future where our research is even more impactful, where our innovations help many more people, and where the next generation of scientists are better equipped to tackle the health challenges of our time. On behalf of the Vice Chancellor, the University of Ghana, and the College of Health Sciences, I extend my heartfelt appreciation to the Director and staff of the Institute for their outstanding contribution to the university's mission and that of the college in terms of research excellence and innovation. To our partners and collaborators, many of whom are here with us celebrating today, both locally and internationally, we thank you for your continued support and steadfast support and commitment to all that Noguchi does in terms of health research and innovation. Honorable Minister, distinguished ladies and gentlemen, I welcome you all to the annual research meeting and to the college's 25th anniversary celebration, which is spanning the whole week and which I must declare publicly has been ably and magnificently supported by Noguchi. Again, let's give a hand of applause to Noguchi. May your deliberation inspire new ideas, forge strong partnerships, and contribute meaningfully to the advancement of healthcare in Ghana and beyond. Thank you very much, ladies and gentlemen.
Thank you so much to our father. We are grateful. Before we continue, I'd like to car number GC 12222. Please attend to your car now. It's important. Thank you. We would like to acknowledge the presence of all heads of department. Please let's see your hands. All heads of department of Noguchi Memorial Institute for Medical Research. Thank you so much for your hard work. We are grateful for all your contribution. Thank you so much. Mr. Linus Anyakpo, MD for MES Equipment. Let's see you if you are here. Mr. Linus Anyakpo. Thank you so much for coming. Pascaline Songsori, representative for Public Affairs Directorate. Please, if you are here, let's see you. Thank you for coming. Dr. Mena Charles, Influenza Program Director of West African Regional Hub of CDC. Please, let's see you if you are here. Dr. Mena, thank you so much for your support. We are grateful. And then right by here, we have Dr. Tala Nsusu of the West Africa Regional Hub, who has been a long-standing member of the Noguchi Memorial Institute for Medical Research. Please, let's give him a round of applause. Well, we'd like to invite the Japanese ambassador to Ghana, His Excellency Hiroshi Yoshimoto, to give us a short remark. Thank you.
Honorable Kwabena Minter Akando, Minister of Health, Professor Dorothy Yeboah Manu, Director for Noguchi Memorial Institute for Medical Research, Professor Alfred Edwin Yaoson, Provost, College of Health Sciences, and Pro Vice Chancellor for Academic and Student Affairs, distinguished researchers and guest speakers, distinguished all the staff of Noguchi Memorial Institute for Medical Research, and friends of media, and ladies and gentlemen, good morning. I'm Japanese Ambassador Hiroshi Yoshimoto. It is a great honor for me to join you this morning for the opening ceremony of the annual research meeting of the Noguchi Memorial Institute for Medical Research. I'm also very grateful to the Institute and the College of Health Sciences for inviting me as a special guest at this important meeting as part of your 25th anniversary celebration. This year's theme, Advancing Healthcare Through Impactful Research and Innovation, captures clearly what the Noguchi Institute has stood for over decades. It also reflects the shared vision that Japan, through JICA and the Embassy, and this institute have cultivated through a partnership grounded in science and humanity. Our cooperation has consistently aimed at one thing, that is advancing healthcare for the people of Ghana and Africa. Ladies and gentlemen, the history of the Noguchi Institute is inseparable from the history of cooperation between Japan and Ghana. This history, which has been recounted many times and is well known to many of you here, began nearly a century ago in 1927 when Dr. Hideo Noguchi arrived on the shores of the then Gold Coast. Although his time in Ghana was brief, but the impact of his scientific missions has left an enduring legacy that helped spark friendship between Japan and Ghana. In 2027, we will commemorate the centenary anniversary of Dr. Noguchi's visit to Ghana, and I believe Dr. Noguchi will be very proud of what this reputable institution named after him has achieved and continue to achieve in global health research. Today, the Noguchi Memorial Institute stands as one of the most respected biomedical research institutions in the African continent and in the world. Your leadership during global health emergencies have become a source of pride not only for Ghana, but also for Japan. Japan is proud to have contributed to this journey through technical cooperation, capacity building, infrastructure development, and exchange programs between Japanese and Ghanaian scientists. Ladies and gentlemen, as we approach the centenary of Dr. Hideo Noguchi's visit, Japan is committed to building our long-standing partnership with this institute. It is said that every vision needs opportunity, and every opportunity needs partnership. We will continue to work side by side with the institute to support your vision and research priorities in order to strengthen your position as a leading institution in impactful research and innovation. I wish all speakers and participants at today's meeting the very best in your presentations and discussions. I encourage you to explore ways of collaborating with your counterparts in Japan. Japanese researchers and institutions are ready to partner with you in advancing research and strengthening our collaborative contribution to global health. On behalf of the government of Japan and people of Japan, I congratulate the Noguchi Memorial Institute for Medical Research and the College of Health Sciences for your 25th anniversary years of excellence and commitment to impactful research and innovation. We are proud of what we have achieved today together and look forward to strengthening our collaboration further. Thank you very much, may I say.
Arigatou gozaimasu. Kite kurete arigatou gozaimasu. Well, we've gotten to a very important point of this ceremony, and I would like to introduce the special guest of honor for this program in the person of Honorable Kwabena Minta Akando. Kwabena Minta Akando is a dedicated public servant, experienced legislator, and accomplished professional with a strong background in mathematics, law, and health systems management. As a member of parliament for the Dwabosu constituency since 2013, he has demonstrated exemplary leadership and advocacy for improved health policies and social development in Ghana. His extensive public service experience includes serving as the Deputy Minister for Lands and Natural Resources and the ranking member for the Health Committee of Parliament from 2019 to 2024. With an LLB and an LLM coupled with specialized training in health systems, management and social security, he is committed to advancing equitable health financing and public development. His passion for public service is complemented by his entrepreneurial spirit. He is one of Ghana's leading rice farmers, contributing to the nation's agricultural development. He is currently the Minister for Health. Ladies and gentlemen, please help me welcome Honorable Kwabena Minta Akando to give us.
Thank you very much, MC. On the table, I hear the greatest of all is the rice farmer. So, Professor Yosin, the chair, the Pro Vice Chancellor who is celebrating his birthday today, the Provost of the College of Health Sciences, Director of the Noguchi Memorial Institute for Medical Research, WHO Country Representative, my sister Fiona, Japanese Ambassador to Ghana, and I hear my brother Soji is around. Dr. Soji, you're welcome. The keynote speakers, Professor Beverly Edry, researchers, scientists, collaborators from Ghana and abroad, friends from the media, distinguished guests, ladies and gentlemen. It is a profound honor to join you at this year's 10th Noguchi Annual Research Meeting, held as part of the 25th anniversary celebration of the College of Health Sciences. This gathering offers us an opportunity not only to reflect on scientific achievements, but also to reaffirm the indispensable role of research in shaping the future of health in Ghana. As we commemorate the legacy of Dr. Noguchi, whose dedication and sacrifice remain a guiding light. We also celebrate the remarkable evolution of the institute that bears his name, which has matured into a center of excellence for biomedical research, public health innovation, and global scientific collaboration. For more than 40 years, the Noguchi Memorial Institute for Medical Research has demonstrated how science can transform national health systems. The Institute's work has consistently informed policy, strengthened disease surveillance, and expanded our capacity to protect communities from both known and emerging threats. Its partnership with the Ministry of Health, the Ghana Health Service, academia, and global institutions, has positioned it as an invaluable pillar of Ghana's health security architecture. It is worth recalling, in particular, the Institute's contribution during the COVID-19 outbreak, a moment that tested the preparedness and resilience of health systems worldwide. The Noguchi Memorial Institute rapidly mobilized its diagnostics and sequencing capabilities, providing timely testing, generating critical genomic data, and supporting laboratories across Ghana to scale up their response. This integrated effort not only advanced national containment strategies, but also enabled Ghana to contribute meaningfully to global surveillance networks. The Institute leadership during that period reinforced the centrality of research in national decision-making and demonstrated the value of scientific readiness in times of crisis. Beyond COVID-19, Noguchi Memorial Institute has continued to provide insights that enhance national preparedness. Its genomic and epidemiological surveillance has supported early detection of mpox, strengthened monitoring of influenza and other respiratory viruses through platforms such as GISRS and COVINET, and contributed vital data to the national and international pathogen surveillance network. The Institute's confirmation of zoonotic diseases, such as the detection of dengue virus and H9N2 avian influenza in Ghana, has guided targeted public health actions and deepened our understanding of genetic and vector-borne disease risk. Together, these contributions demonstrate how research, when harnessed effectively, becomes a powerful instrument of national resilience. As Ghana advances an ambitious agenda for health sector transformation, our partnership with the scientific community becomes even more critical. We are determined to build a health system that is equitable, efficient, and firmly grounded in evidence. To achieve this, allow me to emphasize 4 priority areas where government seeks to deepen its collaboration with Noguchi Memorial Institute and the broader research ecosystem. Government remains committed to expanding and modernizing the country's research and laboratory infrastructure by investing in advanced sequencing technologies, digital epidemiology platforms, and integrated surveillance systems. We aim to enhance early detection capabilities and strengthen national response to infectious, non-communicable, and climate-sensitive diseases. This investment will benefit greatly from your expertise in designing, testing, and operationalizing innovative scientific tools. Ladies and gentlemen, our vision for universal health coverage relies on timely, reliable, and actionable data. To this end, the Ministry of Health is working to ensure that insight generated from the Noguchi Memorial Institute research, particularly surveillance and diagnostic outputs, are integrated into real-time policy dashboards and district-level health decision-making systems. This will enable public health interventions that are faster, more targeted, and better aligned with the realities of disease patterns and community vulnerabilities. Sustaining Ghana's scientific leadership requires a deliberate investment in people. The ministry is exploring a national fellowship program in collaboration with JICA, WHO, and other partners to train young researchers in vaccinology, genomics, biostatistics, biomedical engineering, and other emerging fields. We look to Noguchi Memorial Institute's experience and leadership to guide the development of this program and to mentor the next generation of world-class Ghanaian scientists. In this regard, in line with government priorities, we would also facilitate collaborations with our in-country research centers to build capacity and boost local pharmaceutical and traditional medicine production. Ghana's growing reputation in global research network offers a unique opportunity to position the country as West Africa's Center for Health Innovation. Noguchi Memorial Institute's strong engagement with international partners already provides a foundation for advanced research in pathogen genomics, vaccine development, and emerging disease surveillance. The ministry will continue supporting collaborations that elevate Noguchi Memorial Institute's role as a regional hub and encourage the cross-pollination of ideas, skills, and technologies. Ladies and gentlemen, as we deliberate over the coming days, let us renew our commitment to scientific excellence and collaborative problem solving. The breakthrough achieved in your laboratories ripples across the nation, influencing clinical practices, informing public health policy, and shaping the well-being of millions. Your work affirms the wisdom of Dr. Noguchi's life. The belief that science anchored in curiosity and compassion can change the course of human health. On behalf of the government of Ghana, I extend heartfelt appreciation to the leadership and staff of Noguchi Memorial Institute, our academic partners, and our international collaborators for your dedication and service. May this year's meeting inspire deeper partnerships, bold discoveries, and innovative solutions as we work together towards a healthier, more resilient Ghana. I thank you so very much for the opportunity. The very good news that is clearly missing in my speech is the fact that government wants to procure DNA testing machine for Noguchi. And we have completed the procurement processes. We are procuring that together with some catheterization centers. And I was discussing with the director that I believe this will go a long way to help the activities of Noguchi. And if maybe I'm not mistaken, it will also serve as internally generated, avenue to generate some kind of resources. And that decision was taken by His Excellency the President. Immediately, we sent samples of the helicopter crash victims to South Africa for the DNA testing. So he directed that that should not be repeated. And therefore, he has clearly directed that we purchase DNA testing machine. I thank you so very much for the opportunity, and I would have wished to be with you throughout. Today, I'm beginning the debate of the policy underpinnings of the 2026 budget in Parliament, but I deem this program very, very important, so I decided to pass through myself before I go to Parliament to continue my program for the day. I'm most grateful.
Thank you so much, Honorable Minister. We are grateful for the machine, the DNA testing machine. We're here to see it. Thank you so much. We would like to acknowledge the presence of the following people: Deputy Directors of WAGBI, Professor Lydia Mosi. If you are here, please, let's see you. Professor Peter Kwashi. Please, if you're in the midst, let's see you. Thank you. Professor Hiroku Yamamoto, Director of AIDS Research Center, National Institute of Infectious Disease of Japan. Thank you for coming, flying all the way from Japan. We are grateful. Professor Kwesi Tope, the Dean of School of Public Health, we are grateful for your presence. Professor Mark Sando Yidana, Provost of College of Basic and Applied Sciences, please, if you are here, let's see you. Professor Sandra Hewlett, Dental School. Dental School, yeah, thank you. Prof. Irene Krechi, if you are here, please, let's see you, Prof. Irene Krechi. Okay. We would like to take more remarks from some of our All right, thank you. So the minister is gone, so all attention is shifted to the minister. So the cameras are no more. Then we can close the program then and go. Okay, thank you, Japanese ambassador, for staying. We are grateful. At least we didn't follow the minister. We are grateful. Let's give him a round of applause. We would like to take short remarks from the WHO country representative, Dr. Fiona Braka. Please, you're welcome.
So I want to respectfully acknowledge the Honorable Minister who was with us, the Chairperson and Provost of the College of Health Sciences, our Director for the Noguchi Memorial Institute for Medical Research, Your Excellency the Ambassador for Japan to Ghana, development partners, researchers, scientists, ladies and gentlemen, good morning. On behalf of the World Health Organization, it's my pleasure to join you this morning at the 10th Annual Research Meeting of the Noguchi Memorial Institute for Medical Research, which this year coincides with the Silver Jubilee of the College of Health Sciences, University of Ghana. I congratulate University of Ghana, the College of Health Sciences, and especially the Noguchi Memorial Institute for Medical Research on this remarkable milestone. Since its establishment in 1979, the Noguchi Memorial Institute for Medical Research has been Ghana's premier biomedical research institute and one of Africa's most respected centers of science. For more than 4 decades, the Institute has provided critical evidence on malaria, on tuberculosis, HIV/AIDS, influenza, rotavirus, neglected tropical diseases, and more recently, COVID-19. We've heard from the minister the great work that was done during the COVID-19 pandemic, where the Institute's laboratories were central to Ghana's national response, testing samples, confirming cases, and conducting genomic sequencing of SARS-CoV-2 to track variants. The Noguchi Memorial Institute for Medical Research and the World Health Organization have worked together for decades. The Institute serves as one of WHO's designated national influenza centers, contributing to the global influenza surveillance and response system, which is the backbone for annual influenza vaccine updates worldwide. We are collaborating in different other initiatives. We supported and worked together on the malaria vaccine trials, including the landmark RTSS studies, which informed WHO's 2021 recommendations and Ghana's pioneering introduction of the malaria vaccine into the routine immunization program. We are collaborating on strengthening polio surveillance, and the Institute's data is feeding into WHO's global polio eradication program. We have worked together to provide laboratory confirmation during meningitis and cholera outbreaks in Ghana, which enabled rapid public health action. And our collaboration is advancing antimicrobial resistance monitoring in line with Ghana's National Action Plan on Antimicrobial Resistance and WHO's Global Antimicrobial Resistance Surveillance System. WHO has invested in capacity development through training in molecular diagnostics, biosafety, and genomic sequencing, equipping scientists in Ghana and across West Africa with the skills needed for global health security. These achievements demonstrate how Ghana's research excellence resonates far beyond its borders, shaping global health policy and practice. Beyond our collaboration with the Institute, WHO has been privileged to support Ghana in strengthening its national research and data systems, which are essential for advancing healthcare through evidence and innovation. So the recently released quality of care analysis, the harmonized health facility assessments, the 2022 Ghana Demographic and Health Survey, the STEP survey on non-communicable disease risk factors are all providing essential information on tracking progress and guiding programmatic interventions. Together, these initiatives demonstrate how WHO works hand in hand with the Ministry of Health and the Ghana Health Service and partners to ensure that policy and planning are grounded on robust, nationally owned evidence. So we remain fully committed to working with the Noguchi Memorial Institute for Medical Research, the University of Ghana, and national health authorities to continue to strengthen research capacity and lab systems to support knowledge translation, ensuring that scientific evidence informs national health policy and planning. We are committed to facilitating international collaboration, connecting Ghanaian scientists to WHO's global networks, and to expanding partnerships in genomic research, antimicrobial resistance, surveillance, and vaccine development, while continuing to support national surveys and health data systems. Ladies and gentlemen, the challenges of tomorrow, from pandemics to non-communicable diseases, from climate-sensitive health threats to antimicrobial resistance, demand stronger science, deeper collaboration, and bold innovation. So the theme for this year's meeting, Advancing Healthcare Through Impactful Research and Innovation, captures exactly what is needed for the future. On behalf of the World Health Organization, I congratulate the Noguchi Memorial Institute for Medical Research and the College of Health Sciences once again on this milestone, and I reaffirm WHO's enduring partnership in advancing impactful research and innovation for Ghana, for Africa, and the world. Thank you very much.
Thank you so much, Dr. Braka. We are grateful. Before we continue, I would like to acknowledge the following people too. Mrs. Lydia Anowanya Kudankwa, Academic Affairs Directorate. Thank you for coming. Dr. Till of GIZ, Head of Programs. All right, thank you. Professor Yvonne Day Adumaku, Dean, UG Medical School. Thank you. Professor Florence Knapp, Dean of School of Nursing. School of Nursing. Okay. Dr. Felix Soval, Lab Focal Person for National TB Control Program. If you are here, let's see your hand. Okay. Ao Nana Oye Ekufo, Research Administrator of College of Health Sciences. Thank you. Dr. Paul Watson, National Malaria Elimination Program. Thank you. Professor Kennedy Adu, formerly of Head of Department of Bacteriology. Thank you for coming. All right. We'll now take short remarks from the CEO of the National Vaccine Institute, Dr. Soji Tete. Please, you're welcome.
Thank you very much for having me here, Mr. Chairman, Prof. Yorson, Your Excellency, a Director of Noguchi. I see Dr. Holger, Prof. Warandari, Prof. Furieje, and so many distinguished people in the audience. I'm very happy to be here. I take due notice of the fact that the comments are supposed to be short, so I will keep it that way. I'm coming from the National Vaccine Institute, and as many of you know, our mandate is to coordinate and supervise all research and development and manufacturing activities in relation to vaccines in the country. So to that extent, we've been enjoying a lot of good partnership with Noguchi. And as you know, Noguchi's reputation precedes the institution. You are so accomplished that it has informed the approach that we've decided to take at the National Vaccine Institute, which is not to replicate things that are already being done excellently, whether by WACBIP or by Noguchi or by whichever research institution is in the country. So we'll position ourselves to work in support, and that is really how we've been working up until date. So when you talk about board committees on research and development, Noguchi has been a staunch member and helping us to take things forward. Recently, through some funding from GIZ and also from the World Bank, we've managed to equip some labs and set up a protein lab at Noguchi. We are also on the verge of acquiring some mRNA equipment and set up some facilities here. The caveat, though, is that these equipment and these labs are not being set up exclusively for Noguchi, although they are hosted by Noguchi. And we'll structure the arrangement in such a way that all research scientists in the country can access these facilities. But on the auspicious occasion of your 25th anniversary, I'd like to commend you on the theme that you've chosen, where you are linking impactful research and innovation to healthcare. And for some of us who deal with actors in the policy space, this is particularly important. In my space, it's interesting the health minister has left. But in my daily dialogues with him, as I talk about the need to support the ecosystem, to support vaccine manufacturing in the country, I talk about human capacity development, I talk about building regulatory capacity, I talk about R&D, then I talk about the core manufacturing itself. And often, at the end of that conversation, the health minister would ask, so when are we going to manufacture the vaccines? So it is very critical that in all of these activities, we are able to demonstrate to policymakers and to the people of country the impact on healthcare, which is why I think that you've got your finger right on it. I'll end by talking about two things that we are working on at the moment. We are structuring an agreement with the Africa Pharmaceutical Technology Foundation, and through that, become members of the WHO mRNA Hub. This way, there will be opportunities to develop more research scientists in innovative technologies. There's also an ongoing conversation with Afrigen. Afrigen has a whole network of scientists working on mRNA technology, and the idea is that we'll be able to connect Ghanaian scientists to that network. Yesterday, I also concluded some discussions with the Africa Clinical Trials Research Network. The leadership based in Zimbabwe and is being funded by the Gates Foundation, and there are great opportunities again to connect all Ghanaian, well, not all, Ghanaian scientists working in the area to that network to build capacity, share learning, and to make sure that we are positioned to be able to manufacture the vaccines that we say we are going to work on. The last bit is to also celebrate you on the support that you've given to us together with other scientists in the development of the legislative instrument. NVI is like a new baby. We are 2.5 years old. We have an act, we do not have a legislative instrument, and we've enjoyed good partnership in the research community and others in the ecosystem in the development of the legislative instrument that is going to be used to operationalize the act. And very soon you would see that those who are connected to NVI in one way or the other are enjoying tangible support. And when those times begin to roll out, as you've seen with Noguchi, we are sure that we can support all scientists and manufacturers in the private sector so that, God willing, we can develop the vaccines that we are looking for. Thank you very much for having me.
Thank you so much, Dr. Soji Tete. We are grateful. Well, we've gotten to a very important part of the program as well, and it's time for the keynote address. The keynote address will be delivered by Professor Beverly Ejil, who is an associate professor in the bacteriology department at the ISO certified Noguchi Memorial Institute for Medical Research, University of Ghana. Yes, we are ISO certified. She holds a PhD in molecular bacteriology and infection from the University of Copenhagen, Denmark, funded by the Danish International Development Agency through the Antibiotic Drug Use Monitoring and Evaluation of Resistance Project. She also completed postdoctoral training at the University of Cambridge, United Kingdom, supported by the Alborada Trust under the Cambridge Africa Partnership for Research Excellence. Prof. Ejil's research focuses on surveillance of antimicrobial resistant bacterial species from humans, animals, food, water, and the environment. She employs both phenotypic and molecular tools, including whole genome sequencing, to investigate AMR trends and dynamics. Her work is dedicated to tackling AMR through research, surveillance, and capacity building initiatives across the African continent. She currently leads a multidisciplinary team with expertise in microbiology, sequencing, bioinformatics, and AMR data management. Over the years, she has directly trained and supervised several young scientists, both undergraduate and postgraduate, and has organized AMR-focused workshops involving participants from several African countries. Prof. Ejil is the author of numerous peer-reviewed publications and is actively involved in key national and international AMR networks. These include the SEC Africa Consortium, Wellcome Trust Cedric Genomics for AMR Surveillance Working Group, the Africa CDC Pathogen Genomics Initiative AMR Focus Group, Tanzania Fleming Fellowship Scheme, PulseNet Africa, and Ghana's National Antimicrobial Resistance Coordinating Group. Ladies and gentlemen, please help me welcome Professor Beverly Ejil.
Thank you so much, Chris, for the kind introduction. I'm very grateful to the organizing committee for the invitation to give this talk. And Prof. Chair, Professor Alfred Yeltsin, with your kind permission, I wish to ride on the earlier protocols established. Distinguished ladies and gentlemen, good morning. So, can I have the mic here, the one that you hold? So it may interest you to know that the next antibiotic you take or prescribe may not work. This is not to cause fear and panic, but that's the reality on the ground. And it may not work because of antimicrobial resistance, AMR. And AMR is simply when the bacterial species change, and therefore the commonly used antimicrobials are not working. So the bacterial species become stronger. As a result, they resist treatment. That is the antimicrobials. So in this presentation, or in this talk, I'll provide you information on the menace of antimicrobial resistance in Africa, and then we'll also look at some key drivers of resistance. We'll also look at some action plans as well as policies that we have in place to tackle AMR. And then we'll zoom into some of the activities that we are doing here to tackle antimicrobial resistance. And then we will share some ideas on how to bridge the policy, practice, and prevention. And then we'll end on a summary and reflection. So, this is baby Uzra. struggling for her life in a hospital in Ethiopia with sepsis. The clinicians or doctors have done everything they could do. They've tried all the drugs. Second-line drug did not work. The last option, that is meropenem, was so expensive that the mom could not purchase. And 5 days later, baby Yusra died. This is the reality and danger seen in several hospitals on the continent. And therefore, one will say that AMR is not just an economic issue, but every delay in intervening represents lost lives. And this is going on in several hospitals on the continent. Now, this is another case of a hospital in Ghana. Blood sample was taken, flucloxacillin and cefotaxime were administered. The test results came out with ESBL producing Klebsiella. Unfortunately, the baby passed on. Now, ESBL is an acronym for extended spectrum beta-lactamase, and it's an enzyme that hydrolyzes the beta-lactam ring in our beta-lactams. So when you have an organism producing ESBL, it means that your antibiotic will not work because they will destroy the antibiotics. And we have a lot of organisms producing ESBLs in our settings. So your guess is as good as mine. Many infections will become untreatable. Now, sometimes when we talk about these things, we feel that they are far away from us, but they are very close. On your screen, you find samples or isolates plated from patients, in this case, surgical site infection. On the first plate, plate A, that is Acinetobacter baumannii, resistant to everything that was tested, including meropenem, the last treatment option. On plate B, you have ESBL producing Klebsiella pneumoniae, resistant to 11 antimicrobials, including meropenem. Plate C, you have Pseudomonas aeruginosa, resistant to everything that was tested, including meropenem. Now, this shows results that we received just this week. As you can see, the organism Klebsiella pneumoniae recovered from a tracheal aspirate, resistant to everything that was tested. All beta-lactams, fluoroquinolones, and others. And this is the situation that we have in our hospitals. Now, we are seeing all these things because we are using the antimicrobials anyhow. In this part of our world, anybody can walk into the pharmacy or a chemist's shop to just purchase the antimicrobials. And during the pandemic, as we are all aware, a lot of people were using these antimicrobials. And we are seeing these resistant bugs everywhere. Now, based on several reports, we note that AMR is a major problem across Africa, leading to treatment failures, risky and unsafe surgical procedures, long periods of hospitalization, with huge economic costs. Now, we are also finding resistance to first-line antimicrobials, and second-line antimicrobials are also limited. And we are seeing high mortality and morbidity, especially in newborns, the aged, and the elderly. Now, the key drivers of AMR in Africa include high burden of infectious diseases. And therefore, we use these antimicrobials every now and then because of the high burden. And as a result, we are misusing these antimicrobials, not just in humans, but animals. Now, we also have unregulated antimicrobial use. We also have poor IPCs in our hospitals, leading to hospital-acquired infections and outbreaks. And it will interest you to note that only 1.3% of laboratories in Africa conduct bacteriology testing. So if we have these high levels of resistance and we are not testing, how can we fight what we don't know? So it means we are flying blindly. And to top it up, we have very few genomic surveillance activities going on to have the granular data that we need to tackle AMR. Now, there are common pathogens in the category that we are looking at. When it comes to Klebsiella pneumoniae, we find them in pneumonia and bloodstream infections, and often these organisms are ESBL producing. We find E. coli in UTI and sepsis, and they are often fluoroquinolone or beta-lactam resistant. We also find Salmonella and the others. Largely, most of the organisms that we see on the continent are resistant to a wide range of antimicrobials. Now, several outbreaks have also been reported on the continent. A case was reported in South Africa of carbapenem-resistant Klebsiella pneumoniae in a NICU department. And unfortunately, 10 babies lost their lives. And then there are other cases from Nigeria and Kenya and other African hospitals. So we observe that AMR is high or widespread in several African countries. Now, we have several funders working together with countries and organizations and nations to tackle this AMR. And one of them is the Fleming Fund. Over the years, Fleming Fund has built capacity, infrastructure for laboratory testing. They've also strengthened stewardship programs, as well as awareness creation. They've also built capacity to perform, genomic capacity to perform AMR surveillance and training. These organizations have all been involved in the development of national action plans and multi-sectorial AMR surveillance. So, over 90% of African countries have national action plan and policies to tackle AMR. And these national action plans have been fashioned according to the Global Action Plan on AMR. And the Global Action Plan on AMR has 5 strategic objectives. That is to improve awareness and understanding of AMR, to strengthen surveillance and research, to reduce infections, to optimize the use of antimicrobial, and to ensure sustainable investments in anything that will counter AMR. So, several African countries have a national action plan. So we have a clear roadmap when it comes to tackling AMR, with all these strategic objectives outlined. And this shows political commitment to support or to tackle AMR. But the challenge is turning these action plans into action, or securing sufficient investment to sustain the activities to tackle the AMR. So Ghana also we have the National Action Plan and policies for AMR, tackling AMR. Now, there's a policy statement in the Ghana, in the policy for tackling AMR from Ghana that states that prescribing and dispensing antimicrobials should be informed by laboratory testing. But as you and I know, largely, we use antimicrobials not based on any lab tests, etc. So we have the plans, we have the policy in place to do these things, but turning them into action has been a challenge. We've made some progress, but there's a lot more to be done to tackle AMR. Now, the World Health Organization has indicated that if we don't do anything about AMR, several people will lose their lives with huge economic costs. And unfortunately, most of the people who will lose their lives will originate from this part of our world. And as indicated earlier, based on the Global Action Plan and in line with our national action plans and policy, the activities to do to tackle AMR include infection prevention and control, antibiotic stewardship programs, awareness creation so that people will get to know about the menace of AMR, and then capacity building, which is very, very key, and then to sustain investments to tackle AMR. And one key area is surveillance and research. So here in Noguchi, we've been involved in a lot of surveillance activities because surveillance activity or surveillance data is key to informing treatment decisions, antimicrobial stewardship programs, as well as knowing where to tackle or intervene in the surveillance activities. So we've been involved in surveillance and research training and dissemination to tackle AMR. Now, I'll just give you, going forward, I'll just give you some information on what we have done over the years. So since 2018, we've been recruiting patients with surgical site infections, and we look for multi-drug resistant organisms, for example, MRSA, ESBLs, and the like. So till date, we have recruited 809 patients from 2 hospitals in Ghana. And these are the organisms that we are seeing. We are seeing E. coli, Klebsiella, and again, we are seeing the ESBL here. About 65.5% of E. coli are producing ESBLs. And this is Klebsiella pneumoniae. We are seeing 78.8% of them being ESBLs. And again, we are seeing high levels of ciprofloxacin resistance as well as meropenem, the last treatment option. Now, this is Staph aureus and Pseudomonas aeruginosa from SSI. Again, we are seeing high levels of MRSAs among the Staph aureus. We are also seeing high-risk clones in this collection. And then we are also seeing Pseudomonas aeruginosa that is often resistant to meropenem among the patients with surgical site infections. Now, in 2020, we joined the SEC Africa Consortium. SEC Africa Consortium, we are into sequencing of bacteria species across Africa, and then we also train laboratory staff and students on how to sequence and how to analyze these sequences. Over the years, now just to explain briefly what sequencing is all about. Sequencing is briefly opening the bacteria up and looking at the blueprint and then putting a lens on the blueprint to see what exactly is happening there. Now, the blueprint is into the bacteria in terms of carrying resistant genes, how to grow and how to survive. So you realize that if you sequence an organism, you get more information to work with. And this information is able to support vaccine development, diagnostic tools, and all that. So when you have your sequence data, you go beyond the Petri dish, and you are able to trace what is moving from, let's say, one word to the other, and as well as what type you are working with. So you may have 2 colonies on a plate, let's say Staph aureus. But when you sequence, you realize that they are totally different, even though they are all Staph aureus. So this tool is very, very important, and we have used this tool over the years to sequence a wide range of bacteria species to understand them better. So we've worked with several hospitals, several individuals over the years, and we have been able to sequence more than 4,300 bacteria species, not just from humans, but from animals and the environment. I just want to highlight briefly on the national pilots that we did. So we worked with about 12 hospitals across Ghana and 1 private lab. What we do is that these hospitals recover the organisms, and then they send the organisms to us, and then we confirm the identity of these organisms. We do the susceptibility testing, we sequence these organisms, as well as analyze them. Now, when we analyze them, we don't only do our publications, we go back to the respective hospitals and share the data with them to support IPCs, to support AMS, etc. And we also share this information on National AMR platform, and as well as publications. So this shows the organisms or the sites that we have worked with over the years. So till date, we've done about 1,369 genomes across Ghana. These are a wide range of bacteria species from various hospitals across Ghana. Now, this is a snapshot of the organisms that we have recovered and sequenced so far. We are seeing, again, high levels of ESBLs. About 70% of ESBLs among the E. coli. We are also seeing high levels of quinolone resistance and MRSA. We are also seeing MRA, methicillin-resistant genes, as well as aminoglycosides, etc. And Acinetobacter baumannii is frequently resistant to carbapenems, and we detected them. We also detected colicin resistance. This is used when nothing is working, and we are seeing them in our collection. Now, this shot is just to illustrate data from one of the hospitals. So we sort of analyze the organisms to see how related they are to each other. And these are Klebsiella pneumoniae from NICU, neonates. And then based on, as you can see, there are several genes, resistant genes in this collection from neonates, resistant genes from aminoglycosides, carbapenems, ESBLs, carbapenems, and the rest. And all the strains from NICU are ESBLs. The strains that we recovered from NICU from bloodstream infections are ESBLs, and they carried several resistant genes. And we noted, based on our analysis, we saw some of them clustering together, and based on an analysis, they look very much alike, indicating some level of outbreak in that ward. And therefore, we went back to the hospital to share this information with them, to support IPCs, to support AMS in their and we also noted that most of the organisms were recovered within the same month, indicating some level of persistence in the ward. So we shared this information with the hospital, and they were very, very thankful to us for the information. And they worked on their IPC activities as well as what they are testing in their laboratories. Now, this shows organisms from cancer patients. So we also worked with samples from cancer patients. Again, we are finding high levels of resistance among these organisms, and resistant genes like carbapenem resistance, quinolone, and then ESBLs, etc. And then high-risk clones. High-risk clones are organisms that really multiply fast and move fast in the facility. And we are seeing these things among our patients. So the next study is the ESCAPE study. So ESCAPE is a category of organisms that are globally surveilled because they frequently carry resistance genes in them, or they are frequently resistant to a wide range of organisms. So we started this in September 2024. Till date, we've enrolled 323 patients from 2 hospitals. Half of our patients are coming from the pediatrics department. As you can see, most of our samples, we got a lot of samples, blood samples, urine samples, and wound samples. And if you look critically at the charts on this side, we note that from the blood sample, we find a lot of Klebsiellas and Staph aureus. And then for the wound samples, we find a lot of Pseudomonas aeruginosa from this category. Now again, this is Staph aureus from this project, the ESCAPE project. Again, we are seeing high levels of resistance. Now, an interesting thing to note is the vancomycin resistance there. That is the last treatment option, and we are seeing it among the organisms from the ESCAPE project. Now, the ESBLs, Klebsiella pneumoniae from this project is also producing a lot of ESBL. So largely, we find ESBLs frequently in our settings. Now, these are different organisms, Pseudomonas aeruginosa, Acinetobacter baumannii, and Enterococcus species. Again, we are finding resistance to meropenem in Pseudomonas aeruginosa, and as well as Acinetobacter baumannii. Enterococcus species, we found vancomycin resistance, and these organisms are from a wide range of clinical sources. Now, since we started this study, we've noted that about 30 people have passed on. So we decided to look critically into some of the patients from different wards to know what the variations or proportions of MDRs recovery from the patients who have passed on. And from the burns unit, we are seeing VRE, or vancomycin-resistant enterococci, Ephesium and Faecalis. We are also seeing carbapenem-resistant K. pneumoniae, and then carbapenem-resistant Pseudomonas aeruginosa and the like, indicating that these organisms could have contributed to the mortalities. Unfortunately, these things are not frequently detected in several labs, so it will be very difficult to manage such situations. And now, if you have these resistant bags, superbugs, I call them superbugs, in several of our hospitals, and our IPCs are not up to task, it means that everybody is at risk in these settings. And again, we are also finding carbapenem-resistant Klebsiella pneumoniae from NICU, from blood samples among the patients who lost their lives. We are also finding ESBL positive, E. coli, MDR, and other MDRs. We are finding various wide range of multi-drug resistant organisms among the patients who lost their lives. Now, as indicated earlier, we've been able to share the findings with different categories of stakeholders. And this is a dissemination meeting with surgeons and the pharmacists to share what we are seeing in terms of the resistant profiles and the clones that we are finding from the surgical site infections. And we also share the information with the pharmacists, and this has gone a long way to support the IPCs and AMS, or antibiotic stewardship programs, in their facility. Now, this is another dissemination meeting where we went to Effiong Kwanta Hospital, one of our sentinel sites under the SEC Africa project, to share the findings with them, with clinicians, pharmacists, and nurses to support their IPCs and AMS activities. This is Ho Teaching Hospital. Recently, we were there to also do the same, to support, tell them what we are finding, so that they will up their game in terms of IPC and AMS activities. And these are some of the publications that we have done over the years. You can check on them online. And we've also been able to present on different international and local platforms. We've also trained a number of students, PhDs, MPhils, and BSc students. Now, aside all these activities, we've also been involved in training. Over the years, we've had several training sessions. We've had participants coming from different parts of Africa to be with us here. We teach them how to identify bacteria, how to extract DNA, how to sequence, and how to perform sequence analysis. And these training sessions have been very, very impactful in the sense that some, based on this training, some go ahead and do something in their labs to support AMR surveillance. And we believe strongly that this is a critical way to tackle AMR in a sustainable way as we go ahead in the future. And therefore, we launched this course, the AMR Edge course, to be able to do these things in a sustainable way. We have 5 models. A model looking at bacterial identification and AST, fungal identification and antifungal susceptibility testing, DNA extraction, bioinformatic analysis, data management and visualization, and transformative AMR leadership, because we believe that everything rises and falls on leaders, and therefore we need to have leaders championing antimicrobial resistance. We are starting April 2026. We encourage everyone who is interested in joining this training program to get on our waiting list by scanning, getting on our website, to get on the waiting. Is taking action. Because sin is taking action. Because based on the Global Action Plan, we are to focus on, for example, IPCs, focus on optimizing the use of antimicrobial, sustaining investment to tackle AMR. All these things are outlined there. We are also to ensure that antimicrobials are only prescribed and dispensed based on laboratory testing. So we need to implement these activities and sustain these activities as outlined in the action plan and our policies, so that we can strengthen our labs to test these things, so that we can also enforce the regulations that we need to govern the use of, the regulations that we already have to govern the use of antimicrobials, and to also strengthen IPCs and AMS. It will interest you to know that if you go to several of our hospitals, simple hand washing is not available, even though we are committed to reduce infections. We should be able to take the actions to put in these measures. During the COVID or during the pandemic, every facility has some level of hand washing accoutrements there. But now there's nothing. And you go to several places. I think we should go back to that space to ensure that we reduce infections. And simple activities like washing of hands will go a long way, not to reduce just these resistant bugs, but several other organisms that are troubling our lives on this continent. We also have to sustain multi-sectorial AMR surveillance, because AMR surveillance or AMR is not only a human problem. It's an animal problem as well as an environmental problem. And whatever is in the environment can move to us, and whatever is in the humans can also move into the environment. You have a lot of pharmaceutical companies here and there releasing discharge into river waters and all that. We need to sustain this multi-sectorial AMR surveillance activities to be able to tackle, to really tackle this menace head on. And we also need to integrate tools like whole genome sequencing, artificial intelligence, machine learning into our surveillance system, so that we'll be able to understand this granular data to support AMS as well as IPCs. And when you have the sequence data, you'll be able to inform vaccine development and diagnostic and drug development efforts. So we need to integrate these tools in our surveillance system to generate the granular data that will help us to tackle this menace properly. And we have to expand the workforce. As indicated, we need to expand the numbers to be able to tackle this menace. We have very few staff who are able to do susceptibility testing to identify bacteria in several hospitals. And therefore, if we don't have them, it's difficult to manage this. So we need to expand the workforce so that we can tackle this menace. So, in a nutshell, AMR, we have high burden of AMR in our settings, African settings. In Ghana, we are finding ESBLs, MRSAs, isolates resistant to quinolones, carbapenems, which means that we are running out of options. We are basically running out of options. And the fact that we have just 1.3% of labs testing these things means that we will not be able to treat our patients based on any evidence. And as a continent, we have made progress in line with our AMR plans and policies, etc. But implementation and sustaining these activities are major challenges. And therefore, we need to take the actions and sustain the actions, and always work according to our plans, the strategic objectives and the global action plans, as well as our national action plan, to support support creation of awareness creation, to make sure that we reduce infections in our labs, to sustain investments, to be able to tackle AMR. And this will go a long way to help us bridge the policy and practice and the prevention that we are looking at. So I would like to end on a reflective mode. I'll say that in tackling AMR, everybody has a role to play. And policymakers, researchers, clinicians, pharmacists, farmers, educators, microbiologists, lab scientists, students, and everybody. Because AMR will not wait, and neither should we. And we need to act now, protect our present, and secure our future. A lot of people have contributed along the way to support the various activities that I've talked about. We are grateful to the management of this institution, the present director, Professor Dorothy Yeboah-Menu, past directors, and for the support they've given to all the activities that we have done. We are very, very grateful to them and everyone who has participated in our journey. Now, I'm very grateful to my team who have been involved in all these things for their commitment and efforts over the years. Most of them will be presenting doing a number of presentations. We have posters on machine learning and diagnostics. We have a poster on a dashboard that we are creating to monitor AMR in real time. We have a poster on antifungal susceptibilities of Candida, and we have a poster on wastewater AMR and bloodstream infections and genomic information on several organisms, and we encourage you to reach out to them and get more information. So on this note, I would like to thank you all for your attention, and I'll be happy to take your questions. Thank you so much.
Thank you, Prof. Edri. At the beginning, it sounded all gloom and doom, but it's reassuring to know that if we take collective actions now, we would be able to stem the tide of AMR. Thank you so much. We now, in the interest of time, we'll just take one or two questions if there are any. Yes, there's a question at the back. So I'll take one from Kwesi and then one from Prof. Kwashi, and that'll be it. Prof. Edri would be around during the snack break and you can engage her. Can we get the microphones, please?
Hello. Thank you very much, Prof, for your very insightful presentation. I'm Kwesi, a member of staff here at Noguchi. Prof, I have a question on the survivors of the infections, the bacterial resistant, the AMR resistant infections, the survivors. What is the feasibility of combining WGS, that's whole genome sequencing, AI and ML, in trying to also investigate their genome and see if there are any changes that would inform certain insights into how we can also naturally resist some of these bacteria? Thank you.
Should I? Yeah. So thank you very much for that question. So I talked about people who have lost their lives along the line, and then we took the organism, we looked at what exactly was in their samples. So, I mean, as we all know, when you sequence an organism, you get more information, to deal with the situation that you are dealing with. So what I'll say is that now that we have sequenced a lot of genomes, we can sit down and look into it using the various tools, our machine learning, our AI tools, to really understand this data and then project. We can even project ahead to know what may happen in the future. So we can look into the data and then go forward with the next steps. So, I mean, you are invited to come over and then we can talk further.
Thank you, Prof, for the insightful talk. Yeah.
Oh, okay.
Yeah, so I was quite curious. I think one of the hospitals that you focused in on, you had a few infections within the neonatal ICU, and you said they were clustered together.
Yeah.
And I saw that you were looking at different parts of the hospital. Did you see any sort of like linkages between those that you were seeing in the NICU and around different parts of the hospital?
Yeah. So thank you very much. And in the analysis that you saw, we got organisms from the NICU of one of the hospitals. And within the hospital, they have different wards. So based on the analysis, we noted that within the NICU and some pediatric departments, the organisms recovered are related to each other in that particular department. Okay, and not the other departments. So it's indicated that there's some level of transmission in that particular department, and that is what drew our attention, and then we went there and talked to them about it to up their game in IPCs and all that. Apparently, these things have gone on undetected, and based on our study, they were able to do something about that. Yes.
Thank you very much, Prof. G. Once again, can we give us a round of applause? Yeah. Thank you. As the opening ceremony draws to a close, would invite our chair to give us his closing remarks. Thank you.
Thank you, our MCs. You all agree with me, we've had an exciting morning, and by way of time, I believe we've done well. We've tried to do very well. Let's give ourselves a round of applause when we start early. So I'll attempt to give a brief summary of everything we've heard this morning. Director told us about the functions, the role of Noguchi, and how they have distinguished themselves over the year, and the great number of research outputs and research trainees that they've generated over the years. And our ambassador told us about the partnership through research and innovation with Noguchi, and enduring legacy, and the potential for improved partnership through exchange programs, technical assistance, and infrastructural development. We are very keen and happy on that, to see new things coming up on the university campus. The Honorable Minister emphasized the indispensable role of research in national development and health, and mentioned the invaluable contribution of Noguchi, especially during the COVID-19, and also the surveillance activities, looking at all the potential infectious diseases, mpox, dengue fever, and all that. And we are grateful that they are recognizing this one. And also mention the 4 key areas the ministry is focusing on: modernizing lab systems, which Noguchi really is benefiting from, especially the DNA testing that was mentioned. We all felt very sad on that fateful day that we could do this in Ghana, and now we know we are going to do the testing here. Again, we are grateful. Universal health coverage and relying on data for decision making, actually real-time decision making to solve problems, and deliberate effort at training through the National Fellowship Program, and also health innovation through pharmaceutical manufacturing, vaccines, and all that. And that is also very good. The country rep, WHO, mentioned Noguchi as one of Africa's foremost biomedical center. We are grateful for that recognition and for the continued collaboration in terms of the areas you mentioned, the malaria vaccine, the global polio evaluation, and the contribution of the data from Noguchi and also AMR and other such activities. You also mentioned health system improving activities that WHO has undertaken, the steps, the holistic health facilities assessment, and the demographic and health survey. These provide very useful information and data for improving our health. Dr. Soji told us one clear message I had was that as an institute, they are not going to spend money and repeat what is being done in the academic institutions, and rather they are going to strengthen, provide some machines and other laboratory support to these research institutions in academia to support what they do. And that mentioned some of the new activities linking Ghanaian scientists to the mRNA networks of Africa and other such activities to improve our ability to manufacture vaccines. And I agree with the minister. When are we starting the vaccine manufacturing? Our keynote speaker gave us a brilliant message this morning and highlighted why every delay in time leads to the death of especially neonates. And my key concern was with the issues they found in the NICUs, the neonatal intensive care unit. If you look at the demographic and health survey data from 1990 till date, you see that we've made some quite great gains in reducing maternal mortality. We've done quite well in reducing child and infant mortality. What we haven't done, if you look at the data, we've made minimal gains in neonatal mortalities. And some of these things will need to be looked at. What is killing our infant at that very young age? She also mentioned the general challenges in Africa. We have the action plans, but we are not putting them into action, really. And then the high levels of all the resistances he mentioned. And we were very gratified to know the contribution, especially of Noguchi, to the national effort in terms of providing surveillance data through One Health activity. And I must say proudly that Noguchi is going to run the master's and PhD program in One Health from the next academic year. Can we give ourselves a round of applause? And this is a flagship program we intend to. And then how research evidence is being used for training of practitioners and informing practices, especially in the area of IPC, infectious disease prevention and capacity building. At the end, she admonished us how to bridge the gap between policy, practice, and prevention, and highlighted that every one of us has a role to play. You may not be a health worker, but whenever you enter the health facilities, please do ensure to wash your hands. The bacteria follow the path of health workers and visitors to our facility. Thank you very much, Director and team. We believe that the rest of the occasion and the event will go as well as we've done successfully this morning. Thank you very much, ladies and gentlemen.
Thank you, Provost, for captaining the ship this morning. Before we leave, would like to specially recognize our general sponsors who have made this meeting possible. We have our platinum sponsors, LabMat, GIZ PharmaVax Ghana, and Stanbic Bank. We are also supported by our gold sponsors, Bethel Logistics, Carmore International Limited. I can see Alexander Grant, who for the last couple of years has always attended the ARM. Let us give him a round of applause. We also have MES Equipment Limited and Revna as part of the gold sponsors. And for our silver sponsors, we have Illumina ISN, DCL Laboratory Products, Ecobank Ghana. We are also supported by Inkaba Biotech, Volta Electric, Tasty Treats, Republic Bank, Afro Wings Limited, and Prudential Bank. On behalf of the organizing committee, I'd like to say a very big thank you to all of you who have joined us here today, and for all other participants who have joined us virtually. We are honored to have you here this morning. At this point, we would take a snack break, but I would entreat all of you to remain seated whilst we allow our dignitaries to step out, following which we would take a photograph with our dignitaries, then we can proceed to have our snack break. We would also entreat the media amongst us to hold on with their interviews for us to finish our photograph, then they can have their meetings. Thank you all once again, and do enjoy your snack break. What they printed. So whilst we are stepping out, I would also like to acknowledge our silver sponsors. No, I've mentioned Illumina, DCL, and EcoBank. And Amen Project. Yes, we would please ask that we move out to take the photograph. Please move out. Our dignitaries, kindly move out for the group photograph. There are two exits, one to my left, so you could use the door to my left. Yeah. So what's the time now? So we are coming. So in the interest of time, we are coming back at 11:50. We are coming back 10 minutes to 12. So let's quickly move out for the photograph and then grab something to munch on and reconvene here. Let's take a picture. Please give it.
It's from their end, is it?
That's good.
Because moving them like a bit.
Nothing to get an extra.
Very good. How are you?
We are trying to do it, so we only pretend that we don't tell.
Where are you from?
I can give you.
He wants to be.
Oh, thank you so much. I appreciate it. But please hide it. In fact, everybody comes to see it. Have it.
It's like someone that's
Yes.
see you soon.
Are you still with us or you're done? Oh, no. All right. Excellent. See you.
Should we sit together?
Yeah.
Okay. I think no. But where do we sit?
One can sit on that side, one on this side.
Okay.
I'm taking a chair from the side. This one. How many? 6 years. Alright, so if one person sits here, and then you have your 5 guests. And then the other person sits here.
Yeah, okay.
Alright. You can share mics. Let me see if they have. There's one here.
Maybe we'll be back. It doesn't see something.
I think this one has been used. Who will even use this?
There's 5 bottles here.
Fresh.
This one goes like this. So, Charlene, I was going to let them say the way we are going, or we can just draw the questions and go from there. Yeah, because I don't even know how they're going. Yeah, that's right.
Have you identified them?
We've seen them. We've seen Dr. Till. Dr. Till. I think they mentioned Mr. Grant.
They also mentioned Dr. I think you have
Dr.
Redna.
Dr. Ati.
I think Dr. Akbalu.
Yes. And there's one more.
Yeah, there is one more. We have Dr. Brown.
Yes.
Grant is also there.
No, Mr. Brown, sorry.
Okay.
Dr. Till.
Dr. Akbalu.
Mr. Chile.
Yes.
Another more is Mr. Grant.
Yeah, Grant was
Oh, Reverend is Dr. Fari. Yes. Adogla. Adogla. Mr. Adogla is Nambe. Yes. And Mr. Tule is Namma. Yes. Dr. Tule is. Yes. Okay.
Okay, so you're saying that?
Yes.
All right.
Thank you.
Yeah, I don't know how to when I pressed it, it didn't come on. What? Doesn't come on. Oh, yeah.
You need long press?
That's a long press.
Hello?
Did you hear me?
So what is that?
Hi.
Okay, so I'll just add that to the housekeeping.
Yeah, I think.
Yeah.
So we're going to be sitting.
Yeah, so that's fine.
That helps even.
Yeah.
Okay, so that will help us in the note making. Yeah, because the person is saying something, we have to write it. Yeah, studying it.
But I'm just worried that because there's only one of these.
I know, right? It would have been nice if we could have another one.
Okay, so just start together. Yeah, I think we can ask.
We're sitting together.
Yeah, I think
we are.
we are here.
Maybe when they are coming, we need to find them and ask them to come. Or maybe like Maybe just let's see how it looks like. Okay. Very nice. Casual. It's better than stuff. Okay. So I think we can take a break. Yeah. And then now we know how everything is. There we go.
Am I co-chairing with you? Your name?
My name is Eden.
We
are.
For the one I'm co-chairing.
Is there something else
The
before?
next section.
Is there something else before the panel discussion?
Yes, there's two lectures before the regular.
Oh, and we are already arranging.
Yes, that's what I'm
wondering. They are two plenary before
Okay. So they can sit. No, I think the panel discussion is together, right?
Yes.
It's not a breakup.
So after the plenary, then we have the panel discussion.
No coordinating.
I have a program.
The breakout.
You have a program. Check the program.
Yeah.
Come and look at innovative, the infrastructure that you've been dreaming about. Come and listen to our impactful research that is making waves across Ghana and the sub-region. For Noguchi, there's nothing but quality research.
My name is Professor Jacob Kamidu Souza. I am from the Noguchi Memorial Institute for Medical Research. I'm the co-chair with Professor Kodjosa Wakusi planning this year's annual research meeting of the Institute. This is our 10th annual research meeting, which also coincides with the 25th anniversary of the College of Health Sciences. So this research meeting is being organized together with all other constituents of the College of Health Sciences, bringing together all the scientists to showcase the work that we have been doing.
The theme for this year's annual research meeting is advancing healthcare through impactful research and innovation, and we are having this program from the 25th to the 27th of November 2025. We are having on the first day a keynote to be delivered by one of our own, Professor Beverly Eju, who will be speaking on her work in AMR. We will have, as part of that day, also a panel discussion where we would have some of our sponsors who would speak about the impact of private-public partnerships in promoting research and innovation. Our parallel sessions happening in the afternoon to bring the first day to an end. On the second day, we begin the day with a symposium, a special symposium by IMEC, that is a JICA-funded program that is based at Noguchi. They were having a 1-hour symposium to talk about some of the research that they have conducted over the past years. And then we would have our poster sessions beginning with a table session where selected posters will have 2 minutes to pitch their ideas and invite others to join them for the afternoon session. Then we continue with our parallel sessions in the afternoon for the second day. On the third day, which is one of the unique things that we are doing this year, we are having a joint celebration of our annual research meeting with the College of Health Sciences 25th anniversary, and we are having a joint activity which will be hosted at the Great Hall. And in the morning we will have the closing session or the climax of activities for the College of Health Sciences, and then we continue with activities relating to our annual research meeting. First, with a keynote session from Professor Abdullah Jinde, who is the Noguchi Africa Prize winner for 2025, a researcher with the University of Monaco in Mali. He will be here to share with us on his work in malaria genomics and how we can transmit findings from the bench to the bedside. We will end the day with another unique thing we are doing this year, which is our annual debate.
You do not want to miss the debates. It is Legon versus Colegon. And we would want to see who will win the debate. It's about digital technologies and health in the current age. And whether digital technologies would bridge the gap or extend the gap in healthcare and access between the rich and the poor, the have and the have-nots. We aim to give awards to young scientists who will be presenting their posters and their abstracts, so at least there will be a prize, first, second, and third prize for the abstracts and the poster presenters. The open day, we are expecting at least 1,500 students from southern Ghana. Most of them are from within Accra, but some are from the eastern region, others from the western region. And this day affords the opportunity for young scientists, the future researchers, to get to learn about what we do, see our labs, learn about our equipment, and hopefully be inspired to become scientists in the future.
Going through the 9 departments, immunology, virology, so it's nice to find out the kind of jobs you can take on by learning, and show that your learning is not really for nothing. You can interact, ask questions, and just have a good time and meet new people. So it's been a lovely experience.
This promises to be explosive, and we are inviting all of you to come and witness this as we climax the activities for our annual research meeting this year. We thank all our sponsors for their dedication and commitment to us, and for opening their doors for some.
Africa stands at a crossroads. Technology is transforming healthcare like never before. But will digital innovation bring healthcare closer to everyone or leave some even further behind? As part of the 25th anniversary of the College of Health Sciences and the 2025 annual research meeting of NMIMR, we are bringing you a live thought-provoking debate where two of the brightest teams face off. Experts from Team Legon versus experts from Team Kolebu.
Expect fierce arguments, fresh perspectives, and powerful insights that must reshape how we see the future of healthcare innovation in Africa. Trust me, this is one conversation you do not want to miss.
And the motion, digital health, will widen rather than bridge Africa's healthcare equity gap. And this is happening on the 27th of November 2025 at the Great Hall, University of Ghana, 1 p.m. sharp.
Be there, be inspired, because the future of African healthcare starts with the conversation we have today.
Dear team, what do you think about our upcoming debate?
All right, so we are excited about this debate. This forms part of the 25th anniversary celebration of the College of Health Sciences, and we are gearing up for this debate.
Team Kolebu is truly excited. We know we are going to
Yeah, hello. Yes, good afternoon to all of you. Please, it's about time for us to make our way back to the conference room for the plenary session. So please, I know you're trying to make some connections. There is more time right after this. So please make your way to the conference room for us to begin the plenary session 1. Please make your way to the conference room as we are about to start the plenary session. Ladies and gentlemen, please let's make our way to the conference room where the plenary session 1 is about to start. Please let's make our way to the conference room now. Please come to the conference room now as we begin the plenary sessions, please.
Before they come. Let me finish this. Are you done with the design? The design is finished. Give on pressure, give on pressure. What is it doing? With the close start, give on pressure.
Please, let's make our way to the conference room now. We are about to start the plenary session. Thank you. Please move forward a bit so that those who are late can sit at the back. Thank you so much for coming. Please make your way to the conference room now as we begin the plenary session. And can you please move forward and fill the spaces in front of you and connect to people. Say hello to people as you are coming forward, please. Thank you for coming. Please move forward straight. There are a lot of seats in front of us. Please move forward. The ushers, please help us send people to the front seat. Let's fill the gaps in the front row. Thank you for coming. Please come forward. Thank you for coming. Please move forward. This area is empty. Bring people forward to this side. Yeah, this row to my right is empty, so please fill it for me. All right. Good afternoon to all of us once again. Good afternoon. Thank you for coming. You're all warmly welcome to this afternoon session. It is a plenary session 1. And we have 2 chairs for this session. We have Professor Samuel K. Dazi, former head of the Department of Pathology Department. Please, let's welcome Professor Dazi to the chair. And Professor Grace Lovia Alote Babington of the School of Public Health. Please, let's welcome her too. Thank you so much, chairs. So I'll leave this session to the chairs to take over for me. Thank you very much.
Hello? I think this works. Yeah. Yeah, good afternoon and welcome back. From break, we have this plenary session and we are going to have 2 presentations from very distinguished personalities. I have my co-chair, please.
From the School of Pharmacy.
So my co-chair is from the School of Pharmacy and I'm from Noguchi. So the plan is that we're going to have 2 presentations, each lasting 20 minutes. And my understanding is that we'll have the 2 presentations and then after that we'll have a general discussion because of time. So I will introduce the first speaker. And after that, my co-chair will handle the next speaker. So I have the honor to introduce Dr. Paul Sechi Nyantechi, who is a very distinguished entrepreneur in Ghana. And you'll be surprised to note his contribution to healthcare. So let me just read a bit about him. Dr. Paul Sechi Nyantechi is a pioneering physician entrepreneur with over 25 years of experience advancing evidence-based medicine through diagnostics, research, and clinical trials. A graduate from Randolph Macon College and the Johns Hopkins School of Medicine with internship training at Yale Medical School. Dr. Sechi Nyantechi has redefined laboratory medicine in Ghana. He is the founder of Quest Healthcare, MDS Lancet Laboratories, Ghana Limited. I know many of you have been there. Quest Medical Imaging Limited, and MACREC Clinical Research Management. So WACREC is a network of medical laboratories and radiology centers serving over 2,000 patients daily across 30+ locations. His leadership integrates innovative technology with patient-centered care, setting new standards in healthcare delivery and accessibility. He is very much a visionary. His work has earned him numerous accolades, including the Global Achievement Award from the Johns Hopkins School of Medicine. The award honors alumni who exemplify the Johns Hopkins tradition of excellence and have brought credit to the university and their profession in the international arena through their professional achievements or humanitarian service. Another award is an honorary Doctor of Science degree conferred by Randolph Macon College in recognition of his contribution to science and public health. The European Quality Award from Academic Union Oxford, reflecting his steadfast commitment to quality. And the last, multiple CEO and healthcare leadership honors across Ghana. Dr. Sechi Nyantechi's blend of medical expertise, enterprising spirit, and commitment to innovation has positioned him as a pioneer in Ghana's medical diagnostics landscape. And interesting to know also that he's a very good motivational speaker. So thank you very much, and please let's welcome Dr. Paul Sechi Nyantechi to give us something.
Thank you very much, Prof, for your generous introduction. I think I'm going to need some help. And why you are coming?
So again, Dr. Posech will be talking to us about innovations in diagnostics and laboratory medicine, the Ghanaian perspective. Thank you.
Thank you very much for the opportunity. I hope all the protocols established, so I stand on them. So when I got the invitation to do this, I said to myself, wow, Noguchi, University of Ghana, College of Health Sciences. Let me figure out to pick a topic that would not need any scientific citations. So I can be very safe. So this morning I'm going to walk you through, as the topic indicates, is innovations in diagnostics and laboratory medicine. But it's purely on a Ghanaian personal journey to share with you 25 years ago where diagnostics and today where we are. So this way, no citations, the reference is myself. So this is the journey. I had a personal experience back in 1997. I had just come back home, and it led to this, because originally my professional pathway was not in laboratory medicine. It was actually towards internal medicine. But that personal experience changed me to pick this particular path. So 1997, it was purely manual. I remember setting up a first small lab opposite Kolebu. It's still the same place we have the current Kolebu branch, MDS Lancet. And everything back then was colorimetry, pure manual. We had a chart on the wall, and we do this colorimetry with some inverse equation to give you HB. And so that was the days. Then by 2000, I realized that the experience that I had to do with the importance of laboratory results in helping to manage patients. And definitely those manual, as much as that is the beginning, also had limitations, as we all know, with a lot of manual errors introduced in the results. And we all know also how laboratory results influence decision-making process in patient management. So we had to move to invest, and I remember back then we brought in standalone automated analyzers, and it became like that period similar to Mr. Despai's Museum of Cars, you know, because this is the first time in a very long period people are seeing fully automated hematology analyzers, separated biochemistry, endo, and then we incorporated these standalone analyzers with semi-automated analyzers. And that one was just to help meet one important thing in medical practice, turnaround time for the test, because we were then using fully automated analyzers that are 96 platter reader. And by introducing the strip readers, you could just quickly get beta ECG quantitative to rule out ectopic and things like that. And that helped to now improve the system. But then 2008, the realization of the need for lab pushed me to get a joint venture company with Lancet Laboratories South Africa, because we were then trying hard to get to accreditation, and we realized that as a standalone lab in Ghana, trying to get ISO accreditation was not easy. You have to be involved in a whole lot of quality management systems that as a individual company, the cost involved was going to be very, very challenging. So Lancet came in, and then for the first time we have large volume automated machines with fast run throughput that can run 1,000 samples a day and things like that. So we then leverage and piggyback on Lancet to then move on gradually, and by 2010 we got ISO accreditation. So let me seize the opportunity to congratulate Noguchi. We are happy to see the ISOs. We want to see more ISOs in Ghana because of the role it plays in the quality delivery of laboratory results. So by that time, we then move on to molecular biology lab PCR. So we were first to establish the private PCR lab, and still went on to get ISO accreditation for that particular lab. That led us to be selected by NIH to begin to support safety labs for clinical trials. So that is how the progression was moving on. So just as we thought everything was okay, then come boom, 2020. As much as all the bad things COVID brought, I think it also showed our limitations and opened our eyes. And currently in clinical laboratory practice, we are moving towards total automation, fully total automation. And I'm happy to announce here that MDS Lancet has acquired total automation. It has gone through all the certifications and validations, and currently we are using it. We haven't officially launched it, but it's first of its kind in West Africa. Thank you. So who are we? I'm sure most of you know us, so I'll brush through. We currently lead the private leading medical lab, so we are sort of sister to Noguchi in the public arena. That's why I'm happy to see so many colleagues here that we collaborate with. We have ISO 15189-2022, and over 30 branches. And one of the progressions and innovations we've made when we started, and back in the early 2000s, it became like a phenomenon. People were sending cases outside, and you know, people get excited. Oh, my samples are being taken to South Africa. Please, if you are in the field, anytime you send samples away, it has its own risk. So Lancet, over the years, have taken the initiative to be able to do currently we've cut down about 40% of cases we're going to South Africa. Today, it's less than 5%. And we are basically doing over 5,000 plus routine and specialized testing in-house to improve turnaround times and patient management. So my previous slide is just walking you through the steps and the stages of how the innovations have been taking place. And happily, we're serving over 200 patients across Ghana because we are spread out from northern part to the south. And we are also supporting a lot of colleagues doing research, medical research and clinical research, and doing all the safety labs, which we are accredited to do. And very soon, by next year, by God's grace, there's a joint project coming up that I don't want to talk about it, but it will help us to now support and collaborate with Noguchi to make sure there's a large-scale clinical trials going on here in Ghana to make sure we shut the talk and that we can do it in Africa. That is why always the database doesn't favor us. I hope that problem will be solved together with Noguchi by next year. So our vision mission calls are similar to what Noguchi strives to do, so I will just move. These are pictures of our lab showing one thing is we make sure all our trained scientists are Ghanaians. So now I will spend time to talk about the total laboratory automation because it's the new guy in town. So by definition, it's just a comprehensive system of automations it automates every aspect of laboratory process from pre-analytical to post-analytical. So it includes system of robotics, as the diagram will show you, and anybody is free to see the real one. It's just across the street at our East Legon branch. So it's a robotic combined with machine learning AI. So it integrates a very advanced software. And this particular system is from Beckman DXA 5000 layout. The advanced software in there is called Ramisol. That incorporates is able to. So you just put your samples on a rack, you just give it to her at the pre-analytical level. It will do all the pre-analytical quality checks from sample volume, sample quality, hemolysis, what have you. And if it detects anything, it stops it there. So centrifugation is incorporated into it, and then it will detect based on the logging which of these series of analyzers on the track is supposed to do the test. So that is how TLA, as we popularly call it, total laboratory automation, functions. So what are the advantages? Obviously, it's improving accuracy and precision because pipetting and all those manual systems are incorporated into it, and you program it. Your QC graphs, everything. Of course, very faster turnaround times. From 5 minutes to 15 minutes, everything you give it to it is going to be done and results will be ready for filing. There's minimal manual interference, and by that, it reduces the laboratory errors. Large sample throughput. And another important thing for the environment is it reduces the biohazard exposure because, like I said, everything is contained in the system, and we've programmed it and done all the medical waste direction in underground. Now you have a good improved inventory system, which will help cut costs and hopefully will drive the cost of the test also down. Now the next major thing that personally, because of my interest in research, I'm always proud of is our role in clinical trial service. So we have currently provide all these services, not as a standalone, but in collaboration with academia. We have a lot of collaborators from Global Health and KNUST, and even Noguchi here, and then University of Ghana, some of the individual professors. So we can cover from feasibility studies, database, and active invitations, ethics, regulatory, everything, entire scope of clinical trials. So we currently encourage biobanking and biorepository, project management, sampling, kit preparations. All these are parts and package of a total clinical trials. And the importance for me with the clinical trials is to help to make sure that we are not left out, because we all know the direction of where medicine is going, to precision medicine, and most of the time the data that some of these pharmaceutical sponsors have used has screwed our people here. So our task is to make sure we minimize that. And in the past, you can minimize it because you don't have what you call central lab, which is dedicated for clinical trials with its own various accreditations. And that is what I'm saying, hopefully by next year, first quarter, in collaboration with University of Ghana, UGMC, we will solve that problem so that the sponsors can feel comfortable, and our researchers and all the esteemed scientists in Ghana will be free to now do full-blown clinical trial services. Now, because it's a personal journey, obviously then it's so smooth when I'm telling the story, but it wasn't that smooth. So therefore, I decided to share some few ideas. And from what I said, we try to separate these professions, but experience over the last quarter, 25 years, and this is why it's personal, so I don't need to give you any literature reference. You know. What we have observed is how some of the ideas I want to present for sharing is to be able to integrate clinical rotations into the training of laboratory professionals, especially the clinical side, even the research side, because later on we're going to find out medical practice is never going to grow, improve, advance without medical research. You see, the sad aspect is some things are so obvious as human beings, yet we fail to give it importance. And if you're going to improve healthcare delivery, whatever it is, the emphasis has to start from the research side. Yet we don't fund it enough. Or do we fund it, Prof? Do you have enough funding? So that is the message hopefully I will like to leave, but unfortunately the minister has left. But so we need to also invest in quality management systems that will generate excellence in our service. That is why I'm so proud of Noguchi moving to get this ISO accreditation. That way it's internationally certified. The Western world can use anything as an excuse because we are all certified. Now, it is important, as I've said, to integrate researchers into clinical laboratory practice to bring on board their problem-solving skills. The reality of the matter is, the esteemed researchers we have at Noguchi, University of Ghana in our academia, they are set. They have these special skills that it can't just be left only in the lab. And when you do that, I had to put it together. No medical research, nothing happens. So medical research plus laboratory medicine, we're going to get better patient outcomes. And that is what we are all striving. Good health, then the country is healthy, and economically you will be viable. is also essential for precision medicine, value-based care. It's not always that we're going to sit for the West to keep advancing and moving on. Whether you like it or not, we are moving gradually. It started with presumptive diagnosis, treating people. If you get well, you get well. And then it came down to evidence-based medicine. And just as we are catching up with them on evidence-based medicine, now they are saying something that's called precision medicine. And so, and everything about precision medicine is also based on the research. It's about the genome studies, about the sequencing. So you see how everything is intertwined. And that is why we need that, because the future definitely is on greater reliance on data-driven, personalized healthcare. And I hope our system will support huge set-aside money into research funding. So the new direction in lab medicine, to begin to wrap up, is basically taking a room. In the past, it's all like that. You see the packed microscopes, lab coats, pipettes. But the trend today is they're moving towards interprofessional, interdisciplinary team, which has been proven will improve patient care. And I think that is the core mandate of all of us, even from private, and the core mandate of Noguchi is right there. It's about integration. So if I have any message, I would like to see all of us working together, and so that we can share ideas, because at the end of the day, the knowledge will come from the research, and then the lab will apply it, and then the clinicians will use it for their patient management. Thank you very much.
Thank you very much, Dr. Paul Sechinyantichi, for sharing with us your journey in changing the whole landscape of laboratory medicine and diagnostic. Thank you. Because of time, I think we'll go straight to our next talk, and I'll ask my co-chair to introduce the next speaker.
Thank you very much, Mr. Dr. Nyantichi. Our second speaker is Professor Anita Gansa. She would be talking to us on, the topic is From Genome to Policy, Harnessing Malaria Genomics for Public Health Impact. I'll tell you a little bit about our speaker. Professor Anita Gansa is an eminent Ghanaian genomic epidemiologist and associate professor of genomic epidemiology at the Noguchi Memorial Institute of Medical Research. She serves as head of department of the Department of Parasitology. She earned her PhD in genetic epidemiology from the London School of Hygiene and Tropical Medicine, with 3 years of advanced genomics training at the Wellcome Trust Center for Human Genetics, University of Oxford. As an ExxonMobil malaria scholar, she completed her postdoctoral training at Harvard H.T.H. Chan School of Public Health. Her research focuses on translational genomics for malaria and other infectious diseases, leveraging genomic insight to inform disease control and elimination strategies. She has a strong interest in disease susceptibility, genes, and genomic adaptation in both human and pathogen populations. Professor Gansa is widely recognized as an expert in committees that develop strategies for malaria elimination and drug-resistant monitoring across Africa. She is one of the inaugural cohort members of the prestigious Malaysia's Juma Science Leadership Fellowship, where she leads the development of novel, affordable malaria molecular surveillance tools for Ghana. Beyond malaria, she has contributed to studies on the genetics of chronic disease, bioinformatics capacity building across Africa, and lately hookworm genomics. She is deeply committed to advancing biobanking, and data science for future biomedical research in Ghana. As a passionate mentor, she has nurtured numerous researchers and students supporting their career development. Can we put our hands together for Professor?
Good afternoon to you all. Thank you very much, Madam Chair, for the very generous words. So my presentation today is going to be on leveraging malaria genomics for public health impact. And okay, right. So I'll give you a brief background on the subject, and then we look at the past, present, and future of malaria genomics. Here I'm going to share data from colleagues from the Institute. So basically it's work done by the malaria group of the Institute. And then some of the challenges that we face in malaria genomics and recommendations and some conclusions. So we know that malaria is still a major public health concern. 2023 alone, WHO reported 363 million cases and 597 deaths, respectively. So if you do the math, you see that it's about a child dying every minute. So by the time I finish this 20 minutes presentation, we'll be counting approximately 20 children dying from malaria. And the WHO Africa region is disproportionately affected by malaria. We took a brunt of about 94% of the morbidity and 95% of the mortality. Now, this data is not just statistics. Yes, we have chalked a lot of success, but it shows us there's still a lot more to be done in the area of malaria control. And now that we are talking about eliminating malaria, it shows that we still need more tools. And I'm going to show you in this talk how we can use genomics to support the effort at eliminating malaria. So, unfortunately, all right, is this a pointer? Oh boy. Right, so, yes, I'm not IT savvy, but hey, between 2000 and 2015, we saw a marked reduction in the incidence of malaria, and a lot of things happened during this time. This was a period where Bill and Melinda Gates invested a lot of money and collaborated with WHO, the rollback malaria efforts, to revamp malaria control efforts, specifically looking at vector control. So the use of long-lasting bed nets, indoor residual spraying, and this is the same period where we changed drug policy from chloroquine to the artemisinin-based combination therapy. And so we were declining. And at the same time, the change in policy to the artemisinin-based combination therapy, we saw the emergence of partially resistant parasite to artemisinin. And it is this same period when the gene that is linked with artemisinin resistance was discovered. So by 2015, we saw that this progress that was made had stalled. Why did it stall? Some level of resistance to the drugs. The insecticides that were introduced through the long-lasting bed nets and the indoor residual spraying also became resistant to, the mosquito vector became resistant to these insecticides. And so we saw a stall, and there was donor fatigue. So donors were getting a bit tired of donating to Africa for our control activities, and our health systems needed this funding to sustain what they were doing. Then came COVID-19, which also saw a spike in malaria morbidity. And so now there is some kind of a rebound that we are managing post-COVID. And you see a similar trend with the mortality. So this is the COVID spike. This is the period where activities stagnated or the progress stagnated and the COVID spike. And now we are here. But it's not all gloomy. Over 2.2 billion cases and about 12.7 million deaths were averted between 2000 and 2023 through the efforts that were made. Okay, now look at Ghana. Despite all these challenges, we have chalked a lot of success. Children under 5, you look at the map, the 2011 map, you see how deep it shows morbidity in children under 5. And as you go on in 2022, you see that we have moved from 27.5 to 8.6. This is a marked achievement for a country. Now, at some point, Ghana was considered one of the high-burden countries, 11 high-burden countries. Ghana was part of it. And so we re-strategized in our control activities. We decided, or the recommendation was to use data-driven information to control malaria in these high-burden countries. So we look at the district-level prevalence of malaria, and you see that there are some sites that have very low prevalence of malaria compared to the high prevalence areas. And the interventions were targeted based on these prevalences that you see. So different combinations, and I'll show you some of the interventions that we have. And so, again, data driving what to do for specific sites. So these are some of the interventions: the long-lasting bed nets, spraying, larvicidin. We have our vaccine, which is slowly being rolled out across the country. And then the IPTP, the intermittent treatment for pregnancy, and then seasonal malaria chemo prevention in the savanna areas or areas with seasonal malaria in the country. And our case management with artemisinin and diagnosis. This time we talk about testing before treating. So diagnosis is very key, and this is where we use a rapid diagnostic testing. Now, this is the malaria elimination program's activity, and it's interlaced by research, surveillance, monitoring and evaluation, advocacy, social and behavioral communication, and procurement and supply chain play a key role here. Now, as I said, a lot of things were happening as we're enjoying reduction in malaria. Artemisinin resistance emerged in Southeast Asia. The gene Plasmodium falciparum kelch 13, that is involved in artemisinin resistance, was also discovered through studying the genome. And we found large-scale genomics data. The Malaria Gen Consortium had sequenced a lot of samples, and this reshaped our understanding of malaria genetics. And you see now WHO's technical strategic committee now calling for high resolution surveillance. What does that mean? Going deeper. This is where genomics is becoming important. Now, COVID-19 came in and it drove an expansion of sequencing or genomics across Africa. And formally, between 2022 and 2024, WHO integrated genomics into its elimination framework, which means that genomics, which previously was my career niche, is now becoming a public health intervention. Why? Because genomics is the tool that will help us to, detect early enough resistant parasites, unexpected transmissions, before you see the clinical signs. It is exploring the genome that you can see what is happening, even before it becomes a clinical problem. It gives us that high resolution than what our traditional epidemiology methods would give us. So it's a very good complement for our epidemiological studies. If we embed our genome into our strategies, WHO is now signaling that this molecular data is not just luxury, but it's a necessary innovation as we get to elimination. Because as we eliminate the disease, you are not just interested in clinically positive individuals, but you're interested in every parasite in the population, the reservoir of infection. So you need to have tools that can pick that one parasite that is either imported into a population or whatever it is. Every parasite is important, whether it's clinical or asymptomatic. And this is where genomics becomes important. So this shift also reflects that broader trend of pathogen genomics that we saw with COVID. And now genomics becomes a mainstream tool and not my research niche. I remember when I came back from school, I was the only one talking about genomics, and I was very isolated. Now, today, all my colleagues are applying it in a way. So, what is the genome? I'm not going into genomics 101, but just looking at the nucleus, the cell of the nucleus of the Plasmodium parasite, and teasing out the genetic blueprint, sequencing all the 14 chromosomes on the malaria parasite, we get a 23 megabase genome length. That's 23 million bases, and it has about 5,300 genes, and it's extremely AT rich, and that makes sequencing a huge challenge. And it has hypervariable families that are involved in our immune evasion. And these hypervariable families are found in the subtelomeric regions, which are hotspots for diversity and recombination. So the whole architecture of the malaria parasite genome is very complex. If you compare it to viral DNA or bacterial DNA, they are very, very small and very easy to do a whole genome sequencing. For malaria, it's complex, and therefore, instead of opting for whole genome sequencing, what we do, this can be done, it's difficult, but we normally would target regions of the genome. So these are the 14 chromosomes. You either go whole genome or you do targeted sequencing. So you amplify specific genes or chromosomal regions within the genome, and then you target them, and then you sequence them. And so if you are interested in a gene that is involved in drug resistance, you target it, amplify it, and then you sequence it, and you try to understand what's going on in that gene. Now, how do we leverage the genome of the malaria parasite? We can study mutations within genes or chromosomal regions in the genome. So this is a single mutation, and this mutation could be involved in resistance to a drug. So the malaria parasite is adapting to a drug by mutating the target within its genome. We can look at the genome to develop vaccines. So you look at antigens that may elicit immune responses, and then you use that as target for developing vaccines. We are doing similar with drug development or drug target discovery through studying genes involved in protein or pathways that are specific to the parasites and can be targeted for drug development. If you are interested, we have posters on drug discovery, and we are also using the genome to understand the mechanism of even the artemisinin, our first line drug. Its mechanism of action is not clearly understood. So we are exploring other targets to see whether artemisinin is actually binding to other genes and not just what it's known to be doing. Also another poster that you can explore. Now we can also look at why a hitherto susceptible mosquito has now become resistant to the insecticides. And this would be looking at the genome of the mosquito. Right. We are also interested in looking at the population structure of the parasites. This gives us information on how transmission is ongoing in a population. You may find that here you have different types of parasites moving in a population. You can use it to track movement, where the origin of infections, how it is spreading to other places by looking at the structure. So you see that maybe you test today and you find this type. The next time you find that type in another population within your country, you know that it has moved from here to the other side. So basically giving you information about transmission and also about how interventions are shaping the parasite population. We also look at diversity within individuals. So you are bitten by a mosquito, how many different strains of the parasite did it carry? After a series of interventions, was your intervention, let's say the drug you took, was it able to clear all these strains? Did it leave one? Is that strain that was left resistant to the drug? So studying within host diversity gives us a good idea on the effect of interventions on the population. Now, structural variation. Here there is a break in the DNA sequence. There is a deletion. So if you piece these together, it will give you a shorter sequence from the original one. And this is typically what is happening with our diagnostics using the rapid diagnostic test. The gene or the protein that was targeted for the rapid diagnostic test, which is a histidine rate protein, is sometimes deleted, and therefore we tend to get false negatives when in fact the individual is positive for malaria. Because of the deletion of the gene, you test and you not get the positive results. So these are some of the ways that you can leverage on the genome. Now, it even gets more complex. The parasite's biology is very complex. It moves through the mosquito vector where it undergoes sexual reproduction, and it is during sexual reproduction that there's a lot of recombination. It recombines to get new variants that your immune system is not familiar with, and therefore it's a form of adaptation for its survival within the mosquito. In the human host, it can hide or it stays in the liver for some time and then to the bloodstream, your red blood cells. So in all this, it has to find ways of evading immune responses. And this complex biology, imagine studying a genome like that. And apart from that, you may be infected with a single clone of the parasite when bitten, and then subsequently another bite will introduce other clones. So you become polyclonal, or you can be infected with 2 different clones of the parasite in one bite. So all these makes the malaria parasite's genome very complex to study, and it's big. And so it's expensive, and the data analysis is also very expensive. But we have learned a lot of lessons from COVID. During COVID, people understood what genomics is. Everybody knows what PCR is. We've had labs equipped with sequencing facilities across Africa and extensive training. The only thing is that the skill for doing malaria genomics is not a priority globally. But we are leveraging on these gains from COVID. The establishment of the labs. Noguchi was one of the, or remains one of the regional labs for Africa CDC. And so the story is not all that gloomy. We've been doing some genomics, drug resistance monitoring, diagnostic resistance monitoring, insecticide resistance monitoring, and some vaccine efficacy studies. And these are studies that we have done in collaboration with the National Malaria Elimination Program. The Institute has supported drug resistance diagnostics, insecticide resistance through their activities, and constantly we provide information on the efficacy of the drugs. It started from Professor Kuram's therapeutic efficacy study. He, Professor Buaku, and Professor Nancy Dua championing the genomics or the molecular part of this therapeutic efficacy studies. And they will amplify the genes of interest or genes that are implicated in drug resistance and digest it. It gives you a pattern and you know whether it is a resistant isolate or not. Subsequently, Sanger sequencing, which is a low throughput sequencing approach, has been added to this. And today, we undertake next generation sequencing to support some of the activities that Prof. Buaku and Prof. Nyansi Kwashi are undertaking, all in the bid to look at drug resistance across the sentinel sites of the malaria elimination program. Now, so we know all the genes involved in resistance to various drugs, from chloroquine, amidaquine, pyrimethamine, sulfadoxine, and all that. But of particular interest is the KELCH13 gene and its mutations that have been implicated in artemisinin resistance. So as I said, resistance started in Southeast Asia, and now it has emerged in the Horn of Africa, now East Africa, and is spreading across East Africa. In Ghana, we have also detected the validated KELCH13 gene mutations. So singly across different parts of the country in these sentinel sites of the malaria control program that we are working at. So this is work from Prof. Nancy's group and my own group. Now, we report to the malaria control program. The next thing, but I want to say that artemisinin is still very efficacious. Prof. Buaku will tell you it's 99% efficacious. These have not got any clinical implications, but it's important to monitor these as they have started to rear their faces. This is the deletion of the HRP2 gene involved in diagnostics. So if the gene is deleted, now you test and you get a false negative. And the HRP2 may also stay in circulation even after clearing, so you may get a false positive. And if you are testing non-Plasmodium falciparum, you may also get a false negative. So Professor Amwa at the immunology department and her team have monitored and have observed that some of the false negatives we are getting is a result of the HRP2 deletion, and this is also being monitored and reported to the malaria elimination program. WHO has a cutoff of greater than 5%, after which we will change the drug. Now, our chair, Prof. Dazi, and his team are involved in the insecticide resistant testing. They also monitor genetic changes in the mosquito to see whether they are resisting the insecticides in use. So if you see red, it means there is resistance. So pyrethroids and organochlorine have become resistant. So now they recommend the carbamate and organophosphate, the ones that are showing green and brown. So they monitor and advise the program. Now, we are also interested in the efficacy of the vaccine. The strain, the 3D7 strain that was used to formulate the vaccine, in this study found that in a place like Cape Coast, the circulating parasite formed about 80% of the 3D7 strain. Meanwhile, Navrongo had only about 7% of the circulating parasites identical to the vaccine epitope. And this has huge implications for the efficacy of the vaccine. In another study that we conducted, we found 96 to 98% identity with the vaccine strain. However, the remaining 2%, we found that the variations that occur are within the C-terminal region where the vaccine epitope is designed from. And this makes it monitoring of the diversity of the gene very important, whether you think there are identical strains or not, so that when immune escape variants occur, we will pick it before we lose the vaccine. We are also interested in developing tools. We have come up with a pooling method that will pool samples from sites. You collect about 100 samples into one site, from one site into one tube, and then you sequence it and look for these drug-resistant markers. And we found a very high concordance of about 95% with sequencing individually. And this approach is a very good one for screening. We see a future where we have gotten to malaria elimination and every parasite counts. And therefore, and we can't go around when we have very few parasites to, try and pick them. So this pooling approach will become very important when we get to the elimination stage. We also look at the impact of interventions on the complexity of infection. As I showed you, you may have 3 clones, but after this study looked at spraying with insecticides, we started from 3 clones in individuals, and after a few rounds of IRS spraying, we saw that the population became very clonal, less than 2 clones. So you see how genomics can be used as proxy for transmission intensity after an intervention. We are also interested in looking at the population structure of parasites. These are parasites collected from 3 ecological zones in Ghana: forest, coastal, and savanna. You can see how the coastal forests cluster together, and these kind of studies become important again as you get to elimination. You can actually track the movement of parasites, where parasites came from and how they are spreading, whether there is a hotspot of parasites of importance that we must target. So we are in readiness for the next generation of sequencing. Yes, this work cannot be done just within Ghana. The parasite knows no borders. So networks like the Pathogen Diversity Network across Africa is looking at the diversity of parasites across various African countries. So you see the West African isolates clustering here. This is Central Africa and Ethiopia standing on its own. So parasite describing the history of populations, what has happened, what kind of migrations have occurred. And this network has also looked at signatures of natural selection occurring in the genome of the malaria parasites across Africa. And this becomes a blueprint to study what is going on. Where do we have selection ongoing? What process is it? Is it as a result of a drug pressure? Is it the result of an event that has occurred in a population? So people are now using information from this study to look for diagnostic markers, to look for drug targets, because some signatures have given us indication of what may be happening in the genome. And yes, we've chalked some successes, but there's been challenging. All this is results from research studies. We need to standardize our processes. We need to harmonize our processes. Sometimes we do this work with collaborators, and funders may be interested in the data. So the data sharing becomes a problem. And we have consortium like Pangens, which is trying to standardize operations from sample collection through data analysis. So we are part of Pangens, and we are establishing the standards for these African countries. And interestingly, these countries do not form part of the pDNA network. So these will fill in the gaps for African countries that have not got genomics data. Yeah. In the future, we want to see a dashboard, a very intuitive dashboard that will speak to the control programs, and all they will be interested in is seeing a red spot here, and they ask, what's going on in this area? Is it drug resistance that is rearing its face here? What do we do? Is it a problem now? Should we just continue monitoring? Should we change our drugs? So an intuitive dashboard is what we want to see, which we have started. We need more training, more data toolkits, biologist-friendly analytical pipelines, training, long-term, short-term training in bioinformatics, genomics. We need in-depth ethics, effective communication. Sometimes we talk to the policy makers, and it looks like the language we are speaking is not understood by them. Community engagement, the community itself, we need to engage. We need the funding, the political will. Today, the minister has shown us that there is political will. It's for us to go and hold them to the task to support such activities. So in conclusion, I want to say that the malaria parasite is a formidable force because it's complex. This life cycle, the genetic diversity, the capacity to adapt have slowed our progress towards using genomics, but it's the same complexity that we need to tap into. We now have the expertise, the tools, the vision to transform genomic insights into actionable policy. And this is a requirement by WHO. So by embracing these complexities and not avoiding, we can anticipate resistance, we can safeguard our diagnostics, and ultimately, we can accelerate malaria elimination. So we have the science, we have the evidence, we have the urgency. Now we need to act. As we move from genome to policy, let's be bold enough to transform how Africa fights malaria, using precision data, regional collaboration, and African leadership at the forefront. And Africa CDC is leading this fight by developing a roadmap for genomic surveillance of malaria. which we can all take a look at. I like to acknowledge it's a whole community, our collaborators, past, present, even future, people involved in this effort. Yes, thank you very much.
Yeah, thank you very much, Prof. Anita. So please, I had to make a disclaimer. I had to be a bit generous to my head of department before I lose my job. So I had to give her some extra time so that she can finish her presentation with the agreement of my co-chair. So thank you, Prof. Anita. Now it's time for questions. We have, I think, about 10 minutes for questions. We'll take 5 questions, pressing questions. So any question we are split into 2 presenters. So if you have any question, please address to any of the presenters. Yes, gentlemen. Who has the mic, please? Who has the mic?
Okay, thank you. My first question, I have only one question, but it's directed to Dr. Paul Nyantechi. And please, a big part of your presentation was the total automation of laboratories and how it's emerging. And also, you mentioned some developments for clinical laboratory practice. I would like to ask, what's your view or how you see the clinical laboratory science practice or medical laboratory science practice in being integrated with this emerging technology of total automation systems? And what role you think laboratory scientists will still play if eventually the total automation becomes mainstream and most labs are automated? Thank you.
I think I will address it very simply. I said from experience. Okay, remember the current trend of the education. We know that when it comes to the analytical analysis, it's the medical lab scientist. But then when you are running that in isolation, these results that we produce do not necessarily correlate with clinical picture. So then comes the phase. After they do the lab, how do they decide whether this results or a particular results should be released or not? So what I have been observing, and we practice that in Lancet, because of that we mix medical doctors, about 7 of them now, on the bench for them to discuss the case, to put it into clinical context. Because remember, the way medicine is practiced is you see a clinician, I take a history, I do physical examination, I come up with differential diagnosis, and I select a test. So it cannot be separated. And that is why I feel it's time we do that integration to help the bench medical lab scientists to put into perspective the clinical aspect of the results they are producing. Because at the end of the day, whether your quality systems controls, everything, calibrators, your EQAs are working, there's still random error in laboratory. And you know the statistics, it's 1 in 20. So releasing lab results is hectic if you are not putting them together. Now, I always know when you talk about automation, people think it's about to lose their jobs. No. It's in line. I'm glad you asked these questions in 2 in 1 like that. If you look at what I'm suggesting, it gives, this automation is now giving my lab scientists more time to read, to look at the data, clinical history of these results. If they are always busy and tied on the bench, as soon as the analyzer finishes results, you are ready to go. And it doesn't work that way most of the time. You're going to release wrong results from time to time, false positives. And if you are not very lucky like Lancet, which our own success probably sometimes becomes a case. The doctor will just, oh, this is from Lancet, and then boom, they treat. Everybody forgets that there's 1 in 20 random error, no matter what you do in the lab. And at that point, whether it's automation, total automation, you need the experts, the expertise of looking at a lab results and interpreting it into the clinical picture. Thank you.
Okay, I'm Charles Ochre. So my question that I was going to ask, you partly answered it, because when you mentioned automation, my concern was the economic cost of that, people going to lose their job, but at least partly that is gone. Then let me turn to another cost aspect, because it also needs huge investment. How can other labs also follow your step in investing in this complete automation and the consequence that it will have on their operations? Thank you.
I'm really sorry about that. Yes, it's very, very expensive. And what even we have done at Lancet is not like total. You saw the track was very short. If you want to fully automate it, you're going to link almost every analyzer to it. Currently, we are linking hematology and chempath and endoimmunology. But if you really want to do it, all analyzers from autoimmune diseases, microbiology, and we are doing the automation separately. So it's cost intensive. As to how it can be done, right now my focus is how can we get more funds for research.
Join the club.
Thank you very much.
If you want to ask a question, please raise your hand so that the chair can, ask you to do so.
Yes, I think you can go ahead.
Thank you. Beautiful talk by both speakers. I have a question, 2 very quick questions for Dr. Gansa. The first one is that you mentioned that you're looking at the host variation. And I want to ask how are you studying this? What time points are you sampling? Because when the parasite comes in, there are different variations that you mentioned could exist. And also, it does this recombination that you mentioned. So at what time points are you sampling to know how the host variation is working? And also, you mentioned that you're using Sanger sequencing and you're having the genome is very AT rich. So how are you bypassing this? And if you want to make it very affordable for other research facilities, because Sanger is relatively cheaper as against the others. So how are you doing this as well?
By the vector.
Rich, so forward, solutions for our medical issues. Thank you.
Thank you. I'll take that question first. So, malaria genomics, to me, is an ecosystem. It needs partnership, collaborators, stakeholders like policymakers, the control program itself. Africa CDC is taking a front line in trying to establish malaria genomics across Africa. And so we are talking to developers of tools. They are looking for funding for the data storage. And here, country-specific data protection, data.
Always wanted
Why would a private company give lots of money to scientific researchers to sponsor either research or their meetings? And I'm sure many of you seated here also have asked some of these questions about what is in it for these companies when they sponsor scientific meetings for research. Today we are really privileged to have representatives from all these different key sectors seated here who are going to help us unpack how multi-sector partnerships help in advancing biomedical research in Ghana. Edith Maunya Kutoglu, and together with Ms. Charlene Opong, we are going to be moderating this panel. I want to thank all of you for coming, and especially to our panelists for making time to be here today. And as we begin these discussions, I invite all of you to listen carefully and think about your individual roles, whether as researchers, policymakers, funders, or industry partners in these partnerships. Thank you.
Hello everyone. I will now invite each panelist to introduce themselves, tell us their role and what exactly their organization does in 2 minutes.
Hello everyone. Can you hear me? Yes. We are actually a baby of Noguchi, the director, when we were unveiled just about under 3 years ago, and we've received nothing but support from the Institute as we find our way as a private entity in the research and diagnostic space.
Yeah, good afternoon. My name is Holger Till. I'm a medical doctor, and actually I started my career as a doctor here in Ghana, working for 12 years in Agogo at Ridge Hospital. I was at Kolebu at the cardiothoracic unit. Dr. Noguchi talked about Lancet 1997. I was actually opposite. We were working with Professor Frimpong Boateng at the cardiothoracic unit. So I started as a medical doctor, and now I'm a program manager and working for the German Development Corporation, GIZ, and we are classical development partners, meaning that we are funded by the German ministry and also by the European Union.
In the country, there are a lot of tools to diagnose diseases and a host of that. Thank you.
My name is Derek Romeo Adugla. I am the head of communications for Stanbic Bank Ghana. And today I've heard a lot about funding, money. Yeah. It's, so basically, I mean, we are the largest bank in Africa.
Push a fax through a machine, and you would, you know, it would take you 10 minutes, it would cost you a lot of money, and then you would wonder, has it actually arrived? There would be a beep. It was like, you didn't know whether it arrived or not. Now you communicate with people, you know, we communicate.
How can this be done? And this is how it started with the vaccine committee led by Professor Frimpong Boateng at this time. And then the national vaccine, we had Dr. Sochi here today, came out. And then based on this, we were looking, okay, how can it be supported? And if you want to do local vaccine production, it is an ecosystem strengthening approach. And it is not only, it is one, you need to have skilled workers, you need to have definitely a good governance structure, you need to have a good regulator, like we have here in Ghana. FDA, I think, is the best one in Africa, I would say. You need a strong private sector, need a strong R&D community. So therefore, this is our motivation, because it will never work to support Ghana to produce their own vaccines. And also, of course, we also look at the win-win situation, because we also look at the interest of, in our case, in Germany, of Europe, and through partnership, how can this be done that vaccines will be produced, and therefore is crucial to work together with with research institutions. And if you talk about research institutions, our interest is not to look at research institutions as silos, not only looking at Noguchi or VACPIP or KCCR or UHAS, to find a way how the collaboration between the different research institutions can be strengthened. And I think this is something we try to collaborate. And I just, one last sentence, we are not here to impose at all. We are here to work together and strengthen the systems.
Thank you very much for highlighting the importance of collaboration with researchers to bring advanced research and biomedical innovations. And so that brings me to the value researchers bring to the commercial space. Mr. Atule, please, what is the biggest value you think that researchers bring to the commercial space?
Thank you so much for the question. Over the years, business has actually thrived through the data that comes from the research space. Without research, I wouldn't know what the manufacturers will be doing. And I think that researchers play a very important role in using the tools and the solutions that the manufacturers produce. They actually help to validate these tools that the manufacturers make. Every tool is unique to a particular geographical area. So for instance, we have an equipment that is made for Africa based on its sensitivity and parameters, based on conditions and diseases that are prevalent in the particular geographical area. And so how do we get this data? It comes from research. So I think research has really played a very crucial role to improve the business industry of the biomedical sector.
Thank you very much. I'm sure most of the researchers seated here are quite happy to hear that their research data helps in informing policy and also production, so that's quite important to hear. And that brings me to the next. Most of us think when people sponsor scientific meetings, it's just about visibility. So Mr. Adogla, you are from a financial institution, so maybe you help clarify this. How does your company balance its commercial objectives with broader social impact?
Right, thanks for the question. I think for Stanbic Bank, one of our core focus areas is the people we serve, our clients, and the population generally. And so when we say, Ghana is our home, we drive her growth, who are you growing for? You're growing for the people, right? They are the center of it. And what makes people tick? It's, healthcare, social amenities, the things that they require, very basic things. And how do you get that done? You do that through, research, innovation, and what have you. And so in our corporate social investment policy, two of our core focus areas are in education and healthcare. And what you do, what Noguchi does, falls directly within these two. I mean, you're an educational institution in research, but you're also tilted towards healthcare. And we believe that through the research that you do, through the work that you do, you bring some level of comfort to people, right? And so there's a very important part of the work that it's altruistic, making sure that our clients, through the work and the support that we give them, are able to impact our society the way we should as a business. Because if it's just about being out there making the money, who are the people bringing in the money if everybody's dying, really? So at the heart of it is making sure that our people feel supported, have the right opportunities, are given all the leverage they need to be the best that they can be. Because as a bank, we pride ourselves in the quality of our customers, right? Of our people. And we expect that they should be in a position where they are able to support themselves, be financially independent, and do great things. And that is one of the reasons why we support the events such as that. And we've done this over the years. But don't get it twisted. We also need you to be part of the journey that we're on, right? Growing Ghana's progress, if you like, pushing Ghana's development and making sure that Ghana is where it's supposed to be. And as a Pan-African bank, we are first and foremost who we are as a people, driving our own growth, being independent-minded, and supporting our financial growth together, which is one of the main reasons why we're here. Thank you.
Thank you. It's so comforting to know that you are not just funding scientific research for the sake of visibility, but also you care about how people feel and also improving the lifestyle of people. So that's really comforting. And as we've all already heard, these partnerships are really important to advance research, but there are also some challenges. So I would ask Dr. Akpalio, I would like to hear from you. What are some of the challenges companies face in sponsoring biomedical research in Ghana?
Thank you for that. I think that especially if you're a private sector biomedical research company, your challenges are actually a bit more as well in some instances, but there are opportunities unique as well. Some of them, obviously, everyone's talking about the money bit of it. There is that, especially if you're nascent in the space where everyone's going to ask institutionally, what is your track record? Who's going to take that first leap of faith with you from a finance or investment perspective? But fortunately, GIZ is sitting next to me, but I can say that we've been fortunate enough to have opportunities with the likes of GIZ through developmental funding. We actually were successful twice in the same calendar year last year through a developmental funding opportunity. And what that meant was that unlike your classical academic research grant options, these were actually target specific from a developmental perspective. Okay, we're going to give you, let's say, 100 CDs, and what do you expect to be able to do with that 100 CDs? As opposed to solve a research question and then publish and go from there. So on the private sector side of things, these are the ways we look at it, because the goal there is sustainability. You can't always cap in hand go asking for funding. And as a private entity, you want to quickly get to your independence as possible. So for us, funding opportunities have to be similar to what we've just gotten, where it's target specific, and that's how we have to think about it. But then there's also the other part. If you're a cutting-edge entity doing precision medicine, we say this and people ask the question. I've had people, former colleagues of mine, even in the industry in the US, ask, Derek, are you sure you're going to be able to do this? Precision medicine in Ghana, you must be mad. But we're doing it. And the you must be mad aspect of it is something that I would have also said 6 years ago when I was in my role in J&J running clinical trials around the globe. Because there are standards that need to be maintained, and you need that validation. It's a trust space, and you have to earn that stripe every day. What you did yesterday matters not. It's what you're doing today. So for us, again, it's that evidence of stripes. How do you demonstrate that? It was why I started off with the introduction of the company as saying that we are the only entity in the region that's dual ISO accredited by the American Association of Laboratory Accreditations. And I was saying that just to establish the fact that yes, we can attain those standards right here at the first go, but importantly that what we're doing has that sustainability part, the public health aspect of it. But then once you have that, there's also the question of, do you have the skill set to be able to do that? Because again, right now in the Revna lab at this very moment, we're running NGS tests to inform treatment for pediatrics in real life today, right now. Do we have the equipment? Forget the equipment. Do you have the skill set to be able to, one, generate quality data, two, notice that the data you're going to get will be first bioinformatic data. It's not clinical information, especially if you're using it in real time to help clinical decision making. Do you have the skill set or the tools to be able to do that conversion in real time where bioinformatic insights are being converted into clinical genomic insights or clinical insights to help with that. Yes, so that's another challenge. And of course, as you're doing all of this, we have a very progressive regulatory body in the country, but they also have to keep up, because every time you bring in a new technology, it's a new challenge, it's a new experience in some instances if the institution hasn't had the chance or the opportunity yet to evaluate that platform. So you're constantly, sort of having this tag in a way where, as you're trying to advance, you also have to essentially have these entities and allied bodies go with you. And then there's the obvious one that's kind of mentioned earlier on in the day as well, where even importation of stuff is a problem, because everything we do from a precision medicine part of it is imported. Now let me just put it into context quickly and then hand the mic over. Revna Biosciences is a Ghanaian entity with US locations as well. If we order anything, call it a sequencer, for a US location and the Ghana location, by the time the equipment gets to the Ghana office, it's about 30–40% more expensive than the one in the US because of our import tax situations. Now, what do I do with that? As a scientist, there's the altruistic part of me, but I'm also a business. I have payroll to take care of, 50 employees we have right now to take care of. When you have a situation like this, what happens? You end up having to transfer these costs to the end user when, and these are some of the challenges there. And I can go on, but at least you get an idea of some of the challenges we have to go sort of deal with. So we're a bit selective about the research we do, because oftentimes the targets have to be ones that bring return quickly. We have to be solutions oriented as opposed to sometimes knowledge based. What do I mean by that? We did a collaboration with QIAGEN, for instance, on molecular assays for malaria, PCR based assays. This was one of those that was timely, opportunistic at the time, but also with the mindset of the commercial value beyond the impact as well. So there's the impact, but as a business, I also have to think of how do we translate that into a commercial way so that we can be sustainable, and as we're sustainable, solve other problems as well.
Thank you very much. I'm sure if I ask the room who can relate to these challenges that Dr. Kwali is talking about, all hands will go up. We can all relate to these challenges, and that's why this conversation is really important today. So I'll go to the last question, Mr. Grant. Caramo has been instrumental in supporting global health and development research through strategic partnerships. From your experience, what are the key ingredients that make research successful and sustainable, particularly in low and middle income countries?
I think the primary thing is the scientific leaders. I think scientific leaders who are well connected, so partly from where they've actually done their training, where they're here, or how they've been connected internationally. So the scientific leaders, how they can lead by example, how they can mentor people, how they can change the environment and connect with their own government so that they can make things happen which some politicians had not realized was a thing. So I think that's absolutely key, and it isn't really a low middle income country. I think that applies to any scientific research. I think the difference here is that you have to do more planning. When you're in a country where the products are readily available, as was said before, they're readily available and they can come in. It's not always in a few days. There are manufacturers who take weeks, sometimes months to produce, to turn around either do their manufacturing or bring the things into the right location. So it's not all completely smooth. It's not chalk and cheese, but the difference is you have to plan, because you're bringing in you can't be changing things on the fly and expecting to be able to then carry on with that work, because there is a longer process. The issue about importation, so Noguchi is You know, a couple of years ago, 3 years ago nearly now, the government took away all the exemptions from all the institutions here. And Noguchi, you know, struggled very hard and won a full exemption. Most of the other institutions have partial exemptions, so there's a cost even on the research. So even though the minister will say that they're supporting, they're then using it as a means of obtaining tax. And that's even true for Noguchi. So even though you get a full exemption, there's still a number of taxes. I think Ghana is probably at the top of the league in terms of the number of taxes that they apply to an import. I mean, it virtually runs, with single lines, it virtually runs onto a second A4 page of different taxes. And at one point, you know, I think there were 3 COVID taxes, 3 different levies, small amounts, but just one thing after another, and it all adds up. So that is a cost element. You know, and the problem is even when Noguchi has an exemption, they don't sign it off. So your time period just extends and extends and extends. And that's a problem for a supplier because you buy products and you have to document a shipment for them to start the process, but products have expiry dates and you know, what do you do? Because you documented it with lot numbers, so that's a complication. So that's a complication you have here, and I think that's probably, these days with the way that communication has opened things up. So at the beginning when we were working here, you know, Ghana was relatively isolated. You know, you had to pick up a phone. It all costs money. Now everybody can communicate in a way, and people travel in a way that they didn't do before. So I think there's less difference. The difference is the barriers that the government puts in to bringing products in. Yeah, and used import basically as a source of income because it's a very fixed thing. You know, there's a lot of grey market out there and they can't access that tax. So imports, well, we know what that is. We can tax it.
Thank you so much for pointing out these points. I wish the minister was still here to hear this, especially the one about the taxes for researchers, because it's a big problem that we are facing. So I want to thank all the panelists for the first round of questions where we explored the motivations and the value proposition and also some of the challenges. So we'll now move to the second round where we'll talk about expectations and real world practice in multi-sector partnerships. So I'll start again with Dr. Thiel. How does your organization ensure that sponsorship goes beyond branding and contributes to Ghana's efforts in advancing pharmaceutical manufacturing?
Okay, I think to support pharmaceutical production is already our core business, but more important is how can this be kept on the high political agenda? Because as we all know, funding is for development cooperation is going down. I don't want to mention organizations like USAID and others who are no more present here. And therefore, and even now looking at development funds, there's a competition on development funds. So now, how can this be addressed to support here in Ghana pharmaceutical and vaccine production is, I think, just jointly to be successful. This is what we have to be. We have to be successful, and if we are able to show that what has been said before, that we are not only talking and talking and talking, but then that there are really vaccines being produced here, then we have something to show. If you can show that Ghana is now a regional hub for pharmaceutical production, which has been already announced also, then we are already, then we are there where we want to be. But I also have to really commend the Ghanaian government for its role, because just recently at the National Investment Forum, the president committed $50 million for vaccine production. And this is a lot of money and it's a lot of commitment. And this also helps again now, you know, if we speak now with the European Union, if you speak with the German ministry, they have much more confidence in invest more in this type of programs. And this is our role as a technical partner to make sure together with the Ghanaian partner, we make sure that the program is successful. And then I think this is the way we have to go for. And maybe one more comment is also, it is the importance of partnerships and public-private partnerships. And we should not only look at health as a social team. We have to look at also at the economic economic team, and this, I think, we are here sitting so many economic guys, left and right, and if we are able to marry social values, social outcomes with economic issues, I think then we are on the right way. Thank you.
Thank you very much for emphasizing that GIZ is really interested to see vaccines being produced in Ghana, and you're not just funding for the branding part of it. Thank you very much. And now I'd like to hear from Mr. Tule. What do you see as the main barriers preventing stronger partnerships between academic researchers and private companies?
Thank you for the question. Yeah. So we all know that research is time-bound, and we don't make them. The manufacturers we don't make them. The manufacturers themselves also do not make some of these things down for them to ship to you immediately they receive your payment. They need time to prepare the items. So you look at the time from where we as a private vendor makes payment to a manufacturer, and the time they receive the payment, the time they actually prepare the item for export. There are a lot of documentation that requires to be prepared for export. All these documentations are set. The shipment is dispatched. It gets to Ghana. It takes a long time for you to get it out of customs. All this takes time. From my own opinion, I think that if private companies like vendors like LabMat is being involved during the planning stage of the project, it will really help fast track the delivery and to provide the logistics that is required for the research at the end of the day. Every research is time bound. You need the items to work with. How do you get them? A researcher is working, they have run out of cell culture reagents. How do they get them? I mean, if we work closely with the researchers at the end of the day, we'll be able to understand, what are you working on? I know that Professor A is working on a project that requires, let's say, fetal bovine serum or RPMI or any of the medium. These are items that have very limited shelf life at the end of the day. If we keep them in stock and we are not sure that Professor A is coming for it, at the end of the day, I mean, it looks like juice, but we can't drink it. Yes. So we need to work closely together at the end of the day. If I know that in Q4, Prof would need these items, I add you to my forecast at the end of the day. When I'm bringing cell culture products, I add your stuff to it. When your PO comes, we just deliver the items to you. There are instances where a researcher runs out of cell culture reagents and they call, Richard, I need RPMI. So if we don't have, what happens? You lose your entire cell lines. And that's a lot of work that's have gone in there at the end of the day. So I think that if we're able to leverage on the partnership between the research and the private sector, at the end of the day, we would all be able to come together to see how can the private institution like LabMat help your project to thrive at the end of the day. Today we are here at the ARM. We are one of the sponsors of the ARM. Why are we doing this? We are doing this to help you achieve your project objectives at the end of the day. When you achieve your project objectives, I mean, this is what keeps us alive. But if you don't achieve your project objectives, we are off. Who are we supplying to? No one. So it's a win-win situation at the end of the day. So for me, I think we should leverage more on communication, timely engagement, and we should look at involving the private sector in our project planning at the end of the day. Thank you.
Thank you very much. I think I'm guilty of blaming suppliers for bringing my stuff late. And most of us here have done that at one point in time. So thank you very much for raising this point. And now we'll move to the next question about expectations. And I would like to ask Mr. Adogla, since you are from the financial institution, what are your expectations when you sponsor biomedical research meetings?
Thank you very much. I think that at the heart of every sponsorship is impact, right? We hold people's monies in trust, and they believe that those monies are being used for the right things and for impactful things. Because when we go back to them and say, look, in 2024, in 2025, this is what we did with the trust that you had in us, you are likely to get a lot more coming in. So for us, it's really about impact. Recently, we were in Ho to support the Ho teaching hospital. Apparently, they had a department that was if you like, promoting medical tourism. And it was a first of its kind of a sort, right? So we went in there, Stanbic went in there, looked at, the support that we could give and delivered. Now, what they have done with their medical support for the community is to add a layer on top of that, which is the tourism aspect, that people can come and have medical, services and have everything else on top of that, like an icing on a cake, right? For us, that is impact. You go beyond what you set to do and ensure that what you have actually told your people that you're going to do, you deliver on them. And for Stanbic, that is one of the things that we drum home, even amongst our staff, that when you are dealing with your customers, you know that you have told them that you have to deliver something, right, of a certain quality at a certain time. You need to follow through on that, because immediately you miss those targets, then obviously the next time I'm coming to you, I'll think twice, right? It's like somebody who goes to the restaurant to get fufu and is served with abetia, right? They come from the same source, don't they? But they are different. They look different as well. So at the heart of it, give us impact. If we support Noguchi and you consistently deliver impact, you have. Because we believe that what Noguchi has done over the years, driving, biomedical research, if we had more funding coming in, they could do some more. And obviously I'm not a biomedical scientist, but prior to coming here, I just wanted to understand the level of funding that is available globally, right? And you would notice that between 2020, 2024 or thereabout, every year globally, the funding that has gone into biomedical science research is around, north of $70 billion. And then you dial back and look at how much of that goes into Africa, and you see that just about under 2% comes into Africa. And then if you narrow it into Ghana, then you know we're in trouble, right? But we need to understand that research offers impact. More so, medical research offers impact to our population. And we've seen all the conversations that have taken place today. Professor Genome, at least, give us some more. I'm calling her Professor Genome. I'm in trouble, but I'll take it. But essentially, at the heart of it is you want the best of your brains to do the research, but they should be able to do that with the necessary funding and the backing to deliver quality, so that can morph into something valuable. Over and above biomedical research, we, as a bank, we have customers in food and nutrition science, processing, and all that. And all these people engage in some level of research to be able to, deliver their products to the market. The best ways to actually get there is to have the right funding, the right financial advisory services, and for us, that is how we balance it. It's a business relationship, but it's also a partnership of a sort, that we're able to offer you the best advice, because in the end, if you thrive, the bank thrives. But ultimately, the nation thrives and the people around you thrive. And for us, that is critical. That is really critical.
Thank you very much. I come from Ho, and I've seen that news article about Stanbic Bank donating to Ho. So I think I'm really happy to know that you are really about the impact and not just the branding. Thank you. And that brings another fundamental problem. Many of us seated here will attest to the fact that We wish to see our research results being turned into products, but most of the time there is a barrier. And so, Dr. Akpale, I would like to hear from you. Sorry. In your opinion, what are the key ingredients needed to successfully translate research findings into market-ready biomedical products?
I think for us, or for me, the answer is very simple. If the focus is solutions-based, what question are you trying to answer? What problem are you trying to solve? If that question is asked with the scientific rigor that you need and backed with the right pace, then it's likely to be of good commercial value. And I use that word here loosely, where commercial value is you're solving that problem, you're providing the impact, and from an IP perspective, intellectual property perspective, that becomes a marketable tool. So for us on the Revna Biosciences side, that is what actually drives us. What problem are we trying to solve? Why hasn't it been solved? And why now? If you go through that process, you will have solutions that become, one, impactful, because we all use the word impact, but what is really impact, right? There's a utility to it, there's a timeliness to it, and that relevance as well. And if you can check those boxes, oftentimes I say to the team, don't think of research or the money or the investment that goes into research as sunk cost. It isn't. It's an investment into that's something you can leverage, and basically we see this as we're beginning to build disease models where we funded research activities or collaborated with partners to solve a problem, and now you're getting these phone calls saying, hey, Revna, this issue is becoming a bit more urgent. How quickly can we get this out of the research phase to that? So for us, it's about doing those things that allow you to translate very quickly from the bench side, so to speak, to the market. If you're solving real problems, oftentimes the commercial aspect of it will take care of itself. And this was a lesson that I learned in the industry, where it was basically this: where clinical goes, commercial goes. Essentially, if the clinicians, the researchers, the scientists solve the right questions, the commercial people will find a way to commercialize it. And that's my response to that.
Yeah, thank you very much for outlining those critical elements. And Mr. Grant, given Karamo's long-standing commitment, how are you positioning yourself to support the next wave of innovation, especially in tech and data-driven research in Africa? Especially in technology and data-driven research.
So it's a complicated field. I mean, there are so many vendors. What we do is there's a number of us as scientists on the commercial side dealing with the quotations. So what we're doing is partly in combination with the customers, where the customers are coming to us with a new innovation that they've read about, or there's been a paper, or they've been at a conference and there's been a discussion. So what we're doing is using that information alongside those conversations that we have with our vendors, and them telling us about their new applications, their new instruments. And a good example was Nanopore. So Nanopore, we came to Nanopore, both we came to them and they came to us, partly through some of our existing customers who were exploring that technology in sort of 2017, not long after they actually commercialized their first, the first MinION. And there were lots of issues going on, and a number of customers had suggested that they approach us. We then had a long conversation, and because they're quite legalistic and looking at IP, took about a year and a half to form an agreement, and that was obviously quite crucial, that relationship. We started saying we will deal with that technology into a number of countries, which was going to include Ghana, That was the end of 2019, and then of course the pandemic arrived, and all bets were off, and it just went crazy. And at the same time, the problem was that not so much the nanopore supply. They were ready for that. It was all the other consumables and products that go alongside the technology. That was the challenge during the pandemic. So it's this combination of talking to existing vendors about what they're doing, so understanding where we can actually potentially suggest, a product to a customer, or it's customers coming to us and us exploring that technology and connecting with a new vendor. So we're not tied. We're adding vendors all the time, and that's really just part of the process. And who knows where it goes.
Thank you very much. Please, let's thank our panelists for this second round of discussion. Thank you.
Thank you. We are almost at the end of our session, but I think I'll invite our MC, Christopher Vanna, to give a brief announcement.
Hello. Yes. Thank you so much for staying with us all this while. We are grateful. We understand some people have issues with posters. So if you have an issue mounting your poster, kindly visit the registration desk downstairs to mount your poster just before we go for lunch. Please don't forget to do that. Right after here, we'll be having lunch. There will be breakout sessions at 3 different areas. We have the West Africa Genomic Center here just behind us. Then we have the seminar room here, and then a combined seminar room as well. Then there are QR codes that have been posted around the wall in the seminar room here. Kindly scan for the book of abstract as well. Then in order not to miss your emails and send a text message or WhatsApp, kindly connect to our Wi-Fi at ARM 2025. You can see the passwords just around the wall. Thank you so much.
Thank you. So I will now ask the last question in this session. And we just want to know, how do our panelists today see the role of sponsors in biomedical research evolving in the next couple of years in 2 minutes? So please, Dr.
Yes, I'm lucky. Yes. I get to pick. and the answers run out. Anyway, so based on how things have gone, especially even looking at the geopolitics around, we mentioned, some of these legacy funding entities that have literally disappeared in 2025. There are alternate models that are springing up that we all need to look at. What we're seeing is a shift, one, towards the more milestone-based, results-oriented kind of funding model where, okay, this is the total amount, these are the timelines, but we want that developmental impact measurable in phases. So as you earn or as you make those, you get more, you keep going till you get to the end. So there is that. But what you also find is that there's the need, or there's a drive towards a bit more of sustainability. So you're finding that funders are no longer being philanthropic in that sense. They're participating a bit more in co-development of the projects. They're also vested in measurables, the sustainability of it as well. So basically, how scalable is what you're doing in its instance, and then also that sustainability part of it, which is not just academic. What are you solving, and how is that then used to do something else? For instance, the GIZ is pushing very hard on the vaccine development role. What would a Revna or a Noguchi do in that space? There's a whole lot of life sciences that goes in there. What projects are we picking? What questions are we trying to answer that others in that space can then pick and then run with? So there is a bit more of intentionality in terms of how they're funding, and a bit more obligation on awardees to actually put those funds to good use as well. So I think I'll stop there and leave it.
Okay, I will actually not go so much in answering your question, but I will just mention one topic and do one announcement, if you don't mind. But it's an example also where Noguchi is involved. I think what is very important, if you look at research and also the future of research, especially now and I think it's not only in the area of vaccine and pharma production, is the importance how research institutions are working together with the private sector. And and I just give you an example from our PharmaVax program. We did a so-called call for proposal where research institutions were invited to bring their proposals, but there was a condition. There has to be a key partner from the private sector. If not, your whole proposal will be definitely not even considered. So after the call for proposal, there were 43 proposals, and out of them were 31, if I'm not mistaken, 31 which were eligible. Very good quality, and now it's coming as an announcement. So you might ask, was Noguchi successful, yes or no? I don't know how the answer will be, but of course they were successful. So, and this is, for instance, it is an initiative where Noguchi, and I can even mention it here, is partnering together with Atlantic Life Science, which is one of the vaccine producing companies. I think they brought a proposal over 500,000 euro in the area of tetanus, diphtheria, as vaccine stability testing. So now, of course, it has to go through a commercial eligibility test, and if it's positive, then this project can move on, and this could contribute directly to what is at the end. The aim is that a local vaccine can be produced here in Ghana, which would be the first one. So this is one example, and congratulations to Noguchi, by the way. Thank you.
Okay, thank you so much. Thank you. Yes, so thank you for the question. I want to speak briefly about the involvement of the private sector in supporting research in Ghana. And we all know that beginning last year, the funding space has become a bit shady, and that makes it very difficult for researchers to be able to come up with enough resources to be able to purchase all the logistics and to conduct the activities that they are supposed to conduct. Now the big question is, what will be the role of the private sector, the private partners that are working with the research institutions? What value can they add to these institutions to enable them or to empower them to be able to achieve their objectives? And this is why we are all gathered here at the ARM 2025. And this is why we have taken the initiative to support Noguchi in the ARM 2025. We know that Noguchi has several projects, and in each of the projects you have your funding under it, but each funding has an objective. I don't think there is any of the objectives that states that you should use part of that funds for ARM 2025. So we believe that, yes, you empower us, we also have to help you achieve your project objectives in the little way that we can at the end of the day. And then lastly also, I want to talk briefly about student projects and the impact that LabMat is also creating on students' projects. I think we talk about scientists, we talk about innovations, but we forget that all these happens when these young scientists are being groomed to a certain stage. What are we doing for these young scientists at the end of the day? To be honest with you, when you enter the labs of Noguchi, you see innovative instruments, high-end equipment. Trust me, there are a lot of institutions in the country that you enter, not even a centrifuge. A centrifuge, you will not even find a centrifuge in the lab. But they are doing biomedical laboratory science. You go and sit on the lab bench in the lab, go through a session, and come out. No practicals, nothing. So LabMats, it's actually working closely with students to be able to assist them with their projects at the end of the day. Sometimes students have very innovative topics at the end of the day, but How do you come up with logistics to be able to achieve those objectives? And sometimes they don't even know what it takes to be able to run or to be able to complete that particular project at the end of the day. They select the topic, the tools that is required, their institution doesn't have it, the reagents that is required, they don't have the resources to be able to purchase those reagents. How do we come in to assist? We have a team in-house that is able to work closely with students to understand what is your project objectives, what logistics do you need, and we check internally to see which of the many vendors that we partner with would be able to provide that particular reagent or product at a reasonable cost for the student to be able to afford at the end of the day. We think that this is the little way that we can also impact science generally. And in the end, we all produce the future generation of the scientists that we are actually aiming for. Thank you.
Thank you very much. If this was a classroom setting, I would have said, they said everything, so that's it for me. How many of us in here have a relationship with Stanbic Bank? Okay. Yeah, not that bad. At least there are people here. But there's room for improvement. Before I end, I'll invite you over. So to your question, I think that going forward, sponsors are going to be looking at two critical things. It will be based on values-driven partnership. So we will not step out there to sponsor anything or everything just because it's for the public good. But is it values-driven? Are you doing what you're doing based on a certain level of belief, passion, and drive? If that connects, those values connect with ours, I believe that that is how the world is navigating towards, because we want to drive things that meet our expectations. Recently, we did some work around our sustainability team or unit, and the focus was, in spite of the fact that we've done a lot of work over the years, we want to pivot around the things that matter to us. And the things that matter to us are things that help drive Ghana's growth, pure and simple. So if you're doing whatever research, whatever ideas you're running with, it must be around the values that we share in common, right? The other thing for me is about big data. Now, research cannot sit away from big data because they speak to each other. And we will drive sponsorship based on what the data says about what it is that you want to drive. Is what you want to implement, feasible in the long term? What do we hope to see, or what kind of value do you expect to see? There would be a lot of computation. We just want to make sure, and I'm speaking as a potential sponsor in the future. I want to see real value, looking at the values that you present as an entity, and then also around the data that supports the work that you do. And then I believe that we would both see value together. At the heart of it all, I want to invite all of you, those who are not yet, having a relationship with Stanbic Bank, please. From here, we have a branch on campus. Try and visit them, and I believe you will smile. Thank you very much.
Yeah, I agree. Much of it has been said. I mean, the environment has changed. So, I mean, I remember 10 years ago, nobody asked for sponsorship. The Gates Foundation, the Wellcome Trust, they sponsored it, And it was only later on that they suddenly realised that there was an opportunity, or that part of the funding, and was how are we going to do it? And so given that the funding environment has changed so radically this year, I was at a meeting in June with Gates and Wellcome Trust. They cannot make up that gap. They're being asked to do that, but they're going to reprioritise because they can't fill that space. That face is too big, and it's obviously affected Gavi. It's affected WHO. So it's really affected the space. So I think it just means that yes, you need to talk to your sponsors. You need to talk to commercial companies, but even in your research sort of ideas, you need to be more spread out. I mean, those, probably, Noguchi is probably, lucky in the sense that it's not so massively embedded in the United States, but those people that were very embedded in that, this is a year of crisis, and some people are lucky if they've still got their jobs. You're in a, not in such a difficult position, but it is a difficult time, and commercial sponsors obviously a way to allow you to be able to run events as good as this, with that support. So, but in terms of your research side, you need to be spread out, in terms of your funders, because who knows what thing will happen next.
Thank you very much to our panelists. This has been very insightful. I'm sure all of us here have heard a lot of information, but I think what we can take home today is the idea of collaboration. We've heard a lot of things about collaboration, involving partners more, like from the inception to the very end. We've learned a lot about being intentional about the type of science that you are doing, and I hope that as all of us are sitting here today, we've taken something from this panel which will help us in our future endeavors. Thank you very much again to our panelists, and have a good rest of your day.
All right, thank you so much, Charlene and Edith. We are so grateful for the opportunity. And to all our panelists, thank you once again. Thank you so much. Please, we are not done. We are not done yet. Kindly take a seat. Yes, right after here, there's lunch, and the lunch is combined with poster session as well. You heard from the organizing committee that there are going to be awards. So if you have a poster, kindly make sure you grab your food quickly, and kindly make sure you stand by your poster, because someone may come and talk to you. And lunch is only 40 minutes. So please kindly grab your lunch quickly and get to the poster session as well. And like I said, right after lunch, there are going to be breakout sessions. We have the main conference room here, the combined seminar room, and just behind us at WACMEC, the ushers are going to direct us, those going to WACMEC, those going to the conference room, or even the combined seminar room. And if you are chairing a session, please check to see where you belong. And also what interests you, the kind of research that interests you, kindly make sure that you go to the right room for that particular session. Thank you so much, and see you at lunchtime. Thank you.
Team, what do you think about our upcoming debate?
All right, so we are excited about this debate. This forms part of the 25th anniversary celebration of the College of Health Sciences, and we are gearing up for this debate.
Team Hollywood is truly excited. We know we are going to win. We are surely going to prove that digital healthcare will widen the equity gap.
And even as we win this debate, it's not just a victory for us, but a wake-up call to Africa to start building real foundations for our healthcare.
Yes, it's going to be exciting, insightful, and I'm excited because the points we are going to turn out will shape how healthcare is delivered on our continent for many years to come.
Digital health will certainly widen the healthcare equity gap in Africa, and there are lots of insights to be revealed from this debate.
The debate comes off on Thursday, the 27th of November at 2 p.m. at the Great Hall of the University of Ghana campus, Legon. See you there.
Hi everyone. As part of the University of Ghana's College of Health Sciences 25th anniversary celebrations, there's going to be a grand debate on the topic, digital health will widen rather than bridge Africa's healthcare equity gap. And we are against the motion. As lead, my name is Dr. Lily Pemka. I'm the Deputy Director at the West African Genetic Medicine Center. I'm a molecular geneticist.
And my name is Dr. Justice Kumi, a supporting speaker from the Noguchi Memorial Institute for Medical Research, and I'm a toxicologist.
And I am Dr. Nana Amamrukujima from the School of Pharmacy, and I'm a natural products researcher.
I am Dr. Constance Agbemolutumafu from the Noguchi Memorial Institute for Medical Research. I'm a molecular biologist, and I'm a supporting speaker.
And we are
Team Legon. This debate is happening at the Great Hall on the 27th of November 2025 at 2 p.m.
Come, let's have fun. Come and let's learn digital health from Ghana to Africa and beyond to all parts of the world. And we know that we are winning. Catch you there.
Come and be wild.
We are winning.
We are winning. We are winning.
I welcome you to the 10th annual research meeting of the Noguchi Memorial Institute for Medical Research, College of Health Sciences, University of Ghana. This year we have a lot for you, and the theme for our annual research meeting is Advancing Healthcare Through Impactful Research and Innovations. This ties in very well with what we are doing. Noguchi, we support health delivery not only in Ghana, but in the sub-region. We employ you to join us. We have innovative speakers who are going to speak about their innovative research, antimicrobial resistance. Why is that you go to hospital and they give you all the antibiotics, but you are not responding? Please come, get understanding. How do we prevent the spread of antimicrobial resistance? Please, there are so much information for you. Malaria, is it coming down? Is it going up? We are there. Come. Innovative solutions, drug discovery, diagnostics. So I'm employing you. Come, join us. 25th, 26th. It is not going to be science alone. We are going to have fun. We are inviting all school children. We are going to open the doors of Noguchi. Come and look at all the machines you heard about. JHS, whether you are in primary school, secondary, tertiary, the Noguchi doors will be open to you. Come and look at innovative, the infrastructure that you've been dreaming about. Come and listen to our impactful research that is making waves across Ghana and the sub-region. For Noguchi, there's nothing but quality research.
Hello, my name is Professor Chijo Komiti Souza. I am from the Noguchi Memorial Institute for Medical Research. I'm the co-chair with Professor Kodjo Sabakusi running this year's annual research meeting of the Institute. This is our 10th annual research meeting, which also coincides with the 25th anniversary of the College of Health Sciences. So this research meeting is being organized together with all other constituents of the College of Health Sciences, bringing together all the scientists to showcase the work that we have been doing.
The theme for this year's annual research meeting is advancing healthcare through impactful research and innovation, and we are having this program from the 25th to the 27th of November 2025. We are having on the first day a keynote to be delivered by one of our own, Professor Beverly Ejim, who will be speaking on her work in AMR. We will have, as part of that day, also a panel discussion where we would have some of our sponsors who would speak about the impact of private-public partnerships in promoting research and innovation. Our parallel sessions happening in the afternoon to bring the first day to an end. On the second day, we begin the day with a symposium, a special symposium by AMEC, that is a JICA-funded program that is based at Noguchi. They were having a one-hour symposium to talk about some of the research that they have conducted over the past years. And then we would have our poster sessions beginning with a table session where selected posters will have 2 minutes to pitch their ideas and invite others to join them for the afternoon session. Then we continue with our parallel sessions in the afternoon for the second day. On the third day, which is one of the unique things that we are doing this year, we are having a joint celebration of our annual research meeting with the College of Health Sciences 25th anniversary, and we are having a joint activity which will be hosted at the Great Hall. And in the morning, we will have the closing session for the climax of activities for the College of Health Sciences, and then we continue with activities relating to our annual research meeting. First, with a keynote session from Professor Abdullah Jinde, who is the Noguchi Africa Prize winner for 2025, a researcher with the University of Akko in Mali. He will be here to share with us on his work in malaria genomics and how we can transmit findings from the bench to the bedside. We will end the day with another unique thing we are doing this year, which is our annual debate.
You do not want to miss the debates. It is Legon versus Colegon. And we would want to see who will win the debate. It's about digital technologies and health in the current age. And whether digital technologies would bridge the gap or extend the gap in healthcare and access between the rich and the poor, the have and the have-nots. We aim to give awards to young scientists who will be presenting their posters and their abstract, so at least there will be a prize, first, second, and third prize for the abstracts and the poster presenters. The open day, we are expecting at least 1,500 students from southern Ghana. Most of them are from within Accra, but some are from the eastern region, others from the western region. And this day affords the opportunity for young scientists, the future researchers, to get to learn about what we do, see our labs, learn about our equipment, and hopefully be inspired to become scientists in the future.
Going through the 9 departments, immunology, virology, so it's nice to find out the kind of jobs you can take on by learning, and show that your learning is not really for nothing. You can interact, ask questions, and just have a good time and meet new people. So it's been a lovely experience.
This promises to be explosive, and we are inviting all of you to come and witness this as we climax the activities for our annual research meeting this year. We thank all our sponsors for their dedication and commitment to us and for opening their doors when we start for support.
Africa stands at a crossroads. Technology is transforming healthcare like never before. But will digital innovation bring healthcare closer to everyone or leave some even further behind? As part of the 25th anniversary of the College of Health Sciences and the 2025 annual research meeting of NMIMR, we are bringing you a live thought-provoking debate where two of the brightest teams face off. Experts from Team Legon versus experts from Team Kolebu.
Expert fierce arguments, fresh perspectives, and powerful insights that must reshape how we see the future of healthcare innovation in Africa. Trust me, this is one conversation you do not want to miss.
And the motion, digital health, will widen rather than bridge Africa's healthcare equity gap. And this is happening on the 27th of November 2025 at the Great Hall, University of Ghana, 1 p.m. sharp.
Be there, be inspired, because the future of African healthcare starts with the conversation we have today.
Dear team, what do you think about our upcoming debate?
All right, so we are excited about this debate. This forms part of the 25th anniversary celebration of the College of Health Sciences, and we are gearing up for this debate.
Team Kolebu is truly excited. We know we are going to win. We are surely going to prove that digital healthcare will widen the equity gap.
And even as we win this debate, it's not just a victory for us, but a wake-up call to Africa to start building real foundations for our healthcare.
Yes, it's going to be exciting, insightful, and I'm excited because the points we are going to turn out will shape how healthcare is delivered on our continent for many years to come.
Digital health will certainly widen the healthcare equity gap in Africa, and there are lots of insights to be revealed from this debate.
The debate comes off on Thursday, the 27th of November at 2 p.m. at the Great Hall of the University of Ghana campus, Legon. See you there.
Hi everyone. As part of the University of Ghana's College of Health Sciences 25th anniversary celebrations, there's going to be a grand debate on the topic, digital health will widen rather than bridge Africa's healthcare equity gap. And we
are against the motion.
As lead, my name is Dr. Lily Pemka. I'm the Deputy Director at the West African Genetic Medicine Center. I'm a molecular geneticist.
And my name is Dr. Justice Kumi, a supporting speaker from the Noguchi Memorial Institute for Medical Research, and I'm a toxicologist.
And I am Dr. Nana Amamrikujima from the School of Pharmacy, and I'm a natural products researcher.
I am Dr. Constance Agbemolutumafu from the Noguchi Memorial Institute for Medical Research. I'm a molecular biologist, and I'm a supporting speaker.
And we are
Team Legon. This debate is happening at the Great Hall on the 27th of November 2025 at 2 p.m.
Come, let's have fun. Come and let's learn digital health from Ghana to Africa and beyond to all parts of the world. And we know that we are winning. Catch you there.
Come and be wild.
We are winning.
We are winning. We are winning.
I welcome you to the 10th annual research meeting of the Noguchi Memorial Institute for Medical Research, College of Health Sciences, University of Ghana. This year we have a lot for you, and the theme for our annual research meeting is Advancing Healthcare Through Impactful Research and Innovations. This ties in very well with what we are doing. Noguchi, we support health delivery not only in Ghana, but in the sub-region. We employ you to join us. We have innovative speakers who are going to speak about their innovative research, antimicrobial resistance. Why is that you go to hospital and they give you all the antibiotics, but you are not responding? Please come, get understanding. How do we prevent the spread of antimicrobial resistance? Please, there are so much information for you. Malaria, is it coming down? Is it going up? We are there. Come. Innovative solutions, drug discovery, diagnostics. So I'm employing you. Come join us. 25th, 26th. It is not going to be science alone. We are going to have fun. We are inviting all school children. We are going to open the doors of Noguchi. Come and look at all the machines you heard about. JHS, whether you are in primary school, secondary, tertiary, the Noguchi doors will be open to you. Come and look at innovative, the infrastructure that you've been dreaming about. Come and listen to our impactful research that is making waves across Ghana and the sub-region. For Noguchi, there's nothing but quality research.
Hello, my name is Professor Chijo D'Souza. I am from the Noguchi Memorial Institute for Medical Research. I'm the co-chair with Professor Kojosa Wakusi planning this year's annual research meeting of the Institute. This is our 10th annual research meeting, which also coincides with the 25th anniversary of the College of Health Sciences. So this research meeting is being organized together with all other constituents of the College of Health Sciences, bringing together all the scientists to showcase the work that we have been doing.
The theme for this year's annual research meeting is advancing healthcare through impactful research and innovation. And we are having this program from the 25th to the 27th of November 2025. We are having on the first day a keynote to be delivered by one of our own professors. As part of that, there is also a panel discussion where we would have some of our sponsors who would speak about the impact of private-public partnerships in promoting research and innovation. Our parallel sessions happening in the afternoon to bring the first day to an end. On the second day, we begin the day with a symposium, a special symposium by NMIMR, that is a JICA funded program that is based at Noguchi. They were having a 1-hour symposium to talk about some of the research that they have conducted over the past years. And then we would have our poster sessions beginning with a table session where selected posters will have 2 minutes to pitch their ideas and invite others to join them for the afternoon session. Then we continue with our parallel sessions in the afternoon for the second day. On the third day, which is one of the unique things that we are doing this year, we are having a joint celebration of our annual research meeting with the College of Health Sciences 25th anniversary, and we are having a joint activity which will be hosted at the Great Hall. And in the morning we will have the closing session for the climax of activities for the College of Health Sciences, and then we continue with activities relating to our annual
education and stuff, like who important to stuff, individuals can actually input in the data, and that will help in the progression between treating your cancer if you help once it detects. But the challenging thing is about the imaging, because the model has to be great, and right at the moment, since our model is quite and dicing 85% on quite complete, we then try to now push it out there. So now our work is now more on optimizing this. Then once we fully optimize the biomarkers, we can actually try to mitigate the risk for next event. And our challenging issue was on data set. I knew you were going to say data set is very quite there, because everyone iris in different countries is very different. So you have to be getting very different. Exactly. So one of the things we want to focus is going to centralize it in Africa. So we don't want to go outside or something, because if you go outside, there'll be so many. It will be very, very trouble, because one case also, one guy presented also on biomarkers on there, and he was having a lot of trouble explaining because he used a lot of data from different variations which wouldn't match your accuracy score. So that's why I thought about using it at the moment, because that score wouldn't.
Secretary, should I stay till he's done or I should move to another person too?
Let's break that out. But let me invite you to another program that we talked about. Yes. I think not for coffee. Yes, yes. Yeah.
Okay.
I discussed with things like where we can market and we have videos at the moment. Using that's why your images share. I was talking about your images. You have to put it. Yeah, but we need to use those seeds or upgrade of the model and use it to study the real thing and be able to predict accurately. Like this is a movie of yeah, well, this is a movie of secondary infection. Yeah, which movie is just a movie with or something. So I well, now you actually have to get more images that that is banned and also that are
Is it okay now?
And you have to get images that are seen by the world. Okay, you said that aside, but the issue is getting data. That's always a big question in actually trying to treat the model. Getting the virus and use data to then that's nice. So you have a new discussion. We can do this here, but we need a question. Then we can show you based on the wounds you confirm these wounds as new attention based on PCR or blood. So based on that, then you train the model to know. I'm not focusing on the video. When you get a system or then the test realize the computer. Actually, everything is on the where you the final goal of your research is done mobile lab. And actually, mobile asset back and just handle this hand and get those let's go. How we can push it. Yeah, but carrying PBS, as I mentioned, this is one of the few cancers. You have to expand. It's going to be very painful because you have to again. So the few data we have to do something. It's from Paradise. I know you know Paradise actually, and also that was Paradise, the one I love. Yes.
Hello.
That's charged. That's not. We're not actually planning.
Can you please start making our way to our various breakout sessions? We have one here in the conference room, and that is the theme for the talks here in the conference room is tackling infectious and non-communicable diseases. There's another session going on in the combined seminar rooms, and that's on strengthening health systems for resilience and sustainability. And there's a concurrent session, and that's on maternal and neonatal health. And this will be held at the Ragnick Conference Room. And for those of us who are interested in going to Ragnick, there's a bus from the conference room as well as to Ragnick. The time starting in the scenario. Some of the actions here in the main conference room. Can we have our presenters move to the various breakout sessions? If you're interested in tackling infectious and non-communicable diseases, please move to the conference room. We are about starting. There's another session going on in the combined seminary room, and that's on strengthening health systems for resilience and sustainability. And the third session on maternal and neonatal health and what makes conference centers. The bus and flowers on our conference room to shuttle people to the right next conference room. What makes it across the street. From the poster assessors, can we have all presenters and all participants please move to the various breakout rooms?
Yeah, so you're welcome. You're welcome. My sister. Name is that.
We'll start on time so we can finish early on schedule.
Clinical success. And as we all know, NMIMR is a global health challenge. There's a growing global concern over pseudomonas aeruginosa as a major cause of nosocomial infection. And this challenge is heightened or worsened by the high prevalence of multi-drug resistant pseudomonas aeruginosa strains in our hospitals. If I say our hospitals, our local hospitals, our regional hospitals, hospitals. And this complicates treatment options and worsens patient outcomes in our hospitals like I So, in view of this, we wanted to look at this visitor profile, genomic characteristics, and transmission dynamics of pseudomonas aeruginosa from clinical sources across 7 hospitals in Ghana. So, we work with Exma Hospital, Saints, and Martin de Forest, Patrick Hospital, University of Ghana Hospital, and Tamale Teaching Hospital. So basically, we've partnered with them. Routinely, they test these patient samples, blood, urine, wound swab, ear swabs, semen, and water pills. So whenever they recover pseudomonas, they cryopreserve, get isolated, and they are shipped to our lab.
For those of us interested in maternal and neonatal health, the talk should be held at the What Makes conference room, and that's ready to move right in front of the conference room to What Makes. If you are coming to What Makes, there's a shuttle ready and just about leaving.
And then we proceeded to do DNA extraction using the Cajun, following the Cajun protocol. And then we did some library preparation. We fragmented the DNA, and then we started with barcodes, and then they are loaded, they are put together first, and loaded onto the luminal mindset for sequencing. Once the sequencing is done after 78 hours, we get raw rate Pacific files. Analyze these sequences using chemomatic stream of bad rates. We also use FastQC to do some quality control or do quality check. then we use the Unicycler to assemble the context from the library preparation. Basically, they are fragmented. We have to pull them together to form the whole genome of the organism so that we can better understand the features. So after assembling using Unicycler, we proceeded to use various online platforms from the Center for Genomic Epidemiology to look for resistant genes, look for virulence genes, look for multiple sequence diet, then other mobile genetic elements. So we also perform some phylogenetic, look at the transmission dynamics of these organisms. Now for whole genome sequencing. Yes, so it was whole genome sequencing. So after analyzing the phenotypic data, the antimicrobial susceptibility test results, we realized high level of resistance to ciprofloxacin, erofinem, piperacillin, tazobactam, gentamicin, and then the rest. Now, of interest here is erofinem. Erofinem is a last line treatment drug, which is quite expensive in our hospital setting. A patient goes to hospital, is diagnosed with bacterial infection, they take samples, they do all these processes, they do AST, and you realize that the organism is resistant to almost everything. Now, they take
because you have different diets. Like you have to decide. I'm using some steam. Just and then also
My colleague is bringing something. Can I take that to you?
Are they polycombs or monocombs? Because monocombs just have one color. One color, and then polycombs have like multiple colors. Gram staining is actually come from inside, whereby it binds to the nucleus and then the cytoplasm. But gram staining, I actually want to know polycombs and then also how it's actually functions. That's it. What are you question? And then the demographics, I think you said that one actually. That one's fine.
So your first question, can you repeat your first question?
Yeah, so you said so the last or this one and then the down just yes, or you have it this one like that. It shows something because that was
Vedic media. You've heard of Noguchi, right?
Yeah, I've heard of it.
Vedic media. To allow any fan it doesn't give a particular color. It doesn't work like this. This is a homogenic media. The homogenic media has substrates in them. You're going to produce certain enzymes. So the enzymes react with these substrates to produce color. So the organism will go on this media with different colors. And that gives the presumptive idea of what you are working on. But this is a basic if it's a list, they are going to be female or white sexual. They are not going to be a particular now, there are different stages that you can do. We have huge as potassium stage or potassium these things what is using show you these cells. You know, you could eat white blood. So we have breakout sessions. We have been asked to move to the conference room. And after the breakout sessions, we can come back for the post activity. Time for so I go to some partnerships in the orange about this place. So I think it should be a bad idea. When you are also starting this. What I got will be
Okay, thank you.
It's time for presentation.
So what I'm saying is that so this reading, you understand, they are all to go right.
Let's time for presentation.
I'll show you. 1224. That is between 400 and 500. If you don't have that, and these things are not aligned, you can't tell whether they and they are.
It's time for presentation.
Okay. Thank you very much.
You're presenting someone. You're talking
Good afternoon once again. All we welcome to another session.
Do you mind if I explain on the
Why you say we should go to the listening, so maybe after.
Okay. Thank you.
Please, as you file into the room, kindly move forward and fill the spaces at the front rows. Please come forward. Please come forward. Please come forward. We ask you to come. Please come forward for us. Please come forward and fill the spaces at the front rows, please. Okay, thank you so much, and you're all warmly welcome to this afternoon's plenary session. We have two chairs for this session. The first chair is Dr. Hiroyuki Yamamoto of the AIDS Research Center of the National Institute of Infectious Diseases in Tokyo, Japan. Please, let's welcome him.
My dear colleagues, this is Hiroyuki Yamamoto from the National Institute of Infectious Diseases, Tokyo, Japan, And we have had a 10-year exchange of academic research on our department basis. And Dr. Chris, he also has been like a previous temporary colleague in conjunction with JICA. And it's really, really an honor to join you. It's my very first time in Ghana, and I really, really respect the vibes of this rising country. Yes, and I'm really looking forward to like link with you on many portals. Thank you so much.
Thank you so much, Dr. Yamamoto. So we also have Dr. Ivy Asante of the National Influenza Center at the Virology Department of the Noguchi Memorial Institute for Medical Research as a co-chair.
Hello everyone, good afternoon and welcome to the session. And we hope to have an exciting session, please. I think you all know me. I work here at Virology Department. Thank you.
Thank you, coaches. Please take the charge. Thank you.
All right. Thank you once again and welcome to this session. As the director in her speech mentioned, Noguchi's mandate is in threefold. The first one is to conduct research into infectious and non-infectious diseases. And for this session, our title is Tackling These Infectious and Non-Communicable Diseases. And we have a cocktail of beautiful topics for you to digest. So please pay attention so that we can have interesting discussions. And so to start, Doc, do you have some more remarks? Yeah. Okay. All right. So to start, there are a few things to note. First of all, we want everyone to present. So after your presentation, then we'll have a question and answer session. So for the presenters, you have 10 minutes to present. When you have 2 minutes more to go, I will wave my sheet to let you know that you have 2 minutes more to go. Please, everyone who knows me knows that for these things, I'm very good at it. So that you will stick to 10 minutes so that we are done for your presentation by 10 minutes. And then we'll have 5 to 7 minutes of discussions, please. So to not waste too much time, our first presentation is from Nathaniel Opoku. Nathaniel will present to us on Staphylococcus aureus co-colonization with other Staphylococcus species in commercially raised pigs in Accra, Ghana. Please, let's give him a round of applause. And all the best to you.
Good afternoon to you all. I want to address the chairperson and stand on all established protocols to deliver my presentation. I'm Pokubo Nathaniel, and I represent Staphylococcus aureus co-colonization with other Staphylococcus species in commercially raised pigs in Accra, Ghana. This is going to be the outline for my presentation. The increase in antimicrobial resistance of Staphylococcus species in livestock highlights the need to understand their spread and colonization in pigs. Staphylococcus species, often a Staphylococcus aureus, often colonize pigs with a methicillin-resistant Staphylococcus aureus, posing a major threat to human health. Livestock-associated Staphylococcus species is common due to their evolved antimicrobial resistant patterns. In pig farming, the use of antimicrobials as prophylaxis and for growth is increasing due to consumer demand and regulatory pressures. Our study sought to determine the prevalence of Staphylococcus species among commercially raised pigs in Accra, Ghana, also to assess the antimicrobial resistant patterns of Staphylococcus species and to determine the association between multi-drug resistance and farm practices among the pig farms. So our study employed a cross-sectional study design using Accra as its study site, sampling 274 pigs from 20 commercial pig farms, and data was collected through sample collection and sample analysis to run through our study. And the sample type we used was archive pharyngeal samples, and for our inclusion and exclusion criteria, we involved only healthy pigs in our study. So first, our archive pharyngeal samples were cultured on 5% sheep blood agar, which were further cultured on mannitol salt agar, and gram staining was performed on these isolates. To separate between our coagulase positive and coagulase negative staphylococci, we performed the coagulase testing, and for our coagulase positives, we performed suppositing sensitivity test to find the MRSA among the positive staph isolates. And for our coagulase negative staphylococci, we performed the Bayesian sensitivity test to separate our Staphylococcus epidermidis from our Staphylococcus saprophyticus. And finally, we performed antimicrobial susceptibility testing on all our isolates. So looking at the characteristics of the farms we involved in our study, we had 274 pigs involved in our study, of which the majority were males, 145, and females were 129. And for the age range, it was between 3 to 5 months. So 4 months were the highest among the pigs we employed in our study. And for the breeds involved in our study, they were all exotic breeds, and there were no local breeds involved. And all the farms confirmed using concrete pens as housing systems. Also, we took some data on some farm practices, which include antimicrobial use, and all 20 pig farms confirmed using antimicrobials. And they also confirmed the presence of other farm animals on the farm. Other than that, too, they also confirmed the visit of other animals from external sources, and also they confirmed disposing their waste on the farm as well, of which 18 out of 20 farms confirmed disposing their waste on the farm, and 2 confirmed disposing it outside the farm. So we also took some data on the type of antimicrobials used, and we can observe that the highest antimicrobials used among the farms were penicillin-based antimicrobials, which 13 out of 20 farms confirmed using, followed by sulfonamide trimethoprim, 9 farms out of 20, and tetracycline, 8 out of 20, and tyrosine tartrate, 4 out of 20, and rofloxacin, 2 out of 20, on which the least used antimicrobial is gentamicin. Only 1 farm confirmed using gentamicin in their farm. So for the distribution of our staph species, we took from the farms, we sampled 274 nasopharyngeal samples, and we were able to recover 212 isolates, of which we were only able to find 126 staphylococci species. And out of these staphylococci species, we found 6 out of 126 were Staphylococcus aureus, 5 out of 126 were Staphylococcus epidermidis, and 59 out of 126 were saprophyticus. And for the ones we couldn't characterize phenotypically, we classified them as other coagulase negative staphylococci, of which were 56 out of 126. Looking at our resistant patterns, we could see that the highest resistance was seen in ampicillin sulbactam, of which 99.2% of our isolates were resistant to, followed by closacillin, 99.2%, cefotaxime, 98.4%, and the least resistance was seen in levofloxacin, of which 1.6% of our isolates were resistant to. So for the multi-drug resistance patterns among the isolates we observed, even though we isolated a small number of Staphylococcus aureus, we found that all Staphylococcus aureus isolates were multi-drug resistant, of which the ones we couldn't speciate phenotypically, the other coagulase negative staphylococci, were 78.6% of them were multi-drug resistant, followed by Staphylococcus saprophyticus, 66.1%, and Staphylococcus epidermidis, 40%. So we also took some data on some farm practices that were going on in these farms, and for these farm practices were the use of antimicrobials, presence of other farms, the visit of other animals within the farm, and antimicrobial prescription, as well as the age of pigs. And we established some associations between these farm practices and multi-drug resistance. And we found that there was a statistical significance between multi-drug resistance and the presence of other farm animals, of which we had a p-value of 0.01. And for other animals in the farm too, there was some statistical significance, of which we found 0.04 of the p-value. So we confirmed that there was a high carriage rate of coagulase negative staphylococci, which is consistent with some research from other global sources, as confirmed by Bonvega in the year 2021 and Chiomba in the year 2025, respectively. So as Staphylococcus saprophyticus was the dominant species in our study, Bonvega, on the other hand, found Staphylococcus aureus to be the most dominant in their study. We also found a high multi-drug resistance among Staphylococcus saprophyticus, of which were 42.86%, and the other coagulase negative staphylococci, which were 48.35%. And according to Bagava and Zine in the year 2012, this is common among food animals. We also found a statistical link between multi-drug resistance and the presence of other farm animals, indicating that farms housing different types of animals create an environment where resistant bacteria can be shared among these animals. And also we found a link between multi-drug resistance and external farm visits, of which we suggest that animals from external sources could contribute to the spread of resistant bacteria in the farms. Also, we found that the frequent use of antibiotics may result in resistance in some particular drug class, as we saw that most farms used penicillin-based drugs, and for antimicrobial resistant pathogens, the highest resistance was seen in the penicillin-based drugs. So after this, we concluded that there is a high prevalence of coagulase-negative staphylococci, especially among Staphylococcus saprophyticus, and a troubling level of multi-drug resistance. Also, we found that multi-drug resistance is not only influenced by antibiotic usage, but also factors like the presence of other farm animals on the farm and the visit of external animals as well. We recommend that further studies employing molecular techniques can be done to speciate other coagulase-negative staphylococci further to understand their individual prevalence in pigs of Accra. And also, we encourage antimicrobial stewardship among pig farmers in Accra. I also want to take this time to acknowledge some people involved in this study. And first, I want to acknowledge my supervisors, Dr. Richard Mills, Dr. Matoda Imokono, Ms. Rita Ohinilabi, and the pigs farmers involved in our study, and also the entire SecBio UCC team, and the co-authors as well. Thank you.
Thank you, Nathaniel, for sticking to time. You were right on time. Please, do we have any questions for him? Okay. How many? I see 2 hands up already. So we'll take from Dr. Labi. Abana. So someone should come for the mic for them. And then there's a second hand at the back. Yes, please. Thank you so much.
Hello.
Hello.
Okay, so it's about, you gave us the average ages of the pigs you had in this study. Now, I would have been very happy if you had given us an idea of the lifespan, the average lifespan of the pigs.
Okay.
Before we put this into context.
Okay.
My next question, I'll just ask and then you can answer them. My next question is, you said you ended up, all the pigs you recruited were all exotic breeds. Did you specifically aim for that, or they just randomly occurred in the site you chose?
They just randomly occurred in the site. They just
randomly occurred. So in that case, my question to you then is that how would you say, so suppose the study, how do you think that the local species will fare in comparison to the exotic? Okay. And then my last question, you said...
Can I take the questions one more, please?
Oh, well, I want to ask and then I sit down.
Okay.
I'm sorry about that. So, yes, so you said other animals visiting the farm was a factor.
Yes, please.
I'll be very happy if you can elaborate or just expound on that. Does it mean that the pigs were not in enclosed spaces?
Yeah, they were.
Or what spaces. Animals were visiting the farms? Okay. Thank you.
Okay, thank you very much for your question. So to answer your first question, you asked about the average age of the animals. So from the animals we sampled, the ages were between 2 months to 6 months. Lifespan. Okay, we didn't actually take background data on the lifespan of the animals involved in our study.
No, you have to know the lifespan of the pig if you are going to tell us.
Okay. 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 All right.
So at what point are they killed? Like, at what point do you see
Okay, usually...
the pig is matured to be killed?
Usually, from the data we took, we could see that they were mostly killed around the age of 6 months. Okay. So to your second question, please, if you can kindly remind me. If you can kindly remind me of your second question, please.
In comparison to the exotic ones.
Okay, so what I've observed in Ghana is most of the pigs we consume are of exotic breeds, usually. So we mainly focused on those exotic breeds and not comparing them to the local breeds. So I wanted to see the pigs, wanted to see how these pigs could also be susceptible to these resistant strains, but we didn't actually take in consideration the type of exotic breeds, comparing them to the local breeds. We didn't actually take that into consideration. We're mainly focused on these exotic breeds, as we know that most Ghanaians consume these exotic breeds.
Okay, so the other animals visiting the farm?
Okay, so for the other animals visiting the farm, most farms we sampled confirmed the visit of wild birds and even ducks from external sources, not animals from their farms entirely. Even ducks and some domestic animals coming out from different environments onto their farm.
Okay.
Thank you.
Thank you. And then there was one hand at the back.
Yeah, thank you very much. I just want to find out on your sample selection criteria. You said you selected healthy commercial pigs.
Yes, please.
My question is that what do you mean by healthy? Wait. The second question is that if I had found staph aureus in their nose or in the skin, and it's considered as a normal flora, how did you select healthy pigs? What do you mean by healthy pigs? And how would that inform your decision criteria or something?
Okay.
That's my question.
So please let me come clear. So presumably healthy pigs that were not showing any sign of infection on site.
Did you test for that?
No, please.
Thank you, Nathaniel. Please, any further questions? Any further questions? All right, so I might have one question for you.
Okay.
So you said the waste was disposed on the farms.
Yes, ma'am.
How were they doing this? Did they just throw it on the farm, or they'll keep it somewhere and then?
Okay. Usually, they dig out, should I say, latrines at the back of the farm, like on a farm site, but outside of the pens. So that's what mostly they were doing.
And has it got anything to do with AMR you found? I mean, has it got any implications for it? And my other question would be, so what is the implication of your study for me who loves eating pork?
All right. Okay. First of all, to answer your question, we do know that Staphylococcus saprophyticus is a gut microbiome. They are nuzzling and rooting activity.
Papillomavirus infection, factors influencing uptake of screening by commercial sex workers in 2 municipalities of Ghana. Okay, thank you.
Hello, everyone. I stand on already existing protocol to present my research on human papillomavirus. Before I begin, I would like to share a brief experience on my field work. When I started collecting data, I realized that to truly understand the world of commercial sex workers, I had to step in their shoes. At least, yes. If I mean step in their shoes, at least in perception. There were moments where I had to blend in to listen without charging them. I entered into spaces to earn trust, spaces where researchers were hardly welcomed. It was then I realized that data is not just numbers, it's lived experience. This insight shaped the heart of my study.
So could someone come and help us? Someone from the tech, IT.
My presentation will be taken through from the background through to the summary. Cervical cancer remains one of the leading causes of cancer-related death among women. Human papillomavirus, HPV, is the main risk factor of cervical cancer. HPV is commonly found among females with multiple sex partners, particularly commercial sex workers. Screening has been found to be the primary method and cost-effective way to prevent cancer, cervical cancer. However, previous studies showed that commercial sex workers have low knowledge of HPV, and the uptake of HPV screening among this group is low. Therefore, no known studies have been conducted among commercial sex workers in the Ho and Hokwe municipalities which sought to explore the factors influencing uptake of HPV screening. It is therefore necessary to identify individual, social, and health system related barriers to the uptake of HPV screening in these municipalities. Hence, the aim of my study explored the factors influencing the uptake of HPV screening by commercial sex workers in these two municipalities of the Volta region. My specific objectives were: determine the level of uptake of HPV screening, explore the individual level factors, explore the health system related factors, and then explore social factors that influence HPV screening. My study used an explanatory exploratory study design. The study was situated in Ho and Hokwe municipalities. My study included female commercial sex workers. My study population comprises of female commercial sex workers in Ho and Hokwe municipalities. The study excluded female commercial sex workers who were not permanent residents of Ho and Hokwe but were around on temporary visit. I study used a snowballing sampling procedure, a quantitative study of 60 commercial sex workers, and the eminent issues were explored using 7 in-depth interviews. Quantitatively, a pre-tested semi-structured questionnaire was used, and qualitatively, we used an in-depth interview guide alongside handwritten notes and an audio recorder. Ethical clearance was sought from the UHAS Research and Ethics Committee. All participants provided informed consent. We ensured privacy and confidentiality by allocating code names. Quantitative data was used descriptively using Stata version 17. Codes and teams were developed thematically using Atlas TI version 9. Our study found that 96% of commercial sex workers have never had any form of HPV screening, whereas in terms of HPV uptake by municipality, 10% of commercial sex workers in Hokwe have taken some form of HPV screening, whilst not even a single commercial sex worker in Ho has ever taken some form of HPV screening. Before I move to the next step, it also emerged on field that HPV knowledge among commercial sex workers remain very low. To our qualitative findings, we had 3 teams emerging as barriers. We had 3 teams emerging. Whilst under the first team, individual factors, we had 3 sub-teams emerging as barriers. That's lack of knowledge about the screening, inability to afford screening, and fear of pain. This is what a commercial sex worker had to say. The reason why I didn't do the screening is because I don't know about it. And I don't know how important it is for me. I don't even know if it is painful or not. Commercial sex worker 4 had to say this. If I don't have money and I cannot afford the screening, I will not be able to do it. I won't kill myself. 2 sub-teams emerged as facilitators or the motivators. Education about the screening and less painful screening. Commercial sex worker 1 said, maybe more education and awareness creation on screening, maybe on radio or TV, and people going around to educate us on what HPV is. It will enable us and push us to go for the screening. The second team, social factor, we had 2 sub-teams emerging as barriers. That's peers or friends not taking the HPV screening and stigma by community members. Commercial sex worker 2 said, if you are going to check yourself for HIV or screening, they, will think because if you are having sex, that is why you are checking. They will think because you are having sex, that is why you are checking. For me, I will not do the screening in my community. Also, because our religion says we should not do commercial sex work, people will not do the screening because they will be scared of what people will say when they see them doing the screening. We had one sub-team emerging as a facilitator. That's friends getting screened. If my friends or co-workers go and do the screening and they say it is normal and safe, I will also go and do it. The third team, health system related factor, we had 2 sub-teams emerging as barriers. That's distance to health facility and non-availability of HPV screening. The screening is not that popular where I stay, but if it is available here, I will go and do it, says Commercial Sex Worker 5. We had screening services made available to them and made free, positive attitude of care workers towards commercial sex workers was also noted, and if recommended by a health worker. If the people, that's the health professionals doing the screening, are not nice, I won't go and do the screening. But if they are nice people, I will surely go and do it. Our study found that uptake of HPV among commercial sex workers were poor. What does this imply on public health? Commercial sex workers will be more prone to the acquisition and transmission of HPV. Also, our study found that about a half of commercial sex workers do not have any knowledge on HPV infection. Also, similar studies in Nigeria by Shu et al. Found that slightly a half of commercial sex workers had a good HPV knowledge. Commercial sex also, a major barrier was financial constraints, where commercial sex workers' economic and financial status serve as barrier to the uptake of HPV screening. Previous studies also found that women with weaker health purchasing power are less likely to uptake sexual and reproductive health. Therefore, based on our study, I recommend that health authorities, more specifically the Public Health Department, should organize regular educational and sensitization programs that are targeted towards this vulnerable group. Also, the Ho and Hohwe Municipal Health Directorate, specifically the Health Promotion Unit, should develop a systematic sensitization program on what is involved in the HPV screening process and the number of times to be screened to address some fears by clients who find the process a mystery. Finally, the good news is the Ghana Health Service should also regularly organize in-service training and workshop to reorient healthcare providers. In summary, knowledge and uptake of HPV screening among commercial sex workers were poor. Several barriers emerged, such as inability to afford screening, fear of pain, and lack of knowledge were some of the barriers that hindered HPV screening uptake among commercial sex workers. Therefore, innovative interventions are needed to promote HPV screening among this group. The good news is Ghana has introduced HPV vaccine for children between ages 9 to 14, which was took place in October. Most likely next year, we hope high-risk groups such as commercial sex workers who are not already infected should be targeted. My references, thank you.
Okay, thank you, Dr. Timbisa, for a really nice talk. So now we want questions or comments from the floor. Okay, so, yes, sir.
All right, thank you. My name is Kenneth Oswajiman. I want to know about your work. It's quite complex. How did you enter? Through their leader or what? And also, secondly, who did you deal with? Is it those who are stationary or those who are roaming in your study? All right, thank you.
Okay, so in research, we have something called a sampling procedure, which I mentioned in my study, the snowballing procedure or technique. Yeah, so I had to identify hotspot areas where this group of people work, especially the pubs. I had to rely on pub owners to recruit commercial sex workers, and then I depend on the first commercial sex worker to link me to her co-workers in that sense. So hotspot areas like club, so they move around. So Hohwe, for instance, they have a bar. It's stationary. So they come there to work. It's a business. They do this. So, yes.
All right. So thank you.
Okay. Now, two more questions. Yes. From the back, please.
Okay.
Yeah. We have two.
Yes, thanks for the nice presentation. You indicated targeted, education for them. From the question that came, how do you target them? Okay. Because people are, don't want to be exposed or don't want to be seen. Okay. So how do you ensure that targeted?
Okay. It was not an easy experience, I'll mention. So getting them was really tedious when I relied on the gatekeeper, which is a pub owner, to get me one person. But then getting them to come out of their shell was really a bit of an issue. So I had to go off the line of research to, please them in the way where they can come out. So pleasing them, I had to rely on buying amnesia, alcohol, things that will bring them on board, because these are the kind of things they involve in. So that's a bit of a challenge.
Okay, yeah.
Okay, so.
Okay, next question.
Okay, so my question had to do with pain came up a number of times.
Yes.
Okay, now, did they explain what kind of pain they feared? Being commercial sex workers, one would have thought that they'll be used to pain.
So it all has to do with the knowledge of what HPV screening is. It's because they had no knowledge of what HPV is, what goes into it. They tend to believe that the HPV screening will be painful, so they are scared.
Okay.
They may get hurt in the process, even though they are used to things.
Okay. May I have a related question and comment? Yeah, two brief questions. One is, sorry, maybe we missed it. How many number of workers did you outreach?
60 commercial sex workers.
Yeah, right. Okay,
yes.
Thank you. And another thing is, what to add for the details of outreaching and persuading, the increase of tests on HPV infection. So do you have any ideas? Because it's also an issue in Japan because we didn't have regular vaccination until quite recently, and how to persuade amongst the really the limited number but highlighted adverse cases. It's really kind of like a controversy right now for us. Do you have any ideas?
Ideas
of what would be a persuading detail or hook to request them, or do
yeah, I don't really get you.
I'm sorry. I'm really sorry. Yeah,
what did you tell them?
What did I tell them? Oh, okay. Yeah, sure.
Okay, so let me rephrase then. For example, we have different serotypes.
Yes.
Right, for papillomavirus. Some are rather benign, and some are quite aggressive. Yeah. So I'm wondering how this could be compressed as a detail to kind of inform them. If you just say HPV, the word alone, some people might throw it away instantly.
Yes. I had to explain to them what goes in.
Right.
Most people mistake HPV and cervical cancer for breast cancer. Yes, it came up. I asked you in my in-depth interviews, my questions. I asked you, do you know human papilloma virus? No. Do you know cervical cancer? No. Do you know breast cancer? Yes. There were instances where I asked one commercial sex worker what cervical cancer is, and she said it's the cancer of the breast.
Okay. So maybe kind of normalizing, understanding of that part might be the preceding step.
Yes. So we had to go down, break it down. It was not so complex. The questions were not complex.
Okay, forget this. Okay, it's normal, anatomical.
Yes, anatomical.
Okay, thank you very much. Okay, so we're about time. Thank you, Dr. Timvisa. Thank you.
Hello.
Yeah. One more question?
Yes. Final person, please.
Okay, so I think I'm on the floor. I am very curious. I am quite curious by your own words. I had to please them, quote and unquote.
That's why I said I had to.
Let me land, please.
Research.
And I'm curious with this because a colleague of mine was also doing some investigation in HIV, and he was a man. Apparently, by our own engagement with him at our level, informal, he told us that, look, at a point, I have to pretend as if I was one of their clients.
Yes.
Because they refused to engage with me, and I needed the data for research. And borders on ethics, if this is submitted for a paper, and I'm sure you use pleased, I'm sure you know of coercion.
Yeah.
Please, how do you deal with this?
I use please in the sense where, you had to blend in with them. So there were I remember when I started, I started dressing like a professional going, and one of their bosses told me, Madam, if you really want my girls to talk to you, please start acting like us. So I had to go to the pub one night, dressed like them. I went with condoms to display condoms. Excuse my words. We are all public health people here, so use condoms to display. I displayed condoms. Oh yes, like this is what I do. Like come for the night, we are doing this. That is what I meant by please in that sense. And I was dealing with female commercial sex workers, so please is not what you are thinking.
All right,
Okay,
thank you so much. And thank you for the discussions.
Thank you. Okay, now I'll pass over.
All right. So our next talk is from Jonathan Kluche. Jonathan is from biology department. He works with the HIV group. And his presentation today is latent TB infection modulates T-cell exhaustion in people with HIV on antiretroviral therapy. All right, all the best.
Thank you.
Good afternoon, all. So as already mentioned, I'm Jonathan Kluche. I'm a research assistant with the HIV Cure Research and Infrastructural Study team here at the Noguchi Memorial Institute for Medical Research. And standing on already established protocol, I'll be presenting one of our projects that looked at the impact, how latent TB impacts T-cell exhaustion in people living with HIV. Since its first discovery in the early 1980s, HIV continues to be a serious public health challenge, with over 40 million people living with HIV as of 2024. And it's rather unfortunate, Africa bears a proportionate burden of HIV with over 26.3 million people living with HIV. That's about 65% of the global population of people with HIV. By the end of last year, 77% of the total number of people living with HIV were receiving antiretroviral therapy. Whilst ART has proven efficacy for long-term suppression of HIV-1, it sadly still does not provide a definitive cure. So during the early stage of HIV infection, there is actually high viral load, as we can see in the graph. But once ART is initiated, there is decline in viral load when you take the person's sample and test, and it gets to a point that you test and the virus is undetected. And at this stage, the virus can also not be transmitted. But sadly, once treatment is interrupted, we observe viral rebound. What this means for people living with HIV is that they need to commit to lifelong antiretroviral therapy in order to suppress the virus and also prevent the transition into AIDS. Now, the major challenge to an HIV cure is the latent reservoir, which we refer to as the sleeper cells. So these are basically immune cells, that's the CD4 and macrophages, that harbor the latent provirus in a transcriptionally silent state. So when we look at HIV infection, HIV usually infects CD4 T cell, able to integrate its genome into the genome of the host, replicate. And as the immune system undergo its own course, the immune system is able to clear some of the infected cells. But for taking memory of infection, some of these infected CD4 T cells go into latency, keeping memory of infection. HIV is also known to directly infect resident memory CD4 T cells. And since these cells are not actively transcribing, they harbor the latent provirus in their genome. And other mechanisms such as epigenetic changes, transcriptional factors, and immune metabolism also contribute to the latent reservoir. Now, Africa holds a rich and diverse repository of microbial life, of which TB is not an exception. And with over 2.5 million cases of TB, over a third of them occur among people living with HIV. And TB is the leading cause of morbidity and mortality among people with HIV. Studies have shown that co-infections such as latent TB usually produce antigens that contribute to the persistent immune activation during HIV infection. And since latent TB reside in granulomas, residual antigen production from these granulomas may result in viral seeding of more CD4 T cells, which could potentially increase the reservoir size. So this laid our scientific premise for this study, where we sought to identify the differences in T cell responses, look at the HIV reservoir size between HIV only and HIV latent TB patients. Specifically, we determined the impact of latent tuberculosis infection on the differential secretion of immune activation and exhaustion markers, cytokine production, and the HIV reservoir size between HIV only and HIV latent TB patients. Now, so to do this work, we first of all screened a cohort of 390 individuals. So these are people living with HIV. This cohort was established back in 2019 that we've been following them up every 6 months till date. So we screened them for latent tuberculosis using the interferon gamma release assay. And we found that 37, that's 9.5% of them have latent tuberculosis infection. So in the lab, what did we do? First, we collected 100 ml of whole blood from these participants. So the positive individuals for latent TB were matched based on age and gender. So we collected 100 ml of blood, from which we isolated PBMCs, and from this PBMC, we isolated total CD4 and CD8 T cells. The T cells were stimulated for a period of 19 hours. And in step 2, we seeded the stimulated cells and stained them with antibodies specific to immune activation and exhaustion markers and acquire and analyze using flow cytometry. For step 3, we determined the cytokine profile of our study participants using luminous multiplex assay. And for the HIV reservoir size and latency reversing capacity, we use qPCR. Now, our results show high expression of both immune activation and exhaustion markers. For immune activation markers, we are looking at high expression of CD25, CD38, CD69, and HLA-DR being the main drivers of persistent immune activation in HIV latent TB patients compared to HIV monoinfection. For exhaustion, we noticed PD1, LAC3, and CD244 were the driving markers of T cell exhaustion. For cytokine production, we noticed that in latent TB co-infected patients, there was high production of interferon gamma, TNF alpha, interferon alpha, IL-17, IL-1 beta, IL-6, and IL-10. And usually, we should expect low production of these cytokines. But because of latent TB infection, these cytokines were upregulated to keep latent TB in its latent state. We also observe a reduced production of interleukin-1 beta, interleukin-6, interleukin-10, 17 in HIV latent TB patients compared to their mono-infected counterparts. And once there is reduced production of these cytokines, there is an indication that these CD8 T cells are exhausted. And in the exhausted state, the CD8 T cells, which are cytotoxic T cells, will not be able to kill infected CD4 T cells in the immune system, thereby potentially increasing the reservoir size of HIV, which is the major challenge to an HIV cure. Now, how does these findings translate to cure strategies that are being developed. So we looked at how we'll be able to reactivate the latent provirus using known epigenetic modifying compounds, as well as some novel natural products that we are screening in our lab. And as you can see, it is easier to reactivate the latent provirus in individuals with HIV monoinfection compared to those infected with latent TB. Now, how does all these findings translate into the reservoir size of the study participants? So we observe higher levels of unspliced RNA, which is an indication of active transcription due to the persistent stimulation of T cells by residual antigens from latent TB. And we also observe that in co-infected patients, there is higher reservoir size in terms of the proviral DNA copies that we are seeing. In summary, our study has shown that there is expression of immune activation and exhaustion markers with CD38 and CD69 being the main drivers of immune activation during HIV-TB co-infection. We also observe larger reservoir size in HIV latent TB co-infection compared to monoinfection. And this has contributed to the low latency reversing potential observed in the co-infected individuals. Our findings suggest that there is a need for a cure strategy that is targeted for co-infection in HIV infection. Here are a few references. I'd like to acknowledge the massive action team that made it possible for this work, and also our collaborators back here in the institute and outside the university, and also our funders. Thank you also for your time and listening.
Thank you for that very nice and insightful presentation. Please, do we have any questions for him? Yes, please.
Thank you very much for the presentation. I just want some clarification on your controls. You did mention that you were taking TB infected people who were latent, and then they also had HIV, and then they were on ART. Am I correct?
Yes, please, you are correct.
Okay, so were you looking at people that, they've been on ART for more than 1 year, and then they were at an undetectable stage? Or you were looking at people that they had a HIV, but then, they had levels of viral load that were detectable?
Thank you for that excellent question. So for this study, we did matching, so case control matching. So we took notice of years they've been on ART in doing the matching. And also, all these participants are virologically suppressed. So they have undetectable HIV mRNA using GeneSpect.
The next one is, we have different ARTs. And what a doctor may give to this particular HIV-infected person may be different from what another person may also receive. How did you rule out the fact that it could be that an ART is contributing to the exhaustion markers that you are actually seeing, or they are sort of having an effect on what you are trying to measure, the outcome you are trying to measure? Did you sort of stratify, okay, we have a group that they are taking ART-A, and then we have another group that they are taking ART-B. Do you get the point? But then it wouldn't be like you are analyzing based on people that they are taking ART-A and B, and then you're also analyzing people that they are taking ART-A and C, that kind of messed up. So that you sort of, when you get that stratification, you'll be able to tell that, you'll be able to control for the effect of ART on what you are trying to measure.
Thank you very much. So in our matching, as I mentioned, we started following up these patients since 2019. So we have clinical data on the ARTs they are on. So in our matching, we make sure the people we are picking are on the same ART. And just a point of education, ART will help suppress viral replication, not exhaustion, the expression of exhaustion or activation markers. Thank you very much.
But there is the possibility that, it's a factor. And as you are doing, you have to control for it. So since you have your test samples, you should just make sure like you have things normalized out. But then aside that, I wanted to ask, did you consider the fact of using like a healthy patient, like someone that does not have HIV at all, or someone that just have HIV but not on ART?
Thank you. So the study also recruited healthy participants,
okay,
matched based on age and gender. Thank you very much.
Okay, but then why did you do that?
So one of the clinical defining features of HIV is immune dysregulation. So to rectify that, what we are saying is as a result of latent TB or HIV, we need to bring on healthy donors, which we know their immune system is functioning properly.
Yeah, so you normalize for that one. Just like I was saying for ART, just so you normalize across so that you just know it's not ART that may be contributing to the outcome you are measuring. Thank you.
All right, thank you very much.
Thank you so much. Any further questions? Wow, okay, 3 more. So there's one at the back, one here in the middle, and then Prof. Ampofu. Yes, please. So let's start from the back. I saw him first.
Thank you for your presentation. And then the question I wanted to ask is a bit of clarification. I think you said you were measuring the interferon gamma responses to screen for those who had the TB, right? I wanted to know, interferon gamma is kind of like general for most infections, like immune responses. So was this specific for TB, or it was the general responses?
All right, thank you very much. So interferon gamma is one of the cytokines that is needed to keep TB in the latent state. So the kit we use, which is the quantiferon, uses interferon gamma, and it has a specificity of about 90%. So this interferon was specific to latent TB. Thank you.
All right, yes, the next one.
That was a great presentation. I just wanted to ask, I'm just curious if in terms with the phenotypes that you looked at, the markers, exhaustion markers, were you able to also look at how these markers are associated with HIV genotypes? I don't know if you have data on that. It would be interesting to see how those sort of genotypes correlate with the phenotype markers you are seeing in terms of the immune markers.
All right, thank you very much. So this is an ongoing project, and the question you just asked is being looked at in another study. Thank you very much.
All right, then we have Prof. Ampofu. Please come forward, bring the microphone.
Thank you for a very well-structured presentation. I was impressed with your knowledge of the subject. You didn't tell us whether, you said TB latency, but you didn't talk about, you talked about ART treatment. I want to know about TB treatment, the history of TB treatment because you talked about, you matched them in terms of age and then also HIV, TB latency. But what about TB treatment?
All right, Prof, thank you very much for that excellent question. So for TB treatment, we've not taken that into consideration, so it's something that we'll take up further and explore in the cohorts. Thank you very much.
Thank you, Prof. Jonathan, I hope you know the question I'm going to ask. Do you know? You should know, because I've asked this several times. What does this mean for HIV cure?
So we are getting close to a cure, and for what it means for an HIV cure, we need to focus on drugs that will be able to have the ability to activate the latent provirus in co-infections, not just limited to latent TB, but other co-infections such as HPV and HBV co-infection. Thank you very much.
Thank you so much. Let's give Jonathan. And then we'll move on to our next presentation.
Okay, so the next presenter will be Dr. Joycelyn Zame. Yes?
Let's calm down.
And her talk is going to be antibiotic use in respiratory syncytial virus positive children under 2 years, a cross-sectional study at a tertiary hospital in Ghana. Thank you very much. Yeah.
Thank you very much, and good afternoon to you all. I stand on all existing protocols. My name is Joyce Lindami. I'm a clinician. I'm an infectious disease specialist at the Kolebu Teaching Hospital. So this presentation will be a little different from what you've already been seeing. I make this presentation on behalf of my co-authors. So our sponsors for this project was from UMC Utrecht, and also the subsiding party was the Bill and Melinda Gates Foundation. So I'll start with a general summary of what this presentation is all about. What was the question that we sought to find an answer to? We sought to find out the frequency and clinical determinants of antibiotic use among RSV positive children under 2 years. What did we find? Majority of these children who had an RSV infection received antibiotics. And clinical determinants that were predictors was tachypnea. Tachypnea is when you find you're breathing very fast, and difficulty in breathing were predictors of antibiotic use. But why is this important to me? Why is it important to all of us here? Because using antibiotics for a viral infection promotes antimicrobial resistance. This means that we need antimicrobial stewardship, especially in pediatric care. We need preventive strategies, such as the RSV vaccination as well. So for the background, RSV is a virus, a single-stranded virus. It's a leading cause of acute respiratory infections in children of all age groups, from the young to the very old. And it causes various clinical symptoms. Some are mild, and some may be severe. Now, when it is severe, it can actually overlap with pneumonia, which is a bacterial infection. And so it is difficult to tell that is this RSV a virus or is this bacteria? In places where there is advanced technology, when a child like this appears, what you do is diagnostic, a viral panel will be done, and you can determine whether this is virus, and so I can stop my antibiotics and not promote resistance and just give supportive therapy. But in settings where this is not available, or even when available, expensive, we are not able to do that. So what was our study objective? We wanted to evaluate antibiotic use and its clinical determinants in children with RSV positive illness under 2 years, presenting at the Department of Child Health, where I work, in the Kolebu Teaching Hospital. Now, this study, which we did with antibiotics, was actually nested within a larger prospective observational study known as the RSV Goal3 Health Economic Study. That study was looking at the direct and indirect cost associated with RSV infection in the same age group. It was an international multi-center study, and the Ghanaian arm was at the Department of Child Health, pictured there. It was in children less than 2, as I already said, and the duration of study was from June to November. Why? Because this is the period where studies had shown that this RSV seasonality occurs in Ghana. Who did we include? 2 groups, inpatients and outpatients. For inpatients, we admitted those who had severe acute respiratory infection. That was in line with WHO's extended definition, and that is any child who presents with an acute respiratory infection, either cough, difficulty in breathing, within an onset of 10 days. So for those who are severe, those who are admitted are classified as severe, and outpatients are non-severe. We excluded those less than 4 days. And the reason is that these are babies who have just been born and could have had other problems, such as, we call something meconium aspiration, or even early neonatal sepsis, and it will be difficult to be able to differentiate it from an RSV infection. Also, if the child came in less than 2 years and you were hospitalized for another reason, of course we did not recruit you. Or if for any reason, we know the reason of your respiratory distress, such as you can have a cardiac disease, so you're in cardiac failure, your heart is not working well, and so we know that that is why you're having difficulty in breathing. We will not recruit you. So what were the methods for diagnosis and data collection? RSV was tested using a point of care test. This kit has been previously validated in a previous study in the same site. And also, we did reverse transcriptase PCR testing of all samples. So for every sample that would use the point of care test, we'd also send it to Noguchi right here to confirm the presence of RSV. And the test was considered positive either by PCO testing or by PCR. So we collected variables such as the age, the sex, underlying medical conditions. Something like prematurity is associated with severe RSV infection. The clinical presentation, how they came in, difficulty in breathing, fever, those who needed oxygen, oxygen at admission, etc. Then also the type of antibiotics that they were put on, and the number of antibiotics, because some people would even have more than one antibiotic. For the analysis, we made comparisons between RSV positive patients who received antibiotics and those who did not receive. We also categorized the antibiotic according to the WHO aware system, where it is categorized as in access antibiotics. Access are the antibiotics that do not promote resistance. They are more narrow spectrum, and WHO recommends that at least every country, you should have at least about 70% of all your antibiotic use should be from the access. The watch group tends to promote resistance a bit, so they are more reserved. And so it's when you have maybe an infection with a drug-resistant organism or severe infection, then you would use them. And the reserve, as the name is, antibiotics that are really reserved. Don't use it like polymyxin, colistin, when it is when you really need it. We conducted a logistic regression to predict the use of antibiotics and considered a p-value of less than 0.05 considered significant. So the total number of all participants, majority of them were RSV positive. That is 56%. And these are the patients in whom we looked at their antibiotic use. So what was interesting to note is that even though factors such as median age, sex, etc. were not significant, the clinical determinants, those who came in with tachypnea, that is breathing fast, those who needed oxygen, and those who were breathing with much difficulty, they were the ones more likely to have antibiotics used. On regression, again, the predictors were those who had difficulty in breathing and tachypnea. These continue to be significant. So it shows that if the person came in more ill, it's difficult to tell that this is bacterial or it is a virus. So we would start with antibiotics because I don't know, I don't want any child to die, etc. But what were the type of antibiotics that were used? And of much concern for me is the fact that third generation and beta-lactam inhibitors, such as amoxiclav, these are antibiotics that are more broad. They were the second most frequent antibiotic use. Happy to say that at least the most frequent used were penicillins. And so majority were coming from the access groups. However, these are children who had a virus infection. Majority, again, were found from the access group. And there were a group of children who also had co-infections and no co-infections. Among those with the no co-infections, the common diagnoses were a pneumonia, upper respiratory tract infection, or bronchiolitis, bearing in mind that all this is RSV infection. So we noted that there was majority use of antibiotics among children with viral infections. And what this means is that using these antibiotics, we are promoting resistance. There's an urgent need for stewardship, especially diagnostic stewardship. A child has come in, it's okay for us, we should be able to do viral panels. We should be able to do tests that will determine whether it is virus or bacteria. And also we should look at RSV. We recommend that in line with WHO's current position paper on immunization on RSV, I think Ghana needs to take a look at it. We recommend that pregnant women in their third trimester receive RSV vaccine to protect the baby for at least 6 months. That is the period when you have the RSV infection. Of course, there were some limitations. We did not routinely test for bacteria. We did not explore the rationale behind antibiotic prescribing. It was a single center study. We cannot extrapolate it to other centers, and we did not look at long-term outcomes. But again, we conclude that there was still a high level of antibiotic that was used in these children, promoting resistance, antimicrobial resistance. And so there's an urgent need for stewardship, antimicrobial stewardship, especially in pediatric care, and we need to look at diagnostic stewardship more closely. I acknowledge all the children and parents who agreed, and also the team. This was the study team involved, and I'm happy to take your questions and comments.
Thank you, Dr. Dami, for a really important. Okay, so we have hands from the front. Yeah, front. Yeah. Yep. Then the second class.
Thank you. Sorry. Okay, so my first question is about the assessment of infection. So you said if it was either POC positive or the confirmation test.
Or, yes. And or.
And or.
Yes.
Okay, so did you have a lot of both positive for both cases?
Majority were. I didn't show the data, but majority were confirmed positive by both. There were just a few that were just PCR positive, but we considered all of them as positive as well.
Now, looking at the model, I noticed most of the confidence intervals were really wide, super wide.
Yeah.
So just because of that, I just want to ask about the sample size estimation. How did you estimate your sample size?
Okay, so because this was a study that was nested within the larger study, their sample size was about 148, but the total number of participants I think we had was 128, and that is what we used.
The total number of participants?
The final number that we use. So the sample size had been determined by the initial study.
But by the initial one?
But yes.
But not yours?
But not yours. We use the same population. But for their sample size, a previous study where they did RSV ICU study, they used that the numbers of RSV patients to calculate their sample size, which came to almost 150, I think, 148, 150. But the final sample size, I didn't show that they are working.
Okay. So based on that, if you can just briefly show the model again, based on the logistic regression model you had over there.
They have to show it at the back.
Tech. IT. She needs to go back to her slides.
Yeah. Slides again, please.
Yeah, it's coming up.
Okay. Back the model. Yeah. Okay. So briefing difficulty. So let's say 4.2 to 263.
They were really wide. Yes.
Really wide, extremely wide.
And I think it's because of, again, the sample size was quite small, because just among those within who had the infection, there was a smaller number of all the participants. Those who were used antibiotics, it was a smaller number.
Okay.
So that is just 72.
So in the context of that, how would you interpret your findings?
I still think it's very important, the fact that we are, because like I said, clinically, the fact that we are using antibiotics among this group who we know have an RSV infection, it's important. And if this is because of the, we had a study and we had the point of care test, it's something that is not done routinely. So these are children that it happens all the time. But we were able to stop antibiotics in this group because we knew that it was an RSV infection and give supportive care. So I still think it is important.
Okay, true. So, but then we would at some point need a larger sample size.
Absolutely.
And then having the extremely wide confidence intervals makes the estimates unstable.
Sure.
So that we just have to interpret them with some amount of caution.
Absolutely.
Thank you.
Okay.
Thank you. Okay, we have hands in the middle, and then two. Okay, we have two more then.
Right. Good afternoon, everyone.
Hello.
That's a very interesting study, and without any doubt, you're also a fantastic presenter. Thank you very much. My comments or questions goes those. We are in the lab, and one of the major challenges that we have with practice of medicine in low and middle income countries is underutility of the laboratory.
Absolutely.
Yes, we are trusting science so that we can have improved diagnostics, points of care, but even the ones we have, we are so worried, and it's saddening because we have been deprived of opportunity to have reliable data because we only get tip of the icebergs of those patients' samples being sent to the lab. This study, for example, these patients were tachypnic, and there is no single doctor on earth that will not give them antibiotics. Absolutely. Because there is no indication that this cannot be bacteria. Yeah. However, we would have been able to reduce or eliminate confounding bacterial infections if just at least one sample of blood culture was taken. And this would have increased the value of this study exponentially. For example, we can't say that this result or this patient only had RSVs because we don't have bacterial blood culture that could talk about sepsis. Tachypnea, there could be sepsis, septic. That is one. And then on the other hand, we know we have challenges producing sputum because they are babies. Yeah. But we could do bronchoalveolar lavage, we could do all those other things. But at least with fever, tachypnea, indicative of sepsis, we would have thought that they would have taken blood culture along the line of management, even if there was no research. Then as a research, you would have thought that you go, maybe you did, you just didn't report it. But I would like to know why you didn't do that, if you didn't do. Then number two, mortality, because these were really bad cases, so to say. So I would have loved to know what is the rate of mortality in the group that used antibiotics and the group that didn't use antibiotics. And then maybe you would have been able to say maybe, oh, after all, the antibiotics were justified. Even though we didn't have laboratory basis, but at least the end sometimes justifies the means. We would have liked to know that. Maybe I should just leave it at this too. Thank you very much.
Thank you.
Thank you. And one more question.
Okay, so I'll just respond. Yeah. And so what you said initially about blood cultures is very true. And this was not done just because it was not part of the study. And I must say that unfortunately, routine blood cultures are not done because they are not in health insurance. And it costs almost 200 Ghana cedis to do a blood culture. And I work in a setting where my patients are a little deprived. So except currently I'm doing a study where we are just looking at blood cultures, and that's because we are funding it. But once it doesn't come from funding, it's something that doesn't happen often, which is unfortunate. I agree with you. And that's why we say that it was one of our major limitations, that it wasn't. Concerning mortality, there was one mortality, and that was a child who actually had another co-diagnosis. It was a child who had what we call a gastroschisis. It was a congenital, another kind of infection, disease. So it was a co-infection, but it was not what we thought was associated with either use of antibiotics or not. But again, it was a much smaller sample, that's why.
Okay, and the final question, yes, sir? Yeah.
All right, thank you so much for your presentation. As a next step, you mentioned diagnostic stewardship.
Yeah.
What do you actually mean? Can you throw more light on it so that we can actually translate it into maybe clinical care as well?
Absolutely. Okay, so I love that question because I've started a program on antimicrobial stewardship, and antimicrobial stewardship has to do with the practice of ensuring that antibiotics are being used at the right time for the right patients and for the right need, okay, at the right dose, all the rights, and that is what stewardship is about. When you add diagnostic stewardship, it's being able to implement your diagnostics. So as she already mentioned, you go to a patient and they've started antibiotics on this patient. You would like to know, has a blood culture been done? The importance of that blood culture is to make sure that you can isolate an organism, and if you do isolate, you can either tailor down your antibiotics, because usually you would start broad, and then so that is one aspect, being able to just do cultures, and you use the cultures to influence the use of your antibiotics. Other diagnostics, like with this study, is what we call a respiratory viral panel. I think it's even been done here in Noguchi, where you can have a host of viruses. A child will come in with difficulty in breathing. You do a host of viruses, and then you can tell that this is coming from this kind of infection. So that is also diagnostic. So the child will come in, yes, the child has difficulty in breathing, is coughing, is severely ill. It makes sense to start with your antibiotics. But after you have done your diagnostics, then you can tell that this is actually a virus. Because again, you look at the setting. We have the RSV season. You have the type of patients. You can determine that what we have right now is actually the RSV. And like I also mentioned, RSV can cause severe illness. And what they would need is oxygen support. So again, diagnostic stewardship with the fact that you collaborate with the lab. The lab will help you. If you want to do so, I'll give an example of just briefly of even my own son who had, he came home and I think there was a flu A season had occurred. And so very febrile, high temperatures, coughing, some kind of difficulty in breathing a bit, but it did not need oxygen. I was able to do the respiratory viral panel. It was flu A, and I got Tamiflu, and I used it. That is using diagnostic stewardship, and antibiotics were stopped immediately. But that test cost 850 cedis. How many people are going to be able to afford that? Okay, so that is when we need to collaborate more with our labs to make sure the prices of these things come down, and every child has access to diagnostics. Thank you. I hope that answers your question.
Okay, thank you, Jocelyn, for a wonderful talk. Again, a pass and over.
Thank you, Doc. Please, we will talk after this session. I'm wondering when these things happen, but we'll talk after the session. Thank you. So our next presenter is Diana Atandem. She is also from the biology department, and she will present to us on polymorphisms in the matrix metalloproteinase 3 gene are associated with hepatitis B virus infection in Ghanaian adults. Thank you, Dinah.
Okay, hello everyone. So I'm going to talk about findings from our study titled Polymorphisms in the Matrix Metalloproteinase 3 gene are associated with hepatitis B virus infection in Ghanaian adults. So hepatitis B is still a major public health threat, and over 200 million people live with the infection worldwide, and every year over 1 million new infections are recorded with an equally matched number of deaths. Africa bears a disproportionate brunt of the burden, with more than 60 million people living with chronic Hep B in the continent. And the situation is not different in Ghana. In Ghana, there's close to 3 million people with chronic Hep B, and only less than 1% gets diagnosed. And Dr. Yvonne's group did a hospital study that suggests that as you are moving from the south to the north, the prevalence increases. Hepatitis B virus targets the liver mainly, and once the virus gets into the liver, it attaches to the liver cells, and although it doesn't lyse the cells, it changes the cell's morphology, leading to the production of reactive oxygen species and DAMs. And these trigger a cascade of immune responses, which lead to the establishment of inflammation, and through these processes scar tissue is deposited in the liver, and that is what is usually termed cirrhosis, and then as it progresses it can move to fibrosis and then sometimes cancer. Now in a normal liver, matrix metalloproteinases will come in, degrade the scar tissue so that the liver can regenerate. But when there's a problem, this ECM breakdown can be impaired. Now, matrix metalloproteinases are a group of 23 zinc-dependent enzymes, and they have diverse functions, and the main one is to break down extracellular matrix. MMP3 in particular is constitutively expressed in the liver. It is involved in hepatic fibrogenesis, especially during chronic viral hepatitis, and it's also able to activate other matrix metalloproteinases to help with scar tissue degradation. And studies have shown that in different stages of liver injury, there are elevated levels of MMP3. However, we do not know much about the genetic impact or the genetic influence of these, the MMP3 genes on these processes. So this study sought to examine the full-length MMP3 gene in a Ghanaian cohort of HBV-infected people to find out how it influences HBV infection and whether it has any impact at all on liver health. So the main objective was first to successfully sequence the full-length gene and then to interrogate the gene for polymorphisms that could influence HBV infection. This study is part of a larger study that was studying the clinical and immunopathological consequences of Hep B and malaria co-infection. Participants were recruited from both Kolebu Teaching Hospital and the University Hospital at Legon. And we recruited cases, that is, people that are living with chronic hepatitis B but were not on treatment, meaning they had viral loads of 2,000 IU per ml or lower. And controls were healthy individuals who didn't have any evidence of liver infection. The studies were approved by the Noguchi IRB and the Ethics Committee at Kolebu. And all patients gave us informed consents before data collection. So what we did was to collect blood from each person, centrifuge the blood to obtain serum, and from the serum samples we tested for liver markers, ALT, AST, ALP, and LDH. And then from the same serum we extracted DNA, did a full-length amplification of the MMP3 gene, and then prepared libraries from the amplicons. The libraries were then sequenced on the Illumina platform. We did quality control, sequence alignments, variant calling, and annotation of the gene. So this table is showing the characteristics of the participants that were recruited. And the highlight here is that, as you can see, study cohorts, both cases and controls, were homogeneous. There was no difference in terms of age, sex, and prior vaccination. Now, after analyzing the full-length gene in the cohort, we identified 30 unique variants. These are single nucleotide polymorphisms at various regions of the gene. And all the variants were in Hardy-Weinberg equilibrium. And then we used a logistic regression to assess whether these variants were associated in any way to HBV infection, and found that 5 of the variants, which are up here, were associated with increased risk of HBV infection, and the 2 down here were associated with protection. And these are the RS numbers, which are unique names given to the genes. So each RS number represents a polymorphism at a particular location. And this figure shows the distribution of the various genotypes in the 7 variants that we found were associated with HBV. And these ones are those that are protected. These are the protective variants, and the rest were the risk variants. Subsequently, we wanted to find out whether the variants, the 7 variants, had anything to do with liver health. So we used generalized estimation equations to assess the relationship between the variants and these 4 liver function parameters, ALP, ALT, AST, and LDH, and found that this variant, 575027, was significantly associated with reduced, lower likelihood of having elevated ALP, and the same with ALT and LDH. The variants that were associated were variants that were found to increase the susceptibility to HBV infection, and at the same time, they were the likelihood of having lower levels of ALP, AST, LDH was also established using the GEE, which means that although these variants are associated with risk of HBV infection, they are also protecting the liver from damage. And we all know that hepatitis B is eliminated from the body through immune-mediated hepatocyte damage. And so this means that these variants are somewhat promoting persistent HBV infection. And we wanted to find out if inheriting these variants together compounded the effect And so we established a haplotype block using the 7 significantly associated variants and found these 2 blocks to be significant. As you can see, the LD scores here are 71 and 72% in percentages. So, and from the block 1, which is RS617819 and RS645419, had 2 of the alleles significantly associated with increased risk of HBV infection. So the GG and the GC genotypes were associated with increased risk of infection, meaning that if you inherit GG, if you inherit either the GG or the GC together, the effects of the SNPs are compounded. So the key findings are that we identified 5 risk variants and 2 protective variants, and we realized that the risk variants were associated with reduced a lower likelihood of having elevated ALP, ALT, and LDH. And we also were able to identify 2 genotypes in the haplotype block which were strongly associated with the increased odds of HBV infection. The limitations of this study were that our numbers were quite low, and so it would be good to replicate this study in a larger cohort so that we can further establish the findings, and also to do some functional studies to find out the exact roles of the variants that were identified. Here are a few references, and I want to thank the HEPMAL team, the study participants, the various institutions represented here. Thank you.
Thank you, Dinah. It was a wonderful presentation. I really enjoyed it. Any questions for her? Please, there's one hand up here already. Okay, please go ahead. Thank you.
Okay, thank you very much once again for the very beautifully rendered presentation and interesting study. My question is this. We found some protective variants, right? And some that we think are not. I don't know whether you also tried to do some investigation into other characteristics of the patient, social demographic, clinical, other details of the patient, to see whether we could actually have idea of the kind of people that may be associated with the protective, and maybe the kind of people, at least empirically, that we could suspect that they may have the other variants. Because this can also help. For example, maybe tribe, you know, and some other characteristics, social demographic, you know, clinical, other things like that. Maybe they smoke, whether they drink, those things. It can help us to have more understanding of the impact of these variants. Thank you.
Okay, thank you for the question. So, as I mentioned earlier, this formed part of a larger study, and as part of that study, an extensive demographic data was collected, and but we did not collect ethnicity. What we did collect was nationality, and majority of our cohorts were Ghanaians, but we did not collect ethnicity. However, in terms of their alcohol intake, we did collect that data, and this was data. Questions asked the patients, do you smoke, do you drink? But we did not analyze the genetic data in that context. But it's worth looking at.
Okay, thank you. There's another hand up here.
As a follow-up on what you just said about alcohol intake, did you really assay GGT? Since it's alcohol and whether to assess whether it has any effect on their liver function as well, alcohol and the GGT as well?
Yes. So we the liver function test we did was the full panel. So there was GGT. However, we had previously analyzed liver function between the cases and the controls, and GGT was not a factor. It was not significantly different between the two. That's why we didn't include it in this analysis. Had an effect on the GGT. Okay, we didn't stratify it like that, like just alcohol and GGT. No, we didn't stratify it like that. But we just didn't include it here because when we look at cases and controls, liver function panel, GGT was not something that was significantly different. It was the same in the two groups.
Okay, Dr. Labi's hand is up.
Thank you. I was wondering about the controls. How did you recruit them?
So this study was looking at, the larger study was looking at hepatitis B and malaria co-infection. So a major factor in the control recruitment was location matching. So what we did was, if we recruited an HBV positive person, we asked them to bring somebody from their household who was not positive. When that proved a challenge because of stigma and people did not want to let their family members know that they are tested positive for Hep B, we tried to find people within their location and recruited them as controls. And we made sure that they were not hepatitis B positive and they were clinically assessed to make sure they didn't have any liver condition.
So when you say location, you mean their places of residence?
Yes.
And not the hospital setting?
No, because the malaria aspects needed people that were living in the same locale because of entomological inoculation rates. Because there's a malaria aspect, you don't want your controls to say that we live in an urban area and we have fewer mosquito bites, and your cases to say we live in an area where there are a lot of mosquitoes. So the location matched had to come in there. And this study used the samples from the same study.
Thank you.
Okay, thank you. Any further questions for Dinah? Any more points of discussion? So, Dinah, all these patients were hepatitis B positive or
cases?
Cases, yes. So, maybe I was a little bit confused. They still had protective variants. They had variants that meant protection, or yeah.
So yes, what this means is that the protective variants were more represented in the controls than in the cases. So majority of the protective variants were found in the controls.
Yes, okay.
There were a few that were in the cases, but that's where the statistics come in. So majority was in the controls.
Yeah, this was my point of confusion. All right, thank you so much. If we don't have any further questions for Dinah, thank you very much for that brilliant presentation. So go to our next one.
Okay, thank you. So take over. So the final speaker of this breakout session is Dr. Desmond Opoku Tiamwa, diversity immune cell profiles of 2 Ghanaian ethnic groups associated with specific lineages of Mycobacterium tuberculosis complex. Okay, thank you, Desmond.
Good evening, ladies and gentlemen. My name is Desmond Opoku Tiamwa, and I'll be presenting on behalf of my co-artists on the topic diversity in immune cell profiles of 2 Ghanaian ethnic groups associated with specific lineages of Mycobacterium tuberculosis complex. So since its declaration as a public health emergency in the year 1993, tuberculosis continued to pose a considerable health challenge across the world, despite the many control strategies and advancements made. So, and globally, it is caused by the Mycobacterium tuberculosis complex, and due to this, we have it being grouped into. Thank you. So Mycobacterium tuberculosis is caused by is caused by the Mycobacterium tuberculosis complex, which has a population structure that includes 9 human adapted species and 2 adapted species. The 2 adapted species usually It's caused by the Mycobacterium tuberculosis sensu stricto and then Mycobacterium africanum. Phylogenetic analysis of the TB further classifies the Mycobacterium tuberculosis into lineages, which are globally distributed. And this, because of these differences in genetic diversity, so phylogenetic analysis further classify the TB into lineages, and these lineages further influences how the mycobacterium is distributed, how severe the disease will occur in an infected host, and then how well an immune response is elicited upon infection. Mycobacterium africanum, which comprises of the L5 and L6 lineages, is usually restricted in West Africa, whereby the lineages, whereby the L2 lineages is more susceptible to the peoples in China, and L1 usually affects people around the Indian Oceans, and L3 centered around Central Asia and Western Asia. And as I said earlier, lineages will actually, lineages will, the lineages,
Everything fine?
Do you want to start? Yes, try and continue. Yeah. Take your time. I'll just cancel the time and start. Take your time.
Okay. Good evening, ladies and gentlemen. My name is Desmond Opokuntiamwa, and I'll be presenting on diversity in immune cell profiles of two Ghanaian ethnic groups associated with specific lineages of Mycobacterium tuberculosis complex. So as I said earlier, after its declaration as a public health emergency, it continues to pose significant health challenge in our health systems. And globally, tuberculosis is caused by the members of the Mycobacterium tuberculosis complex, which is made up of 9 animal adapted species and 2 human adapted species. And the 2 usually that infect human are Mycobacterium tuberculosis sensu stricto and M. africanum. And a phylogenetic analysis further reclassifies the MTBC into lineages, which are geographically distributed. And these lineages will influence how the MTBC is distributed globally, how severe an infection will be upon infection, and then the type of immune response initiated. So for lineage 2, and
Let me present it for you. Okay. So, this is a phylogeny. Okay, the global phylogeny, TB, the lineages that we have for TB, they are geographically distributed. So if you look at this graph, you have the brown and the green concentrating in West Africa. You have the purple in Asia. So we have lineage 2, which is the blue lineage. Is found mostly in the Chinese. If you look at the lineage 1, which is a light purple, you find that it's around the Indian Ocean. So you look at the rim of the Indian Ocean, you find the lineage 1 over there. And the lineage 3 is also found in the central Western Asia. But when you look at what I showed initially, the brown and the green lineage, they are found in West Africa. And interestingly, we don't know what is causing the limitation of these lineages in West Africa. And West Africa has 6 out of the 9 lineages, making it the highest diversity of MTBT strain. So it puts West Africa in a unique position. And studies in Ghana has found that the Macrobacterium africanum, that is the brown and the green lineage, which are also called the lineage 5 and lineage 6, these lineages have been found to be associated with an ethnicity. And these are as a result of 2 independent studies in Ghana. So why is this happening? Why are West Africans associated with lineage 5 and lineage 4 and lineage 6? So the question is the immune system. Let's look at the host pathogen interaction. When someone gets TB, when it goes through the immune system, there are 2 possible outcomes. There is a spontaneous healing when somebody inhales the bacteria. And the other is that it can also lead to acute disease. When it leads to acute disease, sometimes too, then the third option is there's a containment of the bacteria. The bacteria can be inside the lungs, and it will be contained. The immune cells will surround it and contain it. And in this system, it's called the granuloma. So usually when somebody has HIV, and then the person has the granuloma, it's surrounded by the CD4 cells and the immune cells, and your CD4 cells go down. You remember the presentation by Jonathan. Then you get the TB. So you see the association between the TB and the HIV. So we want to look at what are the immune factors, the specific immune responses that are playing this relationship, this important role. And the host immune cells, such as the macrophages, the CD4 cells, and the CD8 cells that are contributing to the difference in the pathogenesis. And also what this calls for studies that involve geographical specific areas, because we need to situate it. What we are seeing is peculiar to West Africa. So therefore the research question was, will the proportions of the immune cells of the 2 ethnic groups differ in response to TB? So this is a section of a larger study. Then we hypothesized that based on the sympatric association, when I say sympatric association, I'm talking about the relationship of lineage 5 and lineage 6 to West African hosts. It's looking like we are coexisting with the pathogen in a very nice way. What is causing that? So the aim was to characterize the early phase. When I talk about the early phase, that is the initial exposure of the bacteria to the host, the early phase of TB infection, by looking at the immune cells. So this is what the study was all about. And what we did was to look at cured TB participants and healthy controls. I was very pleased when Jonathan said that he took 100 mils of blood. I wish I could take 100 mils of blood. we could only take 50 mils of blood because of ethical issues. And even with the 50 mils of blood, the group of people that we wanted to take blood from are people who have the TB disease, who have the infection and are in the disease state. But these people are in such a state that taking 50 mils of blood will put them in a very dangerous state. So what we did was that we went into cured TB patients. Even with that, with a large pool of people that we sampled, it's only a few that we could take the blood from, because some of them are still not in good condition. TB is such a bad disease. So we did the outreach at Kolebu Chest Clinic. We called back TB participants who have been cured, and those who volunteered we took. But before then, we checked their HB, their blood pressure, the blood glucose, check pregnancy. If you are pregnant, you are automatically out. We can't take 50 ml of blood. We checked the HIV status. It could be a confining factor, so we took out the retropositives. So we called about 200 people. About 100 and something responded. We were able to take blood from only 53. So if you be asking questions about the sample size, I've already answered that. So the cured TB cases, we had 33, and then the controls, we had 20. It was very difficult, so please forgive me. Our group have decided that with this presentation, we will classify it as, the ethnic group, we will classify it as group 1 and group 2. Because whenever we put the ethnic groups there, it masks the presentation. Everybody's attention is on the ethnic groups. So please forgive me. So what we did is that after the blood, we isolated the PBMCs, we cryopreserved them, and when we were ready, we recovered the PBMCs, did antibody staining to isolate CD14 monocytes. Then went ahead to look at to mature them to macrophages. For other parts of the study, we did macrophage infection assay, but for the purpose of this presentation, I want to end here for the presentation, because we want to look at the population of the immune cells. So this is the flow cytometry gating strategy that we use for the lymphocytes, the monocytes in the PBMCs, and the sorted monocytes, and the monocyte-derived macrophages. So this is the demography of our participants. For the controls, we were able to control them quite well. Looked at 10 and control the ages. For the cases, as you know, it was quite difficult for us. We had, for group 1, we had 18. For group 2, we had 15. We couldn't balance the age for the gender very well but it was pretty okay. So these are the distribution of the, and these were the lineages that they were infected with previously, before they were cured. So phenotypically we looked at, and quantitatively we looked at the T cells first, and we found that the group 1 had more CD4 cells compared to group 2. This we're looking at the phenotypically. Then we said that, okay, is it really translating into the count? Then we looked at the count, and again, it showed in the count. And we actually looked at the MFI, the median fluorescent intensity, and it's also confirmed for the CD4 cell count. So meaning that there's a clear distinction when it comes to control for the two ethnic groups, the donors that showed up, there was a clear difference between the CD4 cell population. But when we looked at the cured TB case, we didn't see the same pattern. What could be happening? These have been infected, their immune systems are flared up, it's all over the place, and they are trying to adjust the system. So it was expected to see that we cannot see the same pattern that we are seeing in the controls, the healthy controls that we use, because of the immune system that has responded to the infection to the different lineages. We went ahead to look at the PBMCs. We looked at the CD14 and HLA negative and DR positive ones. We checked throughout, there was no significant difference between the two ethnic groups. And for the cured, as usual, we didn't see any difference between the two ethnic groups. But when you look at the median fluorescence intensity for the PBMCs, where we look at the CD4 positive, HLA negative, DR positive, we again saw that the ethnic group 1 was showing high levels of those cells. And this goes to confirm what we've seen in our studies, that those in ethnic group 1 are mainly associated with the more virulent form of the TB pathogen. Because the less virulent, their immune system is able to beat it down. So it is only the more virulent that is able to infect the group 1. But for group 2, the less virulent one is able to get across to them. But to understand this further, we need to also look at host genetics, which one member of our study is also looking at. So in conclusion, the difference in CD4 cells, maybe the CD4 count and what the phenotypic and the quantitative may be used as markers to gain some understanding of the TB pathogenesis between the different host and the different lineages. However, we need further studies to, as I talked about, the host genetics to understand it. These findings provide inferential information on the role of the immune cells on TB disease outcome. And therefore, we need to further study the kinetics of these immune cells. We need further studies to understand them. And this will help us to characterize the early phase of TB infection very well, so that we understand how we can tackle this bacteria, this enemy, which has been with us for a long time, even in the Bible days. Thank you very much.
Okay, thank you, Stephen, for a nice relay. Now, open for questions and comments. Okay, we have hands from the front. Yeah. Okay, please, sir.
Good evening. Hello. Please, my question is with regards to the ethnic groups. So you made mention of 2 ethnic groups. So does this, in Ghana we have a lot of several ethnic groups. So are you just dealing with 2 ethnic groups that the mycobacterium is isolated to or strictly related to, or you are just taking 2 ethnic groups out of the several that you have and doing your studies with those 2 only?
Okay, thank you very much. So the 2 ethnic groups is not just out of random. These 2 ethnic groups are based on our previous studies. So one ethnic group, the ethnic group 1, we saw that they are more associated with lineage 4. Then ethnic group 2 is more associated with lineage 5. So based on those 2 independent studies, then we built our hypothesis based on the findings we had previously. It wasn't random, but based on what we've seen, the association, that is where we went ahead with. People who have been with our, okay, so you maybe through other questions then.
Okay, next question, sir. Yeah. Oh, please.
Thank you very much for a very interesting presentation. Again, being a clinician, my question has to do with these findings. Of course, you haven't told us what the ethnic groups are, but I think that for management's sake, do you think that the conclusions of your study will influence management? Because sometimes we need to go even to do routine screening. And when we have had to go into certain communities, we actually find that there are people there who have TB and they're at home. And anytime a child has TB, we always see that there's an adult somewhere who has TB. Mm-hmm. So do you think that your study will influence management?
Yes. So when we look at TB, our studies that we have reported over the years, and how we compare the ethnic groups to the various lineages, initially we thought that if you are infected with TB, you are infected with TB. Why do you want to worry yourself about the lineage that you are infected with? But when we went ahead to look at the different lineages, and they were telling us different stories about how they infect people, how they behave, and how genetically they are different, and how their disease outcome could be different, and how even lineage 6 is associated with HIV patient. And it goes to look at the fact that if someone, and these lineage 5 and lineage 6 are considered the weaker version, or the weaker, let's say the weaker members of the family. And you know, when the immune system goes down to, the weaker ones can get you, the stronger ones can get you, everybody can hit you. So with the knowledge of this, we are able to influence treatment outcome or to influence management of cases, and tell them that, hey, if someone with HIV has lineage 4, the person is in more trouble. But if the person is with lineage 6, at least we know that it's less virulent, so we can manage it in some way. Because sometimes when you are giving the TB drugs and the HIV drugs, I know the clinicians, sometimes you manage, you need to use different versions of different drugs, especially the rifampicin. You have to use rifampicin and other parts of different derivatives of the drug. So that helps with management. Maybe before I end my talk, I'll tell the ethnic groups.
Okay, I want to learn more about the sampling so that maybe possibly we can implement it some way. In normal blood banking issue, there's a cutoff of sample collection.
Mm-hmm.
But in your case, did you use any cutoff? Because the samples that you took were beyond the normal diagnostic volumes, 5 to 10 mils, they're about 50. Other person used 100. Was there any cutoff that you used? And how do you sample? Is it multi-sampling, Bakutena, or you use different method? And also, in regards to the TB, did you by any chance look at DRTB or they were all MTB?
Thank you very much. So we avoided DRTB so that it will not be a confounding factor. Sorry, I forgot to mention that. So it was something that we avoided so that we wouldn't. Concerning the sampling, what we did with the sampling was that, you see, the ideal sample size that we wanted was 100 ml. Yeah, so, but it was, the ethical boards, it was so difficult for them to grant us the 100 mils. So we wanted 60 mil. We bargained, we went to STC, we bargained, and they gave us 50 mil. So we managed with the 50 mil. The reason why we needed the huge volume was that we want the PBMCs. They form a very minute volume of the blood volume, about 9 to 11% of the total blood that you are extracting. So if you have a huge volume of blood, the PBMCs that you are getting is quite little. And these PBMCs, you need them to get monocytes. And even the monocytes are also a subset of the PBMCs, which are very small. Then the monocytes, we need to mature them or derive them to macrophages. And the more monocytes you have, the more likely you are supposed to get the macrophages, because some of the cells will die along the way. So you need large volumes of PBMCs. As you go down, everything begins to decrease and begins to decrease. Because if you start with a very small volume, by the time you get to macrophages, you have 0 cells. So that is something that we looked at.
I'm pragmatic. Okay, so now, we are a little bit running short.
Yes, so we are done. We are done. We can have further discussion.
It's not a question.
Okay, all right.
For the sake of clarity,
yes.
I didn't evaluate this presentation because the original person who was supposed to present was a lady.
Okay. Was a lady?
Amanda. That's what we have for the evaluation. And then and then you have Desmond coming in. And
all right.
So if I can explain to you what happened. So Amanda has traveled. So Amanda should have presented. Desmond should have presented tomorrow. And just before, just a few minutes during this presentation, they asked him to present.
Exactly.
That's how he was started.
Exactly.
Yeah, so he's not even on the scoring sheet. He's not even on the program. To present.
You see, so my problem is when I took a look at the presentation after you took over, you see, the only person who could have presented that was a person who actually prepared the slides. So let's take a moment and absorb Desmond. Don't feel bad about yourself.
Yeah. Okay. Thank you very much.
So he was not supposed to present, so it's not his fault. Thank you.
Okay.
Yeah. And if I may add, so the ethnic groups are the Akan ethnic group and the Ewe ethnic group.
So which one is
so
you
read our papers and find
two?
out more.
Which one is you one and which one is you two? You didn't tell us that.
Please read our papers. You find
out. Oh, please. Thank you. Thank you very much, Stephen. Thank you. And thank you, Desmond, for the attempt. Thank you.
Okay, so now we have this breakout
so
session.
Please, we'll do a short summary and then we have closed. Please, let's calm down. Let's calm down. Thank you.
Okay. Right. So we had this breakout session 1, and it was quite cross-disciplinary, I think, because we had many pathogens. We had co-infections, like a pathogen coexistence, cross-species. It's a really challenging session to comprehensively understand. But I think that's the beauty of it, and I really feel that these types of sessions, it's better to increase, I think, instead of really specifying on a given, for example, pathogen or a given slot of an immune response. And I think we shared a really, really academic experience, and I would have many additional questions to ask each of the presenters. So it was really, really a privilege to together join you on this session. Okay, thank you for the participants. Thank you.
All right. Thank you all for an exciting session. I mean, I know I can tell that we have all had an exciting time and we have really learned a lot. So thank you all for the discussions and for all the contributions. And so the program, the ARM continues tomorrow, and then Dr. Abana will take us then.
Okay, thank you so much. Chairs, we are so grateful. Thank you so much. Well, like she said, today's program has come to an end, and we continue the ARM tomorrow. We start from 8:30 for registration. Then at 9 a.m., we will start with the AMET Symposium. So please come in your numbers for tomorrow's session. As you file out, let's be like the Japanese, and then take any empty bottles that we have left on the seats. Let's try and clean up as we go out of the room. Thank you so much, and safe trip to your various houses. Thank you.